Dear colleagues and partners, on behalf of Survivors Against TB, it is my pleasure to welcome you to the India TB Summit 2021, hosted in partnership with the Indian Express. Over the last year, as India and the world have grappled with the COVID-19 pandemic, we have witnessed several challenges in our fight against TB. Services have been derailed, and TB-affected individuals and communities are now more fearful and concerned than ever before. Today, we are at a defining point in our fight against TB. We need to pause and re-examine if our current tools and approaches are sufficient to keep up the momentum in this fight. The time has come for all of us to regroup, revisit, and reimagine what we are doing and how we are doing it. Hence, the summit theme for this year is Reimagining TB Care in India. This is the first summit where leading national and global experts have come together with survivors to curate discussions and the themes of this event. Every discussion has been developed with inputs from communities and survivors, and they have played a defining role in the direction and the topics of the summit. Each panel has been independently curated by the chairs to ensure academic rigor and independence. Our goal through this summit is to create an open-ended, participative public forum to debate, discuss, learn, and generate new ideas and solutions. The summit hosts a rigorous two-day program and brings together communities, experts, clinicians, and public health workers. It also brings together policymakers, researchers, and advocates. Through these programs, we hope to spark discussion, increase participation, and improve awareness through an independent public discourse around TB. We're extremely grateful to our co-chairs who have, despite their grueling schedules, curated a robust and thought-provoking program with diverse participation and multiple perspectives. In the end, we may not always agree with each other. The fact, however, is that without debate, dissent, and discussion, no progress is possible. While we do not agree, the one thing we do agree on is that TB in India and elsewhere must end, and we are all committed to addressing it. With these words, I welcome you to the summit and look forward to your participation in it. Thank you.
Good day, everyone. I'm Sandhya Krishnan, a TB survivor and fellow with SATB. It gives me immense pleasure to be speaking at the plenary session for the India TB Summit. Talking about the proportion of the TB epidemic, here I would like to highlight whom it impacts the most. Patients, right? And how they are often the most ignored stakeholder in this fight against TB, which kills 1,200 people every day on an average, specifically in India. Patients are not subjects or statistics, but living, breathing people. It is their right and our ethical duty to explain their condition and not dismiss their concerns. Many TB drugs have severe side effects, and therefore patients should be well aware about its impact. Drugs like cycloserine, clofamizine, amikacin have side effects. The sheer number of pills a person with a resistant strain needs to consume and endure its unavoidable side effects is unimaginable. Not educating these patients about it and excluding them from making their decisions about their health can impact their quality of life and treatment outcomes. Considering the COVID-19 pandemic and how disproportionately it has impacted TB only highlights the need to rework our approach. The solution we propose as survivors at SATB is assimilating the survivor-patient perspective at every step. How do we do this? Through the theme of this conference, we reimagine TB care. Survivors and patients need to be made equal stakeholders in the policies and decisions pertaining to TB care by the government and by their health providers. Investing in high-quality diagnostics, drug development, and drug availability is a priority because millions suffer from the lack of access to these. We need to make decisions, treatment more affordable and more accessible for patients. Taking into account the COVID-19 pandemic, creating new and more flexible forms of service delivery also becomes imperative, especially remote support. Another critical aspect is creating economic support programs for TB patients whose financial insecurity is often made worse by the cost of treatment. The mental health costs of TB can be very high, and integrating mental health care in TB is essential. This can be done by creating expanded mental health services and training healthcare staff and TB helpline workers in counseling, etc. To ensure that discrimination against TB patients and survivors is tackled, and to ensure that TB care is bias and stigma-free, providing legal and punitive action against discrimination, and ensuring class, caste, and gender sensitization to healthcare providers becomes very important. As a survivor and a fellow with SATB, I can tell you that peer and mentor support groups, networks, as well as patient education groups help patients adhere to treatment. In conclusion, I will say that the patient is the most important stakeholder in this fight, and we need to fight the disease, not the person infected by it. Let us reimagine patient care by putting the person at the center of the care model and not the disease. Thank you.
Thank you, Chapal, for inviting me to speak at the India TB Summit. My topic is TB-COVID interactions when dark forces collide. By way of introduction, I need to point out that the impact of a novel viral infection, SARS-CoV-2, on an ancient bacterial disease, TB, is indeed likely to be devastating. It reminds me of what another virus, HIV, did to TB control 3 decades ago. And in a similar fashion, the effect of SARS-CoV-2, I would guess, is likely to set back global TB control by years, if not decades. These are the two dilemmas. What are the interactions, the synergies, and the impact when these two airborne diseases collide? One, tuberculosis, as old indeed as human civilization. The other, COVID-19, completely unknown till a year ago. And how do high-burden countries like India, for example, best navigate the tortuous path between controlling COVID-19, at the same time not neglecting tuberculosis? And as you can see from this cartoon, this virus has really crushed the backs of all aspects of our lives, from the economic to the social to the political, and of course the medical. And it has done so for all aspects of TB as well. So it's affected TB exposure, TB infection. The large number of patients with TB disease have been impacted, and those with post-TB fibrosis or residual disability are also greatly impacted by this virus. And look, TB has long been having the distinction of being the world's leading infectious killer. And that title was stripped away from it on April 1st, 2020, less than a year ago, when the daily deaths from COVID for the first time outnumbered the daily deaths from tuberculosis. So TB deaths, which had been static at around 4,000 a day globally every single day, on April 1st were overtaken by COVID-19. And COVID-19 has not looked back, in fact, and the number of deaths per day have continued to outstrip those from tuberculosis. And what really happens when these two large circles or wheels intersect with each other? COVID-19, 1 year into the pandemic, 85 million annually. Tuberculosis eclipsed with 10 million, which sounded vast enough in terms of numbers. And this intersection between the two is what interests me and is going to be the topic of this talk. This intersection, which is only going to expand over time as both these wheels keep turning. So how is COVID-19 impacting on TB? Well, there have been delays in the diagnosis of new TB cases and less active case finding. There have been disruptions to medicine production, to medicine transport and supply. There have been stockouts and delays in accessing vital drugs, first and second line. Less staffing for TB because there's more staffing for COVID means reduced care for our TB patients. Reduced support when they have adverse drug reactions, when they have comorbidities which need more, not less attention. There have been delays in receiving financial and nutritional support packages, which our TB patients have long been promised. There have been delays and shortfalls in BCG vaccination, so crucial for infants and newborns with tuberculosis, to prevent tuberculosis rather, and interruptions in our HIV programs as well. So what are the affinities between these two diseases? Are patients with TB truly more prone to get COVID? Do they have worse outcomes from COVID when they do get dual infection? Well, this is from the original Wuhan cohort. And they found that infection with TB was a more common comorbidity at 36% than with diabetes, with hypertension, with IHT, and with COPD. And you've long known the link between diabetes and hypertension, for example, and COVID. But now you also know that TB was a considerably higher risk factor for COVID infection. And when they did get COVID, MTB infection was resulting in more severe COVID, more rapid progression of COVID, poorer outcomes, and most worrying of all, latent TB infection may be an independent risk factor for susceptibility to SARS-CoV-2. Think of what the impact of this would be in the millions of latently infected people that this country currently harbors. And this was a meta-analysis looking at TB, and HIV, TB and HIV, and COVID-19. And again, they found that TB with or without HIV was a risk factor for COVID-19, period. And that patients with TB had more severe COVID, had higher mortalities when they did contract COVID, and the HIV infected were even more vulnerable. So TB, HIV, COVID infected seem to do worst, in fact, with even worse outcomes than TB COVID. And intriguingly, fascinatingly, these two diseases share the identical biosocial determinants. We've long known that the commonest biodeterminants of TB are poverty, overcrowding, pollution, and diabetes. Well, surprise, surprise, these are also the commonest biodeterminants of COVID. And you can see that from this cartoon here. They are shared biosocial determinants, identical to both diseases. And I'm just going to look at one, poverty, and the poverty trap, because the social and economic consequences of COVID-19 will increase the number of people living in poverty by 500 million. That's easy to understand. So many millions have lost their jobs, their livelihoods because of COVID. And they will be pushed below the poverty line. And the majority of these newly poor people will live in the developing world, Africa, Southeast Asia, India, South America. And poverty in turn will make these new poor then more vulnerable to TB. A vicious circle of poverty impacted on by COVID with an additional 104 million BPL below the poverty line. And this whole group in turn, because of poverty, more vulnerable to tuberculosis. So a complete cycle. And then there are the indirect effects, the effects of the lockdown, this harsh and very rigorous lockdown which was imposed by President Modi with no notice at all on the country and its consequences. And as this brave economist Jayati Ghosh says, the most destructive effects of COVID-19 in India have not been the result of the disease, but the nature of the government response. The most stringent lockdown in the world destroyed the economy and forced millions into poverty, hunger, but did nothing to control virus transmission. So how did the lockdown impact on TB patients? It changed their health-seeking behavior. It disrupted health services both qualitatively and quantitatively. It delayed diagnosis and notifications of TB. There was less testing, mainly because gene expert machines, which are used to diagnose TB, were now used up to diagnose COVID. There were treatment interruptions as our patients were too scared to leave their houses and lacked transport even if they were brave enough to. Medical supplies, drug stockouts, all resulted in interrupted treatment, all of which could have amplified resistance. Increased transmission at home as patients were cooped up in home surroundings. The only good things, if any, from the lockdown were that mask wearing increased, which could only have helped tuberculosis as well. And yes, perhaps there was therefore reduced community transmission of tuberculosis, but not enough to counterbalance all the negatives on this part of the slide. BCG vaccinations dropped precipitously. In April 2020, 1 million fewer children were vaccinated than that same month 1 year ago. Isn't that startling? TB notifications dropped sharply in both the public and the private sector. And there were a number of causes for this, both patient and program related. Indeed, TB notification rates dropped about 30% every month in the lockdown. And what does that translate to? 30% reduction in notification equals 3 million more people dying from tuberculosis. Treatment completion rates fell as patients could not keep their visits to the clinic. And as the global TB report from WHO pointed out, the COVID-19 pandemic is likely to leave a profound and long-lasting impact on TB diagnosis and control, leading to an additional 6.3 million cases of TB globally and an additional 1.4 million TB deaths. The brunt of this is going to be felt in our country. With colleagues from across the world, we put together this article in Emerging Infectious Diseases, and we looked at the direct impact in our hospital. At my hospital, a very busy tertiary TB care center, OPD visits fell by 2/3 during the lockdown, and inpatients fell by 2/3 during the lockdown for our TB patients. So clearly they were hiding somewhere and paying the price of this. And the aftershock will be felt over time. These are very clever projections by my friend and colleague Nem from the Imperial Hospital in the UK. And he showed and projected that each month of lockdown in this country would result in an additional 40,000 TB cases annually over the next 5 years, and a total of 151,000 excess TB deaths in this country. Of course, each crisis is an opportunity in disguise, and we used telemedicine at this time. We had no other choice, really, nor did our patients, to reach out to our most difficult cohort of patients, the XDR-TB patients on bedaquiline, because we did not feel it appropriate to abandon them completely. And we did manage this 30 XDR-TB patient cohort on bedaquiline, our most sick patients really, remotely through the lockdown with the help of one of my registrars, Dr. Sharma. We looked at their complaints, their symptoms, drug reactions, adherence. We gave them their prescriptions online, monitored their bedaquiline with ECG monitoring. And surprise enough, after remote management through the lockdown, when we polled these patients, a good 70% said they preferred the convenience of telemedicine, even to direct contact. They did not have to traverse Bombay's horrendous traffic to come to us. So these are my concluding slides. What if we tackle TB like COVID? What if we combined the considerable overlap between these two diseases, merging their detection, their contact tracing, and their infection control, destigmatizing the use of masks, bi-directional screening and active case finding, leverage the lakhs of community workers newly deployed to search for COVID to now complement active TB case finding efforts, integrated the use of the testing platform common to both diseases, the Gene Expert, sped up new drugs, sped up vaccine trials for TB, as we did for COVID. We've got 12 currently available vaccines for COVID. We've got about 60 in phase 3 trials. Yet for tuberculosis, all we've had is an ancient, ineffective vaccine, the BCG. And this is my concluding slide from the director of Stop TB, who says and reminds us, lest we forget, COVID-19 is a wake-up call to a health system that was already underfunded, overburdened, poorly staffed, wasteful, and provided care of questionable quality. Without a robust and responsive health system, we can neither hope to eliminate TB nor weather the COVID-19 storm. Thank you.
Greetings from the World Health Organization. I'm Dr. Soumya Swaminathan, the Chief Scientist, and I'm delighted to share some thoughts with you all today. Many thanks to Survivors Against TB for having invited me to speak to you all at this very important seminar that's really addressing the intersection of science and the challenge of TB. I don't need to tell this audience about the burden of TB globally. The WHO estimates that there are at least 10 million new cases every year and about 1.5 million deaths. We know that in India, we had 2.3 million notifications. Last year was less, and over 1,200 people continue to die every year due to TB. And this has been going on for many, many years, even though there has been a decline in incidence and in deaths due to TB in the last 10 to 15 years. It certainly hasn't been fast enough. And, we're still losing a lot of lives. The other thing, of course, is that TB affects those who have other vulnerabilities and other risk factors for ill health, particularly in India. Malnutrition is a huge underlying risk factor for TB. Of course, other immunosuppressive conditions, HIV, infection, really worrying is that the impact of COVID on livelihoods and the economy of individuals and families and countries means that it is quite likely that income will be reduced, particularly for those who are already at the bottom end and extremely vulnerable to these kind of shocks. And when income goes down, nutritional status will suffer, and unfortunately, TB incidence could go up. And some of the personal behavioral actions that we have been taking during COVID, like wearing of masks, maintaining distancing, making sure that we cough into our, all of this could actually help to control transmission of TB as well. But that's a more longer term impact. And therefore, if we have to continue to meet the SDG goals, as well as the accelerated goals that India has of TB elimination by 2025, then we really need to focus on what we can do better and what we can do better now. And this, I would like to touch on at least 3 elements. One is doing better with what we have now. The second is looking at science and what it can deliver. And the third is looking to communities and looking at how do we improve the risk factors, how do we address the determinants of TB at the level of the community, and how can we work with communities and engage communities to make sure that the response is equitable, it's fair, it's accessible, and that it also takes into consideration the needs of particularly vulnerable groups like the LGBTQ community and women and children. What's been remarkable in the past year, especially sitting at the WHO and having a global perspective, the one bright thing that's come out of all of this, the uplifting element, has been the contributions of science. And it's become so clear to everyone that the solution for this pandemic can only come out of science, whether it's the development of new diagnostics or drugs or vaccines. And the incredible achievements we've seen, particularly in the field of vaccines, where we have not 1 or 2, but at least 10 vaccines that have completed phase 3 clinical trials, that have been registered for use in countries around the world and that are now being used in millions of people. In fact, as of yesterday, over 250 million people worldwide had received a COVID-19 vaccine, and India can take a lot of credit for not only manufacturing these vaccines, but also a number of innovative products that are coming out of the Indian developers, and the fact that India has now launched what will surely be the largest COVID vaccination program in the world. So, how did this happen? It happened because there was a goal. It built on pre-existing investments in R&D. So there were already these platform technologies like the viral vector, adenoviral vectors, and the mRNA platforms that people had been trying to develop vaccines for other pathogens. They were able to quickly repurpose, and within a few weeks of the genetic sequence of the virus being known, they were able to actually develop a candidate vaccine and start testing it. And then, of course, it also went through very accelerated timelines. Things were done in parallel instead of sequentially. Big investments were made by governments and companies into manufacturing at risk, which means that you start manufacturing even before you know whether the vaccine is successful. And now, of course, we know that we are going to need billions of doses of these vaccines in order to achieve population immunity across the world. But I think the learning from this is that if you have a goal, you have a focus, you have the public-private collaboration, you have the resources and the funding, and the regulatory system, the academics, the developers, the government agencies, all working together for the same goal, there is no reason why we cannot do the same for TB diagnostics or for TB vaccines. And I think there's an opportunity now using some of these platforms, particularly the mRNA platform, where you can insert the genes of interest. We know that TB is much more complex disease and that it's been very difficult to find an effective vaccine because of the complex immunology involved. But it should be still possible to identify the key antigens which might provide protective immunity, quickly develop a vaccine, take it through early phases of clinical trials, and at least get information on whether it is likely to be protective or not, and then go into the larger phase 3 trials, which again for TB are complex because we're looking for disease, and disease as an endpoint is often challenging because it takes time when we follow up that cohort. It is possible. Similarly, in diagnostics, we've seen that so many rapid diagnostic tests, so many molecular diagnostic tests were developed over the last 1 year, and today we're in a position to have a self-testing program for COVID-19. There is no reason why those technologies, including many developed in India, cannot now be reprogrammed for TB. Again, it's complex. We know that the detection of TB in non-respiratory specimens is difficult. There isn't a lot of circulating antigen, but still, I think it's possible to at least try to use some of these new technologies and make it, test it at scale for TB. And India has demonstrated over the last year that its private sector, working along with government and the public sector, is very, very capable of rising to the challenge and addressing whether it's been shortages of PPE or whether it's been in some of these innovative products. And the last thing I would say is the use of digital tools, which have made contact tracing and tracking and symptom tracking and providing information to people, and now currently tracking vaccination. All of this has been possible using digital tools, and therefore that can also be now tried for TB. In all of this, the role of communities of survivors is extremely important. You are the champions. You are the ones who understood what the disease is, having gone through it, and are in a position to help others and also to bring your viewpoint. It's really important to have that new tools are being discussed or are going to be tested. And finally, as I said, we need to keep in mind that whatever we are doing needs to benefit those who are really the furthest away, who are the least accessible, who are the most vulnerable for one reason or the other, whether it's because of stigma or particular group that they belong to, LGBTQ, or whether it's because of other social or economic constraints. And so we need to ensure whatever we do that the equitable access is there right from the beginning as a goal, That's what we have at the global level, equitable access for all COVID tools. And that's what should happen within countries as well, to ensure that all segments of the population benefit from the investments that are being made. I hope that you have very useful discussions, and I would be delighted to keep in touch and to continue to engage on how do we link science and what we've learned the COVID to make similar gains in TB. Thank you.
Hello, I'm Dr. Barnali Datta, Director of Respiratory Medicine in Medanta, the Medicity, and Project Lead of Mission TB Free Haryana. I'm privileged to be chairing a very important track in the India TB Summit, which is called the TB and COVID-19 track. Now, we are all still recovering from the impact of COVID in the last year, and it has affected us all in some way or the other, personally, professionally, etc. Now, as we recover from the pandemic, of course, we have to be cognizant of the many illnesses which just went underground. The burden of the pandemic is so immense that all health services ground to a halt as we try to deal with the pandemic. Before COVID-19, we saw just large numbers of TB patients, both as a clinician in OPD as well as in our outreach program called TB Free Haryana. We battled COVID as well as a pulmonologist. I was in the thick of it. And of course, now that things have abated a bit, we are trying to resurrect the TB work again. In today's track, I have very distinguished guests who are speaking about their experiences in their particular field. The first is Dr. K.S. Sachdeva. Dr. Sachdeva is a public health physician who is presently the Deputy Director General at Central TB Division, Ministry of Health. He has also worked in the National AIDS Control Organization, overseeing HIV counseling and testing services. He also played a significant role in TB and HIV collaborative activities, research, and global fund activities implementation. He has served as the Chief District Medical Officer, South Zone, and a Nodal Officer for the National Rural Health Mission, as well as Chief Medical Officer for the Essential Drug Program within the Directorate of Health Services. Dr. Sachdeva will be speaking about the impact of the pandemic on TB and the way forward for us. He will be coming to us from a government perspective. The second speaker that we have lined up is Dr. Jamie Tonsing. Dr. Jamie Tonsing is a medical doctor with 20 years of clinical and public health experience in several developing countries. She has managed large and complex multi-partnership projects on TB and other public health programs and has provided technical assistance to national TB programs and other organizations. Dr. Tonsing is a senior disease advisor for TB at the Global Fund in Geneva. Prior to this, she served as the Deputy Scientific Director and Regional Director for the Union in Delhi, India. She was the Country Director for FH1360 in Cambodia and for WHO in India, Philippines, and Cambodia. Dr. Jamie Tonsing will be speaking about the Global Fund's information note, what India and other countries can do to mitigate the effect of COVID-19 on TB. Our next speaker is Dr. Naresh Trehan. Dr. Naresh Trehan is a legendary cardiothoracic surgeon who does not need much of an introduction. He serves as the Chairman and Managing Director of Medanta, the Medicity, and he's also the Chief Cardiac Surgeon in the same hospital. He has served as personal surgeon to the President of India since 1991, has received numerous awards, including the Padma Shri, the Padma Bhushan, Lal Bahadur Shastri National Award, and Dr. B.C. Loy Award. Dr. Trehan, who is head of a leading corporate hospital in Delhi NCR, will talk about how the private sector has dealt with the impact of COVID-19 on TB services. Our final speaker is Dr. Diptendu Bhattacharya. He is a teacher by profession and a writer by passion. In the year 2015, he started his PhD at IIT KGP when his infection came to light. It took a turn for the worse and he underwent treatment for 2 years. He survived drug-resistant TB and recently fought the battle against COVID-19 as well. He teaches chemistry and writes for a vernacular magazine which produces content for school students. He has also written on the mental health issues faced by TB patients and interviewed for the BMJ. He is working with Survivors Against TB since 2019 and recently has been inducted to the Global TB CAB as a survivor and a representative of India. Mr. Bhattacharya will speak to us about the Survivors Against TB findings on the impact of COVID-19 pandemic on TB patients and services. With this exciting topics to unfold, let's go ahead with the session. Thank you.
Morning, all the delegates and the other panelists present in the India TB Summit. At the outset, let me thank the organizers for giving me an opportunity to present my views on this summit. I'm former Deputy Director General Tuberculosis from Ministry of Health and Family Welfare. I'll be speaking on the impact of COVID-19 on TB services and what is the way forward. Next slide, please. Next slide, please. So just to give you a background, till now about 169,000 active cases have been reported of COVID-19, of which 10 lakh cases have recovered and there have been about 1.5 lakh deaths till the 1st of March 2021. The commonality between TB and COVID is that both have similar symptoms of cough, fever, difficulty in breathing. Although the major difference between the two is TB is a chronic disease, it means it has a long incubation period between exposure and symptom, whereas the COVID has a short duration between exposure and the first symptom. Both of them primarily attack lungs, so both have the potential to attack any other part of the body. Both are spread mainly by close contact as well as airborne transmission. Co-infection of TB and COVID-19 has the potential to cause severe symptoms and poorer outcomes. However, there are also, we have seen some opportunity having had COVID, that the multi-platform diagnostic technologies available under the program could be used for COVID, and we did use those technologies for COVID. Infection and prevention control measures for TB, we did use them for COVID, and we have also strengthened our protocols for management of respiratory disease. Next, please. So what did COVID do to health services? Initially, a huge setback to the entire health services, not only TB, but all forms of health services. And that was intended also at that point of time. That is why lockdown was announced. So closure of health facilities, including private setups, the movement of people was affected due to lockdown. Human resources and infrastructure was diverted for COVID response. That was also an intention. In fact, TB program offered its services for the COVID response. We did see heightened stigma towards people showing COVID and TB symptoms. And we saw a record dip in TB notification in the month of April 2020. Overall, in 2019, we saw 25% or a fourth of decrease in TB notification. Next, please. Then we quickly mounted a rapid response plan to come back to normalcy and mitigate the effect of COVID-19. So on case finding, we introduce a concept of comprehensive lung health. We also replace sphere microscopy with more sensitive and specific rapid molecular tests. We did a special screening in urban slums and for migrants. We started triaging in the outpatient departments and isolation facilities, and started engaging private sector more vigorously and enthusiastically. With respect to patient support services, we offered them a single window of service delivery. The cash benefits were transferred directly to their bank accounts. We engaged with the community to reduce stigma and improve their health-seeking behavior, and home sample collection and delivery of drugs. Within the health system, a lot of health system strengthening measures were taken by the ministry, so a lot of administrative support. We also started now what is known as a subnational disease certification, monitoring on a real-time basis through our NextShare app, and address stigma due to COVID, and a lot of information and education campaigns were used. We also advised how to use personal protective equipment in a more rational manner. Next, please. We also took out guidance that all TB patients be screened for COVID, all influenza-like illness and severe acute respiratory illness also be screened for TB. In 2020, we could actually screen a fourth of TB patients for COVID-19. The co-infection rate, fortunately, are low in TB and COVID. They are about 0.9%. So quite manageable, and we didn't see much impact on the TB patients per se. Impact of COVID on the TB patients per se. Next, please. A few of the strategies which we use for revival of NTP services, show the next slide, please, were effective sample collection and transportation at the doorstep. Special strategies for specific population, which is urban slums. We used mobile vans, doorstep screening, migrant mapping, and camp-based approach. We also decentralized our gene expert and TrueNet for rapid molecular diagnostics. We did intensive case finding in health facilities, screened for TB in priority OPDs, which is chest, dialysis setups, HIV care settings, pediatrics, non-communicable diseases, and cancer setups. We also launched an active case finding campaign throughout the country, and also put more stress on contact screening should you have an index case. We also leveraged community-based assessment checklist of the health and wellness centers to find more and more TB cases. When they screen people for non-communicable diseases, they are also screened for TB. Next, please. The other strategies are what are already there in the program, which is schedule action notification, mandatory notification of TB, directive through local administration, personalized outreach through joint efforts of elimination of tuberculosis. We also introduced e-pharmacy, doorstep sample collection, and contact through our call center called Nexus Center. Next, please. The opportunities that emerged in this dual pandemic was, for TB program was wearing of mask and social distancing measures is expected to help in reducing TB transmission as well. We hypothesize about cutting TB transmission to the extent of about 20%. Hand washing and other self-care measures do help in reducing many other diseases. Social distancing was observed even in local public transports, and that will also help in controlling the spread of all airborne infection, airborne transmissible infections, including TB. Next, please. We did look at transmission dynamics and advise the public accordingly. Next, please. And we also reimagined how service delivery could be adopted. So we adopted a hub and spoke model for teleconsultation. We uses integrated government online training platform for training, and now the government is establishing dedicated infectious diseases hospitals with isolation wards in each district, which will go a long way in reducing the transmission of airborne transmissible diseases. Next, please. Another is expand the lab capacity to diagnose diseases. So during COVID times, we could add additional 2,500 multi-platform technologies which can detect both TB and COVID. This has helped us to now say that we can now do away with sphere microscopy and move directly to rapid molecular diagnostics. A lot of support to COVID-19 and TB research by many Indian institutions, including Indian Council of Medical Research and Ministry of Health and Family Welfare. Next, please. I've already alluded what we did in health system strengthening was division of ventilators throughout the country, N95 masks, division of rapid RT-PCR kits. The TrueNAT and CVNATs have been expanded exponentially in our country, and they are now being truly used as multi-platform technologies. So facilities which were available under the TB program came in very handy to mount a rapid response for COVID-19. In fact, now 50% of the laboratory capacity of COVID-19 is met through the TB program. Next, please. Having said that, we are not losing our focus on TB. So as our Honorable Health Minister stated, that elimination of TB remains a common priority despite the pandemic. And now we are again imagining that 2021 will be a year where we will build a lot of campaign called Jan Andolan around TB, at par with what we observed for COVID. Government of India did support COVID response with an additional 15,000 crore package, which was also largely handled by officers and consulted by the TB division. Next, please. So thank you for your attention. I will remain available for your comments and questions and suggestions. Thank you. And thanks to the organizers.
Greetings. My name is Jamie Tansing. I'm a senior disease advisor at the Global Fund based in Geneva. Prior to this, I was working for the Union Southeast Asia office in New Delhi for nearly 6 years. Today, I'll be talking about TB and COVID, focusing on what countries can do to mitigate the impact of COVID on TB services. This is the outline of my presentation to really talk about the progress we made in global TB response, what happened when COVID-19 impacted on TB services, what Global Fund response has been like, how can TB programs respond further, and lastly, to reflect a little bit on India's TB program. So this slide refers to the meeting in 2018 where countries committed at the UN high-level meeting on TB to initiate more than 40 million TB patients on treatment by 2020. We did well in the first year in 2018, meeting 100% of the goal to put 7 million on treatment. 2019, we weren't able to meet the same achievement as the previous year, already a slip there, but we already know by 2020, because COVID-19 happened then, that many countries have seen a steep decline in case notification. WHO Global TB report already documented that in the first 6 months of 2020, there was a decline of 25 to 30% in TB notification in 2020 compared to the same period the previous year. Global Fund 2 has been monitoring the impact on grant results in 38 countries comprising of 128 supported Global Fund grants. I think the results are very similar. There's been significant reduction for TB case notification up to 27%, and for MDR TB 39% reduction in 2020 compared first quarter of 2020 compared to the same period 1 year back. Based on the current results, we know now that 2021 targets that has been set in the grants, Global Fund grants, will not be met. And so we are encouraging all countries to come up with catch-up plans to robustly implement the national TB programs and also work with partners to meet the targets for the 6 months of 2021. This is getting into the country detail really to show you that which are the countries that seem to be most impacted. And as you can see from here on the right side of the screen, we see that mostly the high burden countries in Asia are disproportionately affected. Example being Indonesia, where it's a 50% decline, India 26%. In terms of Global Fund response to COVID-19, I think Global Fund realized early that it needed to act quickly on COVID-19 if it were to safeguard the investment that is made over the past decades on TB, HIV, and malaria. So it made available up to $1 billion and allowed for operational flexibility to have, with the existing grants, to help countries fight COVID-19. To date, US $980 million has been disbursed to 106 countries and 15 multi-country programs to respond to COVID-19. Coming on to how TB programs respond and adapt to COVID-19 pandemic. So Global Fund last year worked with its partners to develop an information note called Catch-up Plans to mitigate the impact of COVID-19 on TB services. As you can see on the right side of the screen, they're available on the Global Fund website. And what we are really encouraging countries to do is implement interventions and activities that will help countries to meet these goals and objectives, to restore and accelerate the diagnosis, treatment, and prevention of TB. In terms of specific objectives, these are to reverse the losses in diagnosis, treatment, and prevention of TB to pre-COVID-19 levels during 2021. So secondly, not just the losses, but to accelerate the TB diagnosis, treatment, and prevention services to get back on track to attain the UNHLMA targets by 2022. And as we all know by now, it's also very important that we adapt TB care models to the new COVID-19 context and requirements. Lastly, to reflect a little bit on India's TB program. So India acted early, and I think that helped in its recovery that we saw later towards the end of the year. By December 2020, the case notification gap had decreased to just 12% lower in December 2020 than the previous year. And I think this is because India acted early. They announced a high-level rapid response plans and acted quickly to do what needed to be done at that time. Some of these initiatives were leveraging on COVID-19 response that was done through bi-directional screening for TB and COVID-19, contact tracing, hugely expanding molecular testing, home-based care through sample collection and drug delivery at home. Also, a lot of effort made towards active case finding to accelerate case finding and notifications. Treatment adherence through use of multi-month dispensing of drugs, digital adherence technology, family and neighborhood DOT. Nikshay was a real asset for India. Not only did it sound the alarm on the impact of COVID on TB services, but it continues to help the program to monitor what's happening and to take timely actions to mitigate the adverse consequences. Political commitment and leadership. There's been renewed commitment and response to NTB by 2025, 5 years ahead of when the world will reach that target. I think if there is one lesson the world can learn is that it's possible to recover quickly if you have political commitment and you make sure the resources required for reversing the losses and accelerating the response are fully funded. And to end, the key to what we see as possible areas where India could make further progress. This is really maintaining, expanding private sector engagement. As we know, private sector was equally impacted by COVID. And to mobilize civil society organizations and community response to really partner and complement the work of the National TB program in India. So with that, I thank you very much, and I
Good afternoon to all the participants of this India TB Summit and the organization. So today I want to communicate with you the consequences and ill effects of the pandemic, this terrible pandemic, which we have suffered for a year. And what has it done to our efforts to combat TB? And TB, how we were doing so well in 29. I want to show you the contrast of how well we were doing in 2019 and to the beginning of 2020. And then the pandemic hit. And then now that we are coming out of it, what effect it's had on us. So the question we have been asking ourselves is that we know that there has been an impact on our efforts on TB patients and the services that we were providing to them. How much the impact has been, we will be represented in this graph, where it is very clear that at the beginning of lockdown, if we had notifications of 50,000, it dropped drastically to 30,000, 15,000, and this impact has lasted till about the beginning of this year. And when we see now that these people have been actually ignored or suffered that is the TB patients, because of the overlapping effects of pandemic and the distraction there was in our trying to survive the pandemic, that we need a lot of make-up time now. So fortunately, as we noticed, that there has been, by sustained effort, some recovery. And that recovery has led us to about 50% of where we were. Now what we are doing basically, and this is to study, like we are participating with the government of Haryana as part of our TB-free Haryana program, where we are actually supplementing the efforts of the Haryana government in battling TB. So as you will see on this slide, that there are definite drops like the rest of the country in our notification, in our experience with Medanta as compared to our experience in 2019 and 2020. So that's why I think that we now have only 4 years left for our stated goal of making India TB free by 2025. Now that means that 1 year has been stolen from this whole effort, and we need to move forward in a more cohesive and concentrated manner with great cooperation with each other. When I say cooperation, I'm talking about the industry, PSUs, the government agencies and voluntary agencies like Medanta, that we should be actually aligning our efforts, doubling our efforts actually, to make it possible that the time lost is made up and the target that we have for 2025 is met. And in a way, I believe if we can do it together, that we will, in a way, I believe that if we do it all together, Haryana can be the first state in India to be TB free. That means that all of us, under the leadership of the TB program of the government of Haryana, along with all the efforts that we are making, we just need to coalesce together this effort and move forward in tandem so that we can lick this terrible scourge that has been around the world, and especially in our effort to get rid of it from India. Thank you very much, and I would appreciate if the whole proceedings of this conference lead to a comprehensive program where we can all identify our roles and happen to be there in 2025 when we unveil that India is TB free. With that, good luck to all of you. Have a good discussion all day. Best to all of you. Thank you.
Good morning, everyone. I am Diptendu Bhattacharya, a drug resistance TB survivor and a patient advocate for survivors against TB. Today, I am presenting the topic TB and COVID-19, SATB's finding on the impact of COVID-19 pandemic on TB at India TB summits. Recently, I have been contracted with the COVID-19 and some 4 or 5 months back. And I had to deal with another deadly disease after I have gone through tuberculosis. And I found something astonishing, which is not expected at all. The TB and COVID are similar kind of disease, yet one of them are getting much more hype and much more attention. But the older one, which is lingering with us for last 10,000 years and killing 1,200 Indians every day, are not getting that much of attention. Moreover, this kind of disease created a global pandemic also worsened the situation for the TB patients. So SATB has set up a virtual help desk in March 2020 to assist those patients who are suffering from TB and having trouble during this session. So based on the queries made by those patients, we have conducted an observational study to assess the impact of COVID-19 on TB services. Here I am presenting our findings in front of you. So our main objective was to identify the kind of challenges and services that the patient and the communities have gone through and how they can be addressed. And here also we are presenting with some recommendation. So we have done a prospective observational study of queries. These queries are classified into a general and some few other specific categories. And we have then comprehensively studied them, analyzed them, and presenting the findings from that observation. So we can classify those queries in 4 categories, in more or less speaking. The biggest one of that category was about treatment. The treatments suffered a lot due to the lockdown. The stocks were empty at the beginning of the COVID-19, and where the stocks were available, the patient didn't have any means to go and procure those medicine for themselves, especially those injectables. That resulted into some scare and fear among the patients. Those people are also troubled by the fact that both are similar kind of disease which can interact with each other, and what will be the impact towards their life. Moreover, a few patients missed the opportunity to get diagnosed early and got their tuberculosis portion, which can be managed in earlier stages because of that lockdown. Moreover, last but not the least, the lockdown has taken our economy into the downslide, which results into a more complicated situation that we find people are lying without any proper nutritional support, which is essential for tuberculosis. So here, our overall analysis about the situation was that there was a gap between diagnosis and the treatment, and also that results in the mental health challenges and other challenges which cannot be supported because of lack of patient support. And sometimes it is happening that patient is educated enough to support themselves in this kind of situation, but teacher education and literacy was virtually absent. Patients are facing difficulties, and even in October also, when we have concluded our study, even then, even though the lockdown was virtually over by then, along with that, we have seen that there are stigma and gender discrimination and mental health issue is rising around COVID patients. So this is not rocket science to understand that the same thing are faced by TB patients for years. So these are the area which need to be addressed from the policy level and many other supportive level also too. The lockdown has shown us that how the situation is worse for both the cases if happened simultaneously. So here are a few recommendations of us. The first and foremost thing we can do is the prioritization of the case detection. Without detecting the cases, we cannot ensure that it will eradicate one day, and address the treatment challenge like stocking and the proper distribution and door-to-door service. Third, setting up a proper mental health and stigma support by increasing peer support where people can share their experience and being a strength for each other, and then find a proper deployment of strategic communication which can educate the TB patients. For that, we can take the help of biggest revolution of our decade, that is the internet, and create and initiate a telemedicine kind of feature which is greatly accessible to the TB patients. We can also emphasize the community built up case where people can share each other's experience and get solace from that experience and guidance. And we are requesting the private health services to engage themselves in a larger scale so that all the pressure should not be put on the public service. And strengthening the implementation of direct benefit transfer may help the challenges around nutrition. And last but not the least, we must take care of the gender responsive care and solutions so that the gender discrimination around tuberculosis and stigma are not lingering within our society. So in conclusion, we feel the need of involvement of support survivors and communities to eradicate this disease. We must develop a strength and strategy to work with both the TB and COVID simultaneously. Every crisis is an opportunity to improve, and this is our opportunity to improve our health and services. And while it is important to deal with COVID, we must not ignore TB because we cannot afford it. Thank you.
Thank you, respected speakers. To conclude today's sessions, I think very beautifully dealt by Dr. Sachdeva, Dr. Tehan, Jimmy, and Dipti Bhatnagar. I think the important thing which we need to conclude that there is a substantial amount of decrease or reduction in the TB notification, either in case of TB, that is around 27%, as Jimmy has told, and in case of MDR, 39% reduction in the notification is there. So we need to boost up and revise all these things and gear up to reverse the losses that has been done because of COVID pandemic, either in TB diagnosis, treatment, or prevention. And we have to accelerate the TB diagnosis and treatment, and also we have to do a lot of work in prevention. So I think COVID is there, and we have to understand that TB is also there and has been with us for a long time. So we need to pacify the things. And after this, I would like to hand over the mic and conclude the session. Thank you.
Good afternoon, everyone. I think that was a very stimulating session on what we know. We have all just undergone the pandemic the last year, and we had a very broad perspective from right from Dr. Sachdeva representing the public sector experience of dealing with TB in the midst of COVID. Dr. Trehan taking on the private sector, Dr. Jamie Tonsing giving us the entire global perspective, and Mr. Diptendu Bhattacharya very effectively showing it, telling us from a survivor's, from a common man's perspective. So we'll go through a few questions. There may be questions coming from the floor, but I'll just run through a couple of questions. The first to Dr. Sachdeva, sir. How severe has been the impact of COVID-19 in our fight against TB? What is the setback that we have actually suffered? I mean, is it something that we can even quantify? Because obviously we know the impact, but are you able to just tell us a little bit in your experience?
So it will be wrong to say that there was no impact of COVID. COVID did have a severe impact on the entire health system, including TB. Some of it can be quantified, which is in numbers. Much of it cannot be quantified, which is in terms of suffering to the patients and to the community. So what can be quantified is, yes, there was a dip in notification to the extent of 25%. So 18 lakhs vis-a-vis 24 lakhs in the year 2019, 18 in the year 2020. So that's a quantifiable impact which we see. What we cannot quantify is much has been talked about it, patient suffering, lack of effects, etc., etc. Having said that, when the program started taking measures to get back on track, right in the month of March itself, we saw an increase in notification vis-a-vis comparable period. So April, there was a dip to the extent of 60% of notification, but May was better than April, June was better than May. So and so forth. Again, we saw a dip in July, August. And September onwards, things started again getting back on track. December 2020 notification was nearly matching December 2019 notification. So on and so forth, Jan, Feb are now nearly matching Jan and Feb of early 2020. So we are mostly getting back on track. Many states have reached pre-COVID levels. Some are still lagging behind. We hope we are aiming to achieve what we achieved in 2019 and 2021. To that extent, yes, there is a setback that we entirely, as Dr. Rehan was also saying, we entirely lost 2020. That opportunity was totally missed. But at the same time, lessons in resilience were learned in 2020. The system was very resilient. They mounted a response to the pandemic in a very effective manner. Similarly, the resilience has been shown by other programs in getting back on track. Hope 2021 will match 2019 both quantitatively and qualitatively.
Thank you, sir. I think that was very well put. I think you adequately quantified the losses, but the good thing is that we have managed to, or at least we're trying to cover up. And of course, there are certain aspects of human suffering that we will never be able to quantify, but one just has to move on at this point. Dr. Trehan, the next question is for you. You obviously gave us a very nice idea on private sector and how COVID and TB, the interactions, and of course, private sector in COVID, they really rose to the challenge and did a huge amount, assisted the government very ably. Now, can this experience that private sector especially got from COVID-19 be used for improving TB care? And are there any specific ways that you could point out that we can actually take examples, learnings from how private sector dealt with COVID and apply it to TB? Because the government's obviously doing a lot for TB, but private sector is lagging behind a little bit. And whether that can now be, whether we've learned something that we can apply. Over to you, Dr. Trehan.
Manali, I don't know if you can hear me, but I'm having trouble hearing you guys. Maybe it's my bandwidth, which is not so good. Can you hear me?
Yeah. We can hear you.
Just give me a minute. Let me try to see if I can improve mine.
Okay. I'll just move over to Jamie. Jamie, what Dr. Sajdeva just said about the setback that India suffered from COVID, would you be able to give us the same thing in a global perspective? Okay, sorry, we'll go back to Dr. Trehan. Yes, sir, we can hear you. Can you hear us? Okay. So, sir, we'll give you a minute to get connected while I move to Dr. Jamie Tonsing.
Yeah,
Jamie,
okay.
could you just,
okay, all right.
Can you give us a global sense to the setback that, because everybody was revving up towards elimination of TB in the next, decade, and then suddenly we've had this huge setback, and, globally, what are the perspectives around that? You're muted. Jamie, you're muted. Jamie, you're muted.
I think what we saw in India was very much repeated everywhere across the globe, wherever COVID impacted the country. So the two are really tied, right? If COVID impact is strong in the country, the TB notification is strong. And that's because both the disease presentation and the response is so similar. And COVID-19 has really leveraged on TB's services to respond to COVID-19. What I'm hoping, and I like the idea of a total lung health approach that National TB program in India is talking about, and also the whole idea of leveraging on this opportunity, right? Because now that we know money is coming for COVID-19, the US government recently announced 3.5 billion to Global Fund to disburse to countries to help with COVID-19 response. What we at the Global Fund are very excited is that whatever money is spent on COVID-19 does help mitigate the impact on TB, unlike other diseases. So I'd say good prospects there. And I think we have to strengthen systems, we have to work with communities, and we have to be prepared for COVID-19, because this is unlikely to be the end of an epidemic.
Thanks, Jamie. I think that's very well put. I think we do have to gear ourselves for, for COVID to go on for some time, as it has shown us. But at the same time, we can't stop our battle with existing diseases. I think we're still waiting for Dr. Trehan to get back. I'll shoot a question.
Okay.
Are you there, sir? Okay.
I'm going to switch off. I'm going to switch off my video. Maybe that will make it better. Okay.
Sure, sir. Sure. All right. So a quick question for you, Dr. Trehan. So I was just wanting to know that private sector obviously participated hugely in tackling the COVID-19 pandemic, alongside the government. And I think we did very well in India overall. Can the experience of COVID-19 be used for improving TB care? Would you have some learnings, some examples from what we've experienced? And from the private sector perspective, is there something we can specifically do to improve our battle against TB and reach elimination as per the government's vision?
So, very important question, Bonali, because one, the participation of the private sector and the government in this battle against this terrible pandemic has shown several aspects which were not so clear before. There was always this kind of barrier between public services and private services, huge amount of suspicion. So a lot of that got broken down, and we have actually come out looking good on all fronts, in the sense the numerical control and the mortality and the way we were able to align. So that just shows that when, the old adage, when there is a will, there is a way. In your Bengali, they say it this way. So what I'm saying is that we can actually capitalize on our experience. We can actually use this platform for the benefit not only for TB, but for many, many things as we move forward. Because the ultimate goal is that we want a healthy India. So healthy India means that if we shed all this facade of government and private sector, then we can actually produce 50% more results even today. So one, the battle for against COVID is not over yet. I think that, you are seeing it. The cooperation continues in the vaccination efforts. Yes, we've all said the same thing, that look, the TB detection, treatments, notifications, that all suffered in this period. So how do we move forward? I think that the lessons well learned, that like we give our experience in Haryana, that we've been working for over 4 years now with the government, and we've had nothing but good things to say about it. That's been the fulcrum on which we have worked, is the fact that the DOT program of the government and us plugging the gaps here and there has had a very good outcome. Okay. Now what we need to do is to couple the two, because COVID may never go away. We don't know, but the intensity will come down eventually, and I hope that we are able to stymie it even now. So hopefully that will happen. So that means that all the resources that we have put in place, and that is for fighting the pandemic, can now be diverted sequentially and progressively towards TB care, because TB is as big a problem for India as anything else. So it is a hidden pandemic, you can say. It's an epidemic, you can say, or you can say we are the worst in the world. Okay, no matter what eponym you want to use for it, but the fact is that it's a very serious matter. On top of that, we have a declared fact internationally to say India will lick TB by 25. Our Prime Minister has declared it on international platforms. And I think that what we need to do is to really try to accomplish that. But to do that, it's a Herculean task. And I think that we need to create, similar to what we did for a national task force on fighting the pandemic, we need to transfer that to a national effort on TB. That's a common target. We need to accomplish it. And bringing it into the micro level, talk about Haryana. that we will of course expand our program also to the places where we are present, like Lucknow and Patna and so on and so forth. But at the same time, we need to concentrate on getting Haryana off its feet. The damage done by pandemic, we need to neutralize it and move forward. So all our workers have been vaccinated. We don't know whether there has been any real reinfection after full immunization. So I think that we can take that chance and move into the community and go get where we were before, or even more. We'll have to be. So what has happened is, since the renewed engagement that we have had recently, we already have interest in people wanting to participate from the private sector. So hopefully, in the next few days, few weeks, we shall be able to mobilize a lot of resources from the private sector, from the CSR, aimed toward TB, because they didn't even know that TB was such a bad menace and their own workforce is affected by it. So I think that awareness of healthy India, that awareness that you want your workforce to be healthy and your man days are actually lost man days cost you money, is now sinking in. And I don't think we should let this opportunity go. We should intensify our engagement with the community, with the industry, and see what we can come up with. Okay, with that, thank you very much. I'll have to take your leave, Banali. I have too much pending work in the OT. Okay, all right. Thank you so much.
Thank you so much.
Bye-bye to all of you.
Thank you for
and Jamie, what a pleasure seeing you again. I know you abandoned us, but we still remember you. Okay. All the best.
Likewise. Thank you. Bye.
All right. Thank you very much, Dr. Trehan. I think Dr. Trehan has worked through, for the last many years for TB and now COVID, and he's really trying to put together a lot of resources from other private companies. And I think private sector and public sector healthcare merging or working together, not merging, but working together is probably the way forward. I have a question for Mr. Diptendu Bhattacharya, who has survived DRTB, who has survived COVID. And so because you are obviously representing, patients in the community, and but you have a very good understanding and you have participated as an advocate. What has the prioritization of COVID-19 funding meant for funds allocated for TB? Because the government had allocated a lot of funds for schemes like the Nikshay Poshan Yojana. And because so much funds were diverted towards COVID-19, what is the impact of that?
I have a recent report of Indian government on India and TB condition of India, where it is written that almost 522 crores has been paid through direct benefit transfer under Nikshay Poshan Yojana for 28,86,701 patients. So if we translate that thing into a pure arithmetic number, that gives us almost 2,000 rupees per patient during their treatment phase they are receiving. And so far so good, because most of the patients has recovered from TB within 2 months of DOTS treatment, that first line treatment of medicine. But the thing is that we must ask one thing, that is that sufficient for a situation when we have this kind of economic downturn going around ourselves? The job losses, the mass migration, the uncertainty about the future has definitely made the patient to prioritize their other things, utilizing that fund rather than getting the proper nutrition using that allocated fund what we have intended for. And the average minimum average calorie requirement, that is almost 2,800 to 3,000 kilocalorie per day, is that amount of subsidy helping us to achieve that target? If the policy is correctly implemented or not, is there any checkpoint around this system? We don't know yet. So what I fear that if this report is for 2019, if the same thing is carried out for 2020 also, I think that the thing will not look that much of rosy like we have expected in 2019. And moreover, the thing is that I have made, for a long time I have advocated for a food stamp kind of system instead of giving direct transfer, which ensures that patients are getting the food instead of they have getting the fund, which is they can prioritize into some different scenario like this if we are facing, which we are facing from last 1 year, and one more wave is coming and Nagpur is under total lockdown. Are we ready for that? I have some skepticism around that. So it's a big concern from our patient side, and we are getting queries on our SATB platform, online help desk, regarding this particular situation.
Thank you very much, Mr. Diptendu. I think you're right that the concerns continue because we are not done with the pandemic yet. The next question to Dr. Sachdeva, we've discussed this, that the entire healthcare systems were diverted to COVID-19 crisis. And we've all witnessed what that did to TB care and services. And of course, we are aware that the COVID hasn't gone away yet. So it's going to linger, and it's going to, and in the future, we may have, repeat pandemics. How does one ensure that, the underlying diseases which have been there for a long time don't suffer, and this balance is maintained while fighting the pandemic? We continue to not neglect other diseases which are as lethal and as much of a problem.
So let me put things in the correct perspective. COVID-19 pandemic has not affected funding from any other program. The entire money for COVID-19 pandemic response was additional over and above what the Ministry of Health had already allocated for National Health Mission. The TB program budget was close to 3,500 crores, and we still will close the entire year with the spending of around 3,500 crores. There has been no shortfall in funding for the TB program or any other program per se. The COVID funding has been totally additional with the support of many multinational development partners, multilateral development partners, and development financial institutions, including some by Government of India. So that has been an additional support over and above. Having said that, also I would like to clarify on this point of time. Let's be very clear that when we say TB is a social disease, that much of the determinants of TB lie beyond the ministries of health. The advocacy also has to go beyond Ministry of Health. It is not only the Ministry of Health. There is a National Livelihood Mission, which is a separate from Ministry of Health. There is a Ministry of Social Justice and Empowerment, which is separate from Ministry of Health. Ministry of Health, if it loses its focus from the core function, will do more damage to the National Disease Control or Elimination Program than good. Let all of us get together and do our advocacy with the other arms of the system, which also look at the welfare of the community and others. The HIV program has done exceedingly well in that regard also. They have approached other missions. They have approached National Livelihood Mission. They have done, the community has approached the other arms of the system, and they have been able to secure some funding for them for their livelihoods. So livelihood is a separate subject altogether. It should not be misinterpreted with the disease elimination programs.
Sure, sir. I think that does clarify a lot of misconceptions that are there. And as you say, rightly, we're all getting back on track. Next questions for Jamie. So this is on malnutrition. Now, malnutrition and TB are closely linked, as we know. And it is a major factor for the increasing number of cases of TB, and that is why the government had started trying to give the nutritional support. Now, how has the COVID-19 pandemic worsened the situation in this regard? It is a bit specific, but if you want to address it in a more generic way, then that's fine.
Thank you, Bernali. Indeed, yeah, I think we've known for a long time that malnutrition is the population attributable factor to TB because of malnutrition. That's the highest among all risk factors, and that's been a concern. But I think as a global TB program, the understanding has been this is much bigger an issue than what the TB program can specifically address. And so, though there are food support programs, but they're very limited, usually to malnourished people, to MDR TB patient packages, and other than that. But and besides that, I think with malnutrition, what we're seeing as small examples in India, for example, through the impact born in Madhya Pradesh, I think those are things we should look at and have real evidence to show. If you are able to intervene with food support, what does it lead to? Does it lead to better treatment outcomes? I don't think we have clear evidence on that front. And so I'll be very interested to see more to really guide us and to see what is the best mechanism and responsibility, where should that lie? Because we hear, I think we've heard examples I remember in Maharashtra, in Mumbai when I was there, that food support is very good for patients, but the logistics of organizing that, when it comes on the TB program, it takes away their time from doing a lot of things, and it's not an easy and not necessarily skills that TB people have. So I think there is a need, but we need to do this through a multi-sectoral collaboration approach. And lastly, I'm not aware of the direct association impact of COVID-19 on malnutrition, but what I can say is that we now have clear data emerging from the World Bank that millions more people have been pushed into poverty, right? And that's globally. So if we can then expect that when millions have been pushed into poverty because of COVID-19, then the problem of malnutrition will increase, and thereby the higher risk for them to acquire disease like TB. Over.
Absolutely right. Thank you very much for that. With this, we will wrap up the session. I would have loved to ask one more question to Mr. Diptendu, but I think we're running out of time. Thank you, Dr. Sachdeva. Thank you, Dr. Trehan, Dr. Tonsing, Mr. Bhattacharya, for being part of this panel and having a very interesting discussion. Thank you.
Thank you.
Thank you all very much.
Thank you.
I want to thank the organizers for allowing me to participate in this Indian TB Summit. I'm particularly excited because of the prominence of innovation in the agenda. Turns out innovation's not always been welcome in tuberculosis. There was an unforgettable World TB Day 20-some years ago when Arata Kochi from the WHO said, "We have the tools to control TB, we just lack the political will." And on that exact same day, the now famous Tony Fauci from the NIH said, "We cannot defeat TB without better diagnostics, drugs, and vaccines." And in fact, they were both right. We need new tools and we need the will to implement them. And this synergy is, in my mind, exemplified by how innovation has given us a life-saving regimen, 4 oral medications for 4 months that are life-saving, and yet they will have no impact if we don't have the will to deliver them. Today's agenda also reflects another significant change in tuberculosis, and that is the increasing focus on patient-centric care. In the old days, TB was very much run by the doctors and the health systems administrators, but more and more we are hearing talk of the patient's pathway to cure. What is the gauntlet? What are the challenges that patients must overcome to get back their health? And in my mind, they can be classified into 3 broad categories. The first is those related to helping people understand their health and when they need when they need help. And that's particularly difficult with the slow onset of tuberculosis. The second is ensuring that they get to providers who provide high quality and affordable care. And the final is to assist those patients with the long and arduous course of antibiotics. And it was really with those three challenges in mind that I went through a list of more than 30 pretty cool innovations and picked out the 4 that we had time to talk about in this summit. The first is the use of smartphones to track cough and empower patients to know and monitor their health status. The second is the use of artificial intelligence to interpret chest x-rays in places where there aren't trained radiologists. The third is the use of technology to help patients to adhere to their therapy. And the final is the mechanisms by which the government of India is now directly transferring cash to patients for nutritional supplementation. I think that each of these are great innovations in and of themselves, but together for me, what they signify is something far more important, and that is how in the last 5 years, India has moved from the backwaters of TB innovation to the forefront of bringing together innovations, political will to improve TB care and control. I look forward to the rest of the conference. Thank you very much.
Today, we are meeting to discuss the tuberculosis challenges, and this event is wonderfully being organized by Survivors Against Tuberculosis and sponsored by NEWG, which is a WHO program for Stop TB, division of the WHO. As we all know that tuberculosis remains a challenge, and by 2030, WHO has targeted that we should eradicate the disease from the world. And proactively, our Honorable Prime Minister has shortened this period, and he wants that from India, tuberculosis should be eradicated by 2025. Of course, we all know it is a Herculean task, but definitely Government of India and we all are trying our best if we can and how we can meet the target which has been set by our Honorable Prime Minister to eradicate the disease. Unfortunately, we had almost 1 year gone in the COVID time. So this was really a tough time because most of the resources, including the human resource as well as consumables, so the equipment, all were diverted towards the COVID epidemic. And this has definitely slowed down the work on tuberculosis. But good thing is that the appropriate behaviors, what we were using, I personally feel, even though there is no data, but I personally feel that this has helped in the reduction of the incidence of tuberculosis, particularly the mask, which all be used. So, but the result, of course, need to come later on. So discuss, obviously, today's topic is diagnostics. As we all know that still the biggest hurdle, if at all, to eradicate the disease by 2025 or even 2030 remains the diagnosis. We need to diagnose early, and we need to, once we can diagnose, obviously we can start treatment which are available. So if there is any delay in the diagnosis, obviously we not only allow the patient to spread the infection in the community, but also the progression of disease also goes haywire. Now in today's this topic, actually this is focused. This session is focused on the diagnostics. As I already said, what is the importance of diagnostic? And the organizers have very wonderfully invited, 4 very prominent speakers in this session. And these are, we know, one is Dr. Madhukar Pai, who will be speaking on the relooking at TB diagnostics. And we all know Dr. Madhukar Pai, that he is the one who is well known for his work. And he is based in Canada, though Indian by origin. And he is the Canada Research Chair in the Epidemiology and Global Health at McGill University, Montreal. And he is also Associate Director of the McGill International TB Program. Madhu actually is from India only, and he did his community medicine from Bangalore, and then he moved to UC Berkeley, from where he did his PhD and fellowship in the public health. And now he is having many decorations, including he is in many of the committees of WHO, Advisory Committee of the FIND, Associate Advisory Committee of TB Alliance, and many more. Our second speaker is Dr. Timothy Rodwell. He is Associate Professor and Physician and the clinician at FIND, Switzerland, which is, FIND, we know that this is also one of the very important organization which deals with all the diagnostics we have in the world about the tuberculosis and other diseases also. We have a third very prominent and young dynamic speaker, Dr. Amita Joshi from our own, from India. She is Professor and Head, Department of Microbiology at Grant Medical College and Sir J.J. Group of Hospitals. She is co-chair of National Technical Expert Group, TB Diagnosis, CTD Central TB Division, Government of India. She is also trainer of the guidelines of programmatic management of drug resistant TB. She will also be speaking on very important topic, sequencing. The Bill Diagnostics help India to eradicate TB. And subheading is changing the diagnostics paradigm with sequencing MTB, because we know these days that sequencing is also has become very important, and not only it helps in the diagnosis, but also it helps you understand if there are any mutations which are pertinent to the drug resistance or not. So that is also very, very important. And then we have the fourth speaker, Dr. Amita Gupta. She is also Indian origin, senior faculty. And Dr. Gupta is Deputy Director of Johns Hopkins Center for Clinical Global Health Education. And she is faculty co-chair of the Johns Hopkins India Institute. So she is also very prominent speaker, and she has been collaborating with various institutes, particularly from Maharashtra, many of the institutes I know personally. And she is the one who is clinician and working in USA on TB, which is usually not many people they like to work because it is not their problem. But obviously, Dr. Amita chose to continue her strive to work on tuberculosis, and she will be speaking obviously on her topics she has chosen is on the reimagining diagnostics in the public sector, what feasible and what not. So definitely that is also very important topic, because what we can do and what we cannot do. She will also share her experience from the Johns Hopkins, as well as what she has various clinical trials in the NIH, MFAR funded, and she is having many collaborations from India. After that, these technical talks, we also have a very young, dynamic and a TB survivor, Mr. Himanshu. She will also share his experience with you all, and he is actually Himanshu Patel had MDR TB, and he is located in Mumbai, and then obviously he got cured of TB, and it is so nice of him that he has made this aspect as his mission. So I am sure that you will all will be very happy to know that not only he got cured, but he is continuously working on the topic. And I think with that, I invite all the speakers, and after that, they have spoken. Dr. Kamala Rodriguez, my colleague from PD Hinduja Hospital, she will summarize the discussion what we had, and I think I open the session to the speaker. Thank you very much.
Hello everyone, I hope you all are doing well. My name is Himanshu Patel. I'm an MDR-TB survivor and I work with Survivors Against TB. At Survivors Against TB, we work with patients and help them complete their treatment. Through working for years with SATB, I've realized that diagnosis is the first step, and yet it is the most difficult for many people. We cannot even provide patients with one stop point of care, and we expect them to take toxic medicines for almost 2 years. Why cannot patients be diagnosed quickly and effectively? Why is testing not available to all at the ground level? Why do patients have to travel? Why can't patients receive in-person counseling and guidance from the very first day of their diagnosis? Why do we not have DR-TB diagnosis as basic norm in public and private sector? As you listen to the panel, imagine the journey a TB-affected individual goes through. They have every classic symptom, but they run from doctors to doctor to understand what they have. Sometimes they are treated for viral, and other times they are treated for other diseases. The one thing that they should know about and should be tested for is not available to them. What is the point of technology if it does not reach the most vulnerable? If the patient has to find their way to it or pay exorbitant amount for it? Let us ask ourselves and try to find answers through this panel. Thank you.
Thank you for inviting me to speak on how we could potentially reimagine TB diagnosis. I think we know, and we've known for a while, that diagnosis is the weakest link in the cascade of care for TB. We also know that a certain fraction of people with TB will have no symptoms or very mild symptoms. We know that from prevalence surveys. We also know that a fraction of people do not seek care or seek care very late. And we also know TB is a spectrum, and subclinical TB is an important group and might result in TB transmission. And lastly, COVID has made everything worse because we've lost a lot of people in the last year who we should have normally identified as TB, and we need to now find them and make sure they have adequate quality treatment. So TB and COVID are now a syndemic, but thankfully COVID has shown us that we can reimagine TB care and do better than what we've been doing all these years. We know that we have probably missed well over 1 million patients with TB, just in the high burden countries with TB, because of the drop in notifications that we're seeing. We know that in India, compared to 2019 and 18, we have definitely missed more than a quarter of the notifications. Well over 500,000 people alone in India have been missed, and we need active case finding strategies to find them and make sure they're linked to treatment. So here, I think we could reimagine TB care using many of the COVID innovations and systems that we've already seen in the last year. For example, the widespread use of apps during COVID to educate people and for contact tracing and for nudging them to seek care. I would love to see them repurposed for tuberculosis, and this work is already underway. We know that digital X-rays are the best triage test we have, and we know there are portable high performance systems that are available. We know artificial intelligence-based software is readily available and endorsed by WHO. And we also have cough detection apps that are now available. We need to find a way to get these done at a much larger level than what we've been able to do so far. We know molecular tests are available. We know molecular tests are also available for TB, for COVID, and for a variety of conditions, whether it's GeneXpert or whether it's MolBio. We would love to see them being used for multiple respiratory conditions as a multi-disease platform. We know simpler sample collection is now possible for COVID, like oral swabs, anterior nasal swabs. I would love to see similar innovations happen in the TB space so that we can move away from sputum to something that's even more easy to do. And testing closer to home is where I think the future really lies and something we should all work towards. And bidirectional screening that has been proposed by the Indian government is something we should really case out. But now that the COVID cases are going down, I'm not sure what the yield of this would be, but this is something implementation science can help us identify. And lastly, we've all learned that care close to people's homes is absolute gold in this crisis. That means home-based sample collection, home-based delivery of medicines, using food delivery type of systems to reach people's homes, telehealth, telemedicine, use of call centers, anything we can do to make TB care more accessible to people without making them go all the way to a district level hospital or to across the city is absolutely fundamental. And lastly, it's not enough to think in terms of discrete tools. We need to find a way to kind of bring them all together into a package. So this website, Reimagining TB Care, provides multiple modern TB care models on how they could all potentially link together and function together as a cohesive system, paper-free, connected to a ICT system. And I think this is definitely feasible today. If we can combine simple triage options, if we can do active case finding, if we can do rapid molecular testing, and then drug assistance using sequencing, shorter regimens, 4 months, 6 months, 6 months for MDR using regimens like DPAL, digital adherence technologies that can connect people to an ICT system. We are looking at a really vastly improved reimagined TB care than what we've been able to do all these years. Thank you.
Hi, and thank you very much for inviting me to speak at this TB Summit. My name is Tim Rodbaum, and I'm an associate professor at University of San Diego, California, and a senior scientific advisor to FIND in Geneva. I'm going to be talking today about sequencing MTB and is it the paradigm shift that we need? As my time is very short, I'm going to make just 4 points. The first is that new TB and drug-resistant TB regimens require fewer drugs and for far shorter duration. While that is a very welcome change, it also increases the consequences of undetected resistance, which increases the diagnostic burden on the provider. Next-generation sequencing is very well suited and well positioned to provide rapid and comprehensive decision support for this new diagnostic burden. However, some significant challenges remain, mostly from our lack of knowledge of the genomic basis of resistance to the very newest drugs. And with that, I'm going to jump right in to the new treatment regimens. There's been a lot of change, and we are in a period of transition for the treatment of TB and drug-resistant TB. And the best way I can think about this is by putting it in all the different new guidelines into 3 different buckets. We have legacy regimens, we've got recently approved regimens, and we've got the future regimens. Legacy regimens are essentially drug-susceptible TB regimen, the 4 drugs we've had for the last few decades for 6 months. Most of the change has come in the bucket of recently approved regimens. And these are for drug-resistant TB, all the way from isoniazid monoresistance to the new definition, pre-XDR, which is MDR plus fluoroquinolone resistance, which goes from the new treatment for isoniazid monoresistance all the way to BPAL for pre-XDR. Noting, of course, that the BPAL treatment for pre-XDR is currently research use only by WHO standards guidelines. Then there's the future regimens. While there are many, I'm focusing mostly on this one, on the one that is doing very well in trials and most likely to be the next approved, hopefully, which is bedaquiline, pretomanid, moxifloxacin, and pyrazinamide, which will be used for both drug-susceptible TB and drug-resistant MDR TB, but for different durations. Now, while there's a lot of complexity in those new treatment guidelines, I think this is probably the most important point. And that's that legacy drug-resistant TB treatment required multiple drugs taken over an 18 to 24-month period to prevent resistance and failure. The new TB regimens and drug-resistant TB regimens are composed of fewer drugs, and they are taken for far less time, which means that treatment success requires that all of those drugs be effective all of the time. And so what do I mean when I say there's worse consequences in the new treatment regimens for undetected drug resistance? Think about the old regimens and the new regimens as a multi-layered, multi-tiered, redundant protection system. With the legacy regimens, with up to 6, 7 drugs at a time being taken, if you are resistant to any one of those drugs and that resistance is undetected, you're taking still many, many drugs, and you're taking them for a very long time, and so you're likely to be okay. With the new drug regimens, we're only talking about 3 drugs taken for 6 to 9 months. If you have undetected resistance to just one of those drugs, you are now taking only 2 drugs for as little as 6 months. And as history has shown for the resistance of TB, that is likely not to be a good outcome. It's not likely not to have a good outcome, both in terms of resistance, acquired resistance, and in terms of treatment outcomes. So how can we avoid that? We can avoid that by changing the diagnostic burden. The diagnostic burden for the legacy drugs was moderately complex and moderately complicated to interpret clinically. And in terms of the clinical decision-making, that was best done with prediction of phenotypic resistance by nucleotide changes. To be able to do that for the legacy drugs, we need to look at about 7 gene targets and about 1,000 base pairs. And that allowed us essentially to predict resistance to isoniazid, rifampin, fluoroquinolones, and second-line injectables. The new diagnostic burden, the optimal new diagnostic burden, is way more complicated than that. We now have many more options for drug choices and combinations, and we need to know resistance to all of those different combinations before we put patients on those treatments, especially the ones that have very short and few drugs in them. And so now we're looking at understanding phenotypic resistance, predicting phenotypic resistance by looking at gene targets across 34 different genes and about 25,000 different nucleotides. This is not possible anymore with the existing nucleic acid amplification tests, such as the HNLPA or the new XDR cartridge. This is something that's going to require something like next generation sequencing or, of course, phenotypic DST. It also requires more complex analysis, and it requires more complex interpretation in terms of making clinical decisions. The good news is that next generation sequencing is literally designed to handle this kind of complexity and is used in this way for things like cancer treatment now. And the other good news is that next generation sequencing of just 34 targets, which is something you could do with targeted next generation sequencing, should give you all of the information you need to make treatment decisions for all of the new treatment regimens that are available. This is an example of how a treatment decision tree would work based on the results at each one of the steps to each one of those different gene targets. And this is all information that's available today. So what about feasibility? Is clinical targeted next generation sequencing feasible? The answer is yes. There are already several solutions available that are research use only solutions, and those are end-to-end solutions that go from a sputum sample through to a clinical report. While those are still research use only, we hope that to change very soon, which brings me to my next point. FIND is currently leading a project called the Seek and Treat project that is funded by Unitaid, and a project that we're doing in collaboration with the World Health Organization and partners all over the world. And there are many goals to this project, but the main goals are to make clinical next-generation sequencing available for the diagnosis of drug-resistant TB. The 2 parts that I'd like to talk to you about today are about the new WHO TB knowledge base that we're working on and should be available publicly soon. This essentially will become the primary source for information about whether or not a drug resistance is associated with phenotypic drug resistance. Drug resistance mutation is associated with phenotypic drug resistance. We've been working on that product for well over a year, and we hope to have that available publicly sometime in late April, early May. The second most important part of this project is the clinical evaluation of commercial end-to-end solutions for targeted next-gen sequencing for the diagnosis of drug-resistant TB. The analytical validation phase of that work is done, and we're now just starting the clinical evaluation phase of that. We hope that work will be done by around the end of 2021, and hopefully the results will be available publicly in 2022, and hopefully that will make it clear that there are some commercial solutions that make this possible on a clinical basis. So I know that I haven't had much time to go into much detail, but I hope I've at least intrigued you about the idea of sequencing MTB and that it is definitely part of the paradigm shift that we need. It may not be everything, but it is definitely part of it. However, challenges remain. The two that concern me most are finding enough TB DNA to sequence and our gaps in knowledge about the genetics of drug resistance. When I say finding enough TB in the DNA, TB DNA in samples, I mean FB negative samples. Those are going to be a challenge. And the other is about genetics of resistance. We're doing quite well with some of the new drugs, such like Bedaquiline and Delaminid, but we've still got a long way to go with drugs like Pertominid, for which the phenotypic DST is not all exactly worked out yet. And with that, I will conclude, and I will thank all the organizations and all the people, as well as yourself, for listening and supporting this work. Thank you.
Hi, I'm going to be speaking about will new diagnostics help India to eradicate TB? So we have very ambitious targets to end TB. And what this figure here is trying to show is that we're currently on the red dotted line, which is telling us that our current trend of reducing TB globally is at minus 1.5% per year. So we clearly need new tools to be optimized, and we also need new tools such as vaccines, drugs, and better diagnostics to really bend the curve so that we get to the minus 17% per year reduction in incidence to get us to our very sort of targeted goals of ending TB by 2035. We have the National Strategic Plan for TB Elimination in India, and we also have the NTB strategy that the WHO has released, and that can guide us. In the Indian context, the key issue is finding the missing million in India, where we know that there are many people who go undiagnosed and therefore untreated and are continuing to transmit in the population. And more recently, there's been attempts to look at what can work, such as combinations of incentives for doctors, expanding the diagnostic network extensively, as well as providing nutrition support and punishing people who don't notify if a patient's been diagnosed or not, particularly in the private sector. We also have roadmaps to really think about how to use new diagnostics to achieve our targets of NTB. These include having triage tests, having biomarkers that can tell us whether someone has tuberculosis and can replace the smear that only has 50% sensitivity. We also need universal access to drug susceptibility testing, as well as an ability to test for latent infection and treat people who don't have active TB with preventive therapy. These are just some of the key aspects of being able to eliminate TB with new diagnostics. So what are some of the new diagnostics? Well, there are many types that use different platforms and types, and you will have heard from Madhukar Pai about these, but they range from those that are sputum-based, blood-based, urine or breath-based. Some of them are point of care, some of them are near point of care, and some of them need very specialized central labs. They all come with issues of access, complexity, cost, and test performance. And so currently, the ones at the top half of the circle are those that the WHO has approved. So line probe assay, the Gene Expert, both ultra and standard. We have the LAMP assay, and then something that's called TrueLab. On the bottom are the other emerging technologies that include this, things like centralized drug susceptibility tested with whole genome sequencing, and you will have heard of from Tom Redwell, point of care testings like the MolBio, sequencing, and other expert cartridges that can be done in the community through the Omni machine. What I wanted to highlight that with any diagnostic, it does certainly have an impact, particularly if it's a good diagnostic. And this table particularly shows what the impact of expert has been on patient-centered outcomes of mortality, loss of treatment, loss to follow-up pre-treatment, as well as time to diagnosis. And you can see here that comparing expert to smear microscopy, we have had an impact on fewer deaths, fewer people being lost to follow-up, and having fewer people who, more people who are more quickly diagnosed, with time to diagnosis being 5 more per 100,000. So clearly having a better diagnostic that's made available can certainly have a big impact on patient outcomes. I want to, however, caveat that any new diagnostic by itself is not going to be the solution. We have to reach a large number of people. So here, this model shows that if we can offer TB testing with a good new diagnostic and reach 70% of the adults in India, at a one-time large mass intervention, you can actually result in 25% reduction in TB incidence and mortality that is sustained over a 20-year period. The key here, though, is to know that it's not just the diagnostics that are helping. We have to offer the preventive therapy to somebody who doesn't have TB, and when you're done your screening, and you obviously have to have strong health system strengthening to really magnify the effect so that you can link people to the appropriate care, both for active TB as well as preventive therapy. So I think that's really the take-home message, that new diagnostics can be very exciting, shiny new tools, but they all matter how we use them and making sure we can get to as many of the population to have access, and then, of course, link them to the proper care and preventive therapy strategy. So I'll end by saying that any new diagnostic has to be seen in the context, and in the red boxes are sort of where diagnostics play in the whole spectrum of activities that are needed to be successful at ending TB in India and beyond. Thank you.
I would like to thank India TB Summit for inviting me as a panelist for reimagining TB diagnostics in India, especially with respect to TB diagnostic in the public sector, what's feasible and what's not feasible. The Ministry of Health and Family Welfare, Government of India, had come out with a national strategic plan for tuberculosis elimination by 2025, 5 years ahead of 2030 as announced by the World Health Organization. And this was only possible under the dynamic leadership of Honorable Prime Minister of India. This NSP was driven by the detect, treat, prevent, build approach with a vision to have TB-free India with zero death and a goal to achieve a rapid decline in the burden of TB, morbidity and mortality. The detect component basically was to find out all TB cases, whether they were drug sensitive or the drug resistant. And the method was to scale up free, highly sensitive diagnostic tests and upgrade the algorithms as and when these tests was introduced. To scale up effective private provider engagement approach, to give universal testing for drug resistant TB, and to have a systematic screening of high-risk population. It was only because of this national strategic plan that by the year 2020, we had 6 national reference laboratory fully functional, 31 intermediate reference laboratory, around 50 certified laboratories for liquid culture and drug sensitivity testing. All of them were providing, whether NRL, IRL or certified culture DST lab, all the diagnostic tests available. We had 64 certified laboratories with the line probe assay services, more than 20,000 designated microscopy centers, 15 standalone TB containment lab providing liquid culture, more than 1,000 CBNAT facilities. In the year 2019, we had 19 laboratories in the TB sector, which went in for NABL accreditation for ISO 15189. India is the only country in the world where whole genome sequencing was first introduced in the public sector. 5 sites in India were identified and strategically located so that the entire population of India was covered. There was a well connectivity within these labs with a robust lab information management system or LIMS, and every data generated was put in the Nikshay program, which was readily available to the clinician and the person concerned. It was because of inclusion of these various tests, the diagnostic algorithm went multiple changes and sometimes even to the tune of twice in a year. Whenever a new test was approved by WHO, the committee looked at this, national committee, validated this test for the program. The laboratories were quality assured, and then only was it rolled out in the national program mode. This is the latest diagnostic algorithm. As can be seen, upfront, a molecular test in the form of a nucleic acid amplification test, either CBNAT or TrueNAT, was offered to all presumptive TB cases, those of PLH-HIV, extrapulmonary tuberculosis, smear negative but X-ray suggestive of TB, pediatric TB, vulnerable population, as well as contact of drug-resistant TB. To all notified TB cases and non-responders to TB, where we started even addressing the rifampicin resistant but isoniazid resistant, rifampicin sensitive and isoniazid resistant population also. In a cascading manner, all the other tests, whether first line LPA, second line LPA, culture with first line sensitivity and second line was offered in a reflex manner depending what was the result in the previous. As can be seen, every possible and feasible, it was possible and feasible only because we had a strong advocacy and the power to eliminate TB with a robust funding model as was put down in the National Strategic Plan. Every diagnostic test was given to the population free of cost without compromising quality, to the extent that even the high-end whole genome sequencing is fully functional at the 5 sites with continuous training and monitoring by the National TB Elimination Program with fortnightly eco sessions and support of FIND and FMR. So if you ask me what is feasible, I'll say in the public sector, everything is feasible. So what is not feasible? There is nothing that is not feasible. We definitely face some challenges. We were thinking that the large population of India will be our main challenge when we put down these high-end testing in the public sector. But the COVID-19 pandemic stumped all of us. It affected not only my national TB program, but all the national programs in India as well as worldwide. Not only did we see a reduction in the number of cases due to the lockdown and the difficulty faced by the patient in approaching the center, but we saw fully equipped TB laboratories being converted into COVID-19 testing labs to cater to the large population which came with this pandemic. Another challenge was the human resources, like getting qualified trained personnel. The high attrition rate of these qualified trained personnel was further multiplied when these staff got diverted to the COVID-19 testing sites. But no patient service was refused. Samples that came to the public sector were diverted under the guidance of the national program to the private labs. So if you ask me, where there's a will, there's a way stands very true in our national TB elimination program. Everything is feasible. There is nothing which is not feasible. The national TB program led the way, and all the labs, whether we were in the public or in the private sector, followed. Thank you.
It's my pleasant duty to actually close this session, which, as you all have realized, has been a really brilliant session by our excellent speakers, whom we've actually cherry-picked from across the world. And as you know, accurate diagnosis has the potential to really be the cornerstone in the management of TB, not only the management and the control of TB worldwide. And the problems confronting TB has been decades of neglect, partly sort of fostered by the misconception that drugs had beaten the bug. Today, the diagnostic landscape has hugely changed. It's promising, and there's a robust pipeline of new tools that we have at our beck and call. You've heard the story of a TB survivor's journey from diagnosis to treatment, and you've heard our 4 panelists addressing the wide scope of TB diagnostics, from the highly complex whole genome sequencing to those available at the lower tiers of the healthcare system. And newer diagnostics really, to be effective, have to be accessible and affordable to those who need it the most. And frankly, we possibly have to there is sort of potential to reach scale still. And if I could sum up today's session, I would love to reimagine TB diagnostics as showing greater alignment or offering greater alignment with novel TB drugs, being better tests to case detect paucibacillary TB, TB that affects the brain, TB that affects the bones, and which tend to be paucibacillary and not so easily picked up. And of course, we need to have biomarkers for triage, biomarkers to cure, and biomarkers to tell us the progression of the disease. I can also already see several questions in our Q&A for our Q&A session. So as I just wind up this session, I would like to thank our partners, the new Diagnostic Working Group of the Stop TB Partnership, for supporting this program. Thank you.
Good afternoon, friends. We're a little early, but that's good. We have more time to talk. And the questions are pouring in. And we have 4 panelists. We have Tim Rodwell. Have you heard, Tim? You're awake. Great. Thanks for joining. Sure. We have Dr. Amita Joshi, who was our last speaker and is our public face. We have the survivor, Himanshu Patel, and I'm waiting for Salman to join. So the first question that someone has asked is that why is that the diagnosis of TB continues to remain a challenge? Is it the awareness or the stigma, lack of awareness or the stigma, or do we simply ignore the systems? This is actually a question for Himanshu.
Thank you, Camilla. I think to answer these questions, I mean, that lies on the doctors that are treating patients, right? I mean, yes, I mean, people are not aware, that is true. But if like they're reaching out to doctors, like whenever anyone is sick, they reach out to a doctor. And if doctor is able to diagnose it correctly, then we won't have any problem. So I think it's the standard approach, how like one needs to be diagnosed, needs to be followed everywhere. I mean, whether it's urban city like Mumbai or any rural area in India.
But Himanshu, do you think it is because of stigma? If I mean, you're a TB patient, you were a TB patient, do you think you sought care later, or were you not aware? What was the reason that you believe, from a patient perspective, the diagnosis was delayed?
So I was not aware, honestly, but my doctor diagnosed it correctly. So there was like not a longer delay in my diagnosis. So initially, like for like first 2 weeks, I was being treated for like cough. But after 2 weeks, when my doctor realized that I'm not getting better, he immediately asked me to do a chest X-ray and some sample blood test that confirmed my diagnosis, and even gene expert that confirmed that I have drug resistant. So I feel, I mean, stigma could be a reason that it will definitely contribute to people will not talk about it, so they will not become aware. But I still feel that if all doctors in India are like they do diagnosis correctly, I think there won't be much problem.
Himanshu, you're putting us doctors on the spot. But anyway, the next question is for Tim. Dr. Tim looked at the genome sequencing, and it really seems transformational. What would it cost for large-scale deployment in India? And what would be the returns in terms of lives saved?
Excellent question. Thank you for the question. Not a good answer, I'm afraid. It's still a little bit early days in terms of costing, because there's the clinical solutions are only being evaluated we're sort of starting the clinical study of the diagnostic solutions this year. So depending on how that goes, we'll have a better sense of how it'll cost. But I think the short answer to that is that it should definitely not cost more than doing it phenotypic drug resistance testing. So the same that we do now in midget, it shouldn't cost more than that. And I think the very good news is that people that I've spoken to in India, commercial partners in India, feel that it can actually be a lot cheaper than that. So I think, again, this is a question of scale. It's a question of rollout. It's a little hard to say, but I think it's well within the cost of what we already do for TB. This is not something that's way more expensive than anything else we do for TB. That's the first part of the question. Second part about lives saved. It really comes down to how quickly you can get it done. Whole genome sequencing or targeted next-gen sequencing can basically give you an answer in 48 hours. So you contrast that with the phenotypic drug susceptibility testing, which we're talking 4 weeks, 5 weeks, 6 weeks. And so it's definitely going to be measured in lives saved. I can't tell you exactly how many lives saved, but getting drug resistance diagnosis faster, getting people onto the right drugs sooner is definitely something that's going to make a difference. Not only that, I think this is also going to be one of those things where the lives saved is going to be also measured in terms of not destroying new drugs too early. The new drug regimes that are made up of only 3 drugs, for example, BPAL, the 3-drug regimen that's coming, if we start to get resistance to one of those drugs early, it'll literally destroy the regimen for everybody else. And so this is just something that measuring lives saved is not just going to be how quick could you get it done to get the lives saved, but keeping drugs like the new drug regimes effective.
Okay, before the next question, I want some clarity from you. So I'm going to ask you, how do you resolve, given the association that genotypic and phenotypic testing is poorly assessed for bedaquiline and linezolid, which are now our go-to drugs which are now actually included in the XDR definition? How do we diagnose or detect this by DST? What would your recommendations be?
Yeah, so things are going to be a little bit rough in the early years, and the reason why it's going to be rough is actually good. The reason why it's going to be rough in the early years is actually the frequency of resistance is so low right now. So because the frequency of resistance is low, we literally don't have enough information to associate genotype to phenotype. As soon as we get more of them, the associations will become more tightened. So I think the good news is that we have a place to start. We already have 2-3 genes identified that can make the association. But for example, in the WHO catalog that we're working on right now, there's literally so few resistant bugs in the catalog that it's hard to make the statistical association. So I think the good news is that it's so infrequent right now that we don't have a lot of statistical strength to the association between genotype and phenotype. But as that builds, and I guarantee you it will build, so will our knowledge. And the good part, Camilla, is that we'll be able to with something like targeted next-gen sequencing, we can apply the knowledge very, very quickly. So this mutation catalog, for example, that we're developing right now with WHO, this is not a stationary catalog. This catalog is going to be updated on a regular basis. And as our knowledge comes in, so the recommendations will change.
I'm sort of finishing questions with you, Tim. There's another question that says, how are you going to make next-gen sequencing in India? How do you propose it to be available with your what are your next step forward? You did talk about it, but how do you think it will roll out in India?
I think a lot has to do with, as Dr. Joshi spoke about WHO approval of technology. Then India looks at the WHO approval and looks at when and how to best apply it. We're hoping the same goes here. That we're going to do the clinical study this year. By the end of 2021, we should have all of that data. So early 22, we're looking at having a WHO review and endorsement. And I would hope what that would trigger in India is a review of that technology as well at that time. And looking at that, basically using that as an opportunity to say, okay, is this time to roll out in India? And if it is time to roll out in India, then it's all about which technologies where. And the good part about sequencing is there's all sorts of instruments that can be brought to play. There's small desktop instruments that are the size of a toaster and large room-size instruments if you have a gigantic hospital with 1,000 cases a day, like the kind of cases that you see at Hinduja. So I think there's lots and lots of different solutions, and this can be done in a lot of different ways at expenses that are not terribly different from things like GeneXpert and other things like that. So we're not talking the price of a pregnancy test. We're not. It's more complicated than that. But it's also not something that can't be scaled. And the great thing about this technology, it's a digital technology. The more we do it, the more we scale, the cheaper it'll be. Whereas something like Midget, a DST, for example, it's a technology that's only used for TB. And it's very hard to get sort of price scaling to come down with Midget. It kind of stays the same all the time. This technology is used for things way beyond TB, And so the things driving the pressure of the price pressures down in sequencing are probably not going to be TB, but TB will be able to take derive the benefit from the prices being pushed down by other things like cancer and things happening in the rest of the world that will push those prices down. I don't know if that really answered your question.
Somewhat. Okay, Amita, there's a question from a patient who asked, I suffered from MDR TB and took forever to get the diagnosis right. Every time there were new tests, there were new drugs. Why is there so much discrepancy and variation? And why is the paradigm different in India than the rest of the world?
Camilla, you're also part, though you're a private lab, you're a part of our laboratory diagnostic that we are offering in the national program, and you're aware. I think it is a large number of patients which are not able to cater. Though we have made up so many diagnostic labs, even with the culture facility, we are not able to take care of all the population. That is a main point which is there. But when it comes in, we are giving. Yes, even 2 years back when we did that exercise, there is the linkages are poor. The lab is generating the report, but unfortunately, it is not landing up or networking linkages. It's not going to the clinician. And there is a big gap which we are trying to now bridge, how to bridge this gap. Because the lab, the report goes to the TB officer then gives it to the clinician. So this gap is the one, I think, where we are losing out our patients, where though the lab is doing full justice, but somehow the report is not reaching at the right time. And another thing, though we started the sequencing, let me tell you, we are only doing it from epidemiological purposes at present. And our main challenge is that even when we started the next-gen sequences, our starting point is culture. You know, it is yet culture only. We are not getting any much success with a sample. So if the patients or if the world thinks that we have a magic in our hand, it is only if I get a culture, then then the magic starts with the sequencing. Unfortunately, I think even Tim will agree, at present, the start point has to be the culture to get a proper sequencing result. At least that's what has been our experience. We're not having much success as far as the direct sample is concerned. Unless it's a 2+, you know, on the microscopy, then we are having some amount of success with the direct sequencing that is there. So a patient complaining, I will even say what Himanshu said. Many of our clinicians are not aware that we have got such a big diagnostic in the public sector free of cost. So the cost factor does come many a times, you know. They are referred to a private sectors and the cost of in the private sector, though the same lab may be giving it free of cost when they come in the national program, it deters many of the patients. They can't afford. That is the thing is that. So I think the knowledge among our clinical people itself is quite less. The doctors themselves are not aware that we have a very good quality assured lab, even in the public sector, giving everything free of cost, I will say.
True. But Tim actually spoke about targeted NGS, which is, you know, directly from samples. So that may address issues much faster than waiting for whole genome sequencing that is currently only available from a culture positive sample. So somebody has asked a very simple question that we're faltering at the first step of diagnostics. How do we correct ourselves as a system? I would say that India is definitely, I mean, I've been doing TB for the last 25 years. And I remember when we started doing TB, we were one of the few labs in the country that had a TB Backtech 460. And, you know, we actually started doing it because we felt the need was so much. But things have hugely improved, really hugely improved. The country is engaging much more. And I think active case finding is really on its own today. And we're looking and we have actors advertising, which is the best way to get Indians to listen. Celebrities saying, you know, when you have a cough, when you have unexplained fever, when you have loss of weight, get to a doctor. And the good part, as Amita did state, we have almost 1,200 CB NATs, whether it's expert or whether it's small bio, available at the peripheral center. So, I mean, we really have come a long way, I think. There's a long road to cover, I know. And Himanshu, don't lose heart. It's going to happen. It is happening. And And I really believe that as we look at better and better tests, like Tim said, if we can put our patients on the top drugs, the category A fast, because of the definitions of XDR being redefined, maybe we'll really get better treatment because we're shortening our regimes. With shortening regimes, our patients are not going to be so deterred by this 18-month or 24-month, which is really bulking. I mean, if I had to take injections or I had to, 24 months is really a long time. And I feel for patients who are MDR TB. And are there any more questions? I can't see any more. How much should India invest in diagnosis in rural settings? And are the delays happening there? To be honest, India is investing in rural settings, but the problems are happening in the metros. The metros are hugely crowded. Anyone who visits Bombay gets shocked when they look at the number of people per square kilometer. So definitely TB is being transmitted in the metros. In the rural areas, somehow there is TB, nobody denies that, but it is being accessible. Amita, what do you think about diagnostics in rural settings?
I agree with you, Camilla. We have even gone up to the district and sub-district, if you understand the cascade that we have. So even up to the PHC now we are trying, because even in a diagnostic technical group, if you remember, we had spoken of putting LAMP over there, at least to diagnose, and having our TrueNat systems right up to the PHC. That is a public, the district's primary health centers that we have. So already the framework is there. The machines have come in, and the training is happening over there. So I think we have reached, we may not reach right up to the end, but at least we have reached up to the primary health center. So that is a big achievement as far as India is concerned, I think so.
Tim, how do you feel about the use of AI in TB diagnostics? And how should we be looking at it in terms of privacy and costs?
Yeah, I saw that question. It's an excellent question. I think there's an absolute, there's a real case for AI. Essentially, what we're trying to do with all the new information that's pouring in, because we're doing sequencing faster, we're getting more bugs in, we're getting both genotype and phenotype. It's all about understanding the relationship between the genotype and the expressed phenotype. And AI is going to be able to do a marvelous job of that. So a lot of the work that we're doing sort of manually and statistically now, I fully expect AI to take that all over and do a much better job than we are. With respect to the question of privacy, that's an interesting question, actually. When we take the DNA out of a clinical sample, we're pulling DNA out from both the human sample, from the sputum, and from the bugs. But in all of the sequencing work that we do, or the targeted sequencing and the whole genome sequencing, the very first step we do is we filter out all the human DNA. So we have a bioinformatics filter that gets rid of the human DNA. So all the work that we do, we won't let that human DNA even into our database in the first place. So from a privacy perspective, the only thing you're having exposed is your bug. Your bug's DNA is getting exposed, not your DNA. And that's an important distinction.
There's an interesting question. How do we ensure the quality of testing is maintained? My family members get incorrect reports, and this leads to misdiagnosis. I can take that. I think, the quality control that the Indian government is putting into TB diagnostics is really big. Every lab that reports out on TB that is recognized by the government system, you must ensure that when you go to a lab, it is under some accreditation system. Don't just go to the friendly neighbor lab who is not accredited. There has to be an accreditation system, because with that comes a whole lot of proficiency testing, a whole lot of audits that are done all the time, and they ensure quality. So my advice to you would be, try and get to any lab that is accredited. Ideally, the Indian system is really good in the accreditation system. It has, it yearly does it. There's NABL for accreditation. So, we're getting there. But make sure the lab you're giving your sample to is accredited. There's another question. How far are we from a self-test on TB? I need to understand this because the disease is so widespread. Why are we not getting people to self-test? Tim, Amita.
Dr. Joshi, you want to take it first? I can take it second.
Since both are laughing, we know we are not very near. I mean, we are quite far, at least from self-test as far as TB is concerned. I think they're talking how good we are where HIV is concerned, where self-test can be done. Unfortunately, that is not the scenario. At least not. I don't see in the near future, very near future also, unless maybe Tim has got something more to add on the self-test.
Yeah, if you'd asked me that question just literally 3 years ago, I would have just said, forget about it. There's nothing even on the radar that I feel confident about. And I have to say, the last 2 years has very much changed my view. So much so that, honestly, one whole side of my lab now works on that. Not self-testing, but the kind of technology that will lead to self-testing. Up to now, antigen detection, antibody detection, like human host antibody detection, it wasn't going well. But there are a couple super exciting things. So the Fuji Lam stuff looking very exciting. We've got some direct antigen detection stuff that's looking very exciting. And the new three marker host marker stuff coming out of the Stanford 3 marker that is being evaluated by Cepheid. Those are very, very promising things. And they at least have the chance to be turned into something that could get near self-testing. And so I think there's at least we laugh because, boy, we wish that was possible. But I really feel for the first time in my career, so 10, 12 years, I haven't been doing this as long as Camilla's been doing this, but I do feel for the first time ever, there is finally something that could lead in that direction, possibly within 5 years. I know that seems ridiculous for anybody who wants an answer now, but I at least feel optimistic about it this time.
And we're talking sputum, or we're talking urine, or we're talking blood?
I'm talking urine, we're talking blood, urine and blood so far. So direct antigen detection in blood is absolutely looking like a possibility in technologies that could potentially head towards self-testing. And the urine lamb testing, if that continues to improve the way it has been improving, that could ultimately turn out to something that could be in the format of self-testing. A little bit complicated still, so it's still a little bit fantastical, but I at least feel excited about it and feel that we can be moving in that direction, whereas even just 3 years ago, I wouldn't have said that.
Great. If there are no more questions, Himanshu, we're answering your questions. We're getting there. And hopefully our patients won't suffer anymore. Hopefully there'll be less MDR patients. Hopefully patients will get a diagnosis. Things really have improved. I mean, the other day a patient came and said, how can I believe this test has come in 2 hours? I said, no, believe it. It's true. So he said, no, earlier I have to wait 3 months, and my daughter waited 3 months. And are you sure the test is right? I said, I'm sure it is right. So we're getting there. Things are really improving where TB is concerned. And molecular tests, there is no question. I'm a traditional microbiologist and I love cultures, but I have to believe the era belongs to genotypic and molecular tests, at least where TB is concerned. So I'm actually going to close the session because there are no more questions. Any more pressing issues on diagnostics? Okay, I would just like to thank the new Diagnostic Working Group again for sponsoring this session. They're from the Stop TB Partnership, and thank you very much. It's been a pleasure being on board. Thanks, Amita.
Thank you very much for the invitation.
Thank you. Likewise. Thanks, Himanshu. Bye-bye.
Good night, everybody.
Bye. Good night.
Hello, everyone. My name is Rashi Garg, and I'm the General Manager for Cepheid India. Over the last decade, molecular diagnostics has undergone tremendous transformation from complex technologies to point-of-care testing, both globally and in India. Tests like ExpertRIF, MTB, have changed the diagnostic landscape of TB. Millions and millions of tests have been done using GeneXpert. And detection of MDR-TB has increased 3 to 8 times compared to conventional testing. The rollout has galvanized many stakeholders, from civil bodies to donors, and has paved way for UDST. Yet, diagnosis in India has remained a challenge. the time has come to revamp our efforts in TB elimination. Given the large concern around TB detection, the problem really lies in slow and time-consuming diagnosis of MDR and XDR TB. It's time to shorten the time to result with better quality, fast reporting, multiplexing capabilities to provide more information in less time. Cepheid has innovated a novel 10-color technology launched in 2020. This technology will help identify broader target sequences in PCR technology and will be very useful for detection of multiple pathogens in a single molecular test. This is the first PCR system with integrated 10-color capability for your hospital, your lab, and point of care setting. So what is a 10-color technology? It's basically a 6-color module which has been calibrated for 4 additional dyes with our innovative excitation and detection technique, which enables broad spectrum of pathogen detection. The benefits, obviously, as independently monitoring 10 or more signals, can be worked on any of our gene expert systems, and same benefits as our existing menu. So why was this technology so important for us? The simple reason is it helped us to further innovate with our MTB XDR test, which is a first 10-color base test on our 10-color instrument. So what does that do? For the first time in the history of molecular diagnosis, Cepheid has innovated and launched a 90-minute molecular test to detect MDR and XDR TB within a single test. That means if the patient is RIF or RIF positive, you can immediately test him for INH, for fluoroquinolones, ethanoamides, for second-line injectables like amikacin, kanamycin, and capreomycin. And it will help us rule out any TB resistance, any drug resistance. Let me also quickly introduce Ms. Anita Herstock, who is the Managing Director for our manufacturing capacity in India and is leading our Make in India Atmanirbhar initiative for Cepheid. Over to you, Anita. Thank you very much.
Hello, my name is Anita Herstrom Sjöberg. I'm VP, Managing Director for Cepheid in Sweden. I'm also responsible for setting up manufacturing in India. Cepheid in India has made a huge investment to make the product such as MTB RIF cartridge in India to ultimately come closer to our patients, build better inventories for local requirements, and to empower Indian healthcare system as self-reliance in molecular TB diagnostics. This will create additional jobs and opportunities along with so many other benefits to the healthcare partners, TB programs, and patients. Cepheid is producing expert MTB RIF tests in India. This gives us the opportunity to dedicatedly provide the test to Indian patients, including those on the National TB Elimination Program, the NTEP. It is a remarkable milestone in Cepheid's journey as we are improving access of game-changing diagnostic solution through a technology transfer and collaboration mode in India. We have set up manufacturing units in India and production started in Q4 of 2020 with an installed capacity of 7.5 million tests. We are now in talks with the government to expand our localization footprint in the country. It is a huge stride in support of the government's TB eradication drive by 2025, strengthening the Make in India commitment and also enabling a self-reliant manufacturing. Not only will this help the patients and healthcare practitioners better, but also generate a local employment and also an ecosystem assuring a robust molecular diagnostic future in India.
Hello, I'm Dr. Lancelot Pinto. I'm a consultant chest physician at the Hinduja Hospital, Mumbai. I, along with Dr. Saurabh Rane, have the honor and the privilege of being invited by the Survivors Against TB to chair what I'm sure will be an extremely interesting and valuable session on reimagining TB treatment in India as part of the summit to reimagine TB care in India. While COVID-19 has taken center stage over the past year, we know that our efforts to eradicate tuberculosis are far from optimal, and there is a serious concern that they may be hampered by a diversion of resources that the management of COVID entails. As a physician who treats patients with tuberculosis, my dream or my imagination in the treatment domain would be to help patients have a treatment experience that is no different from other infectious diseases. Take malaria, for example. Treatment that is offered without judgment or stigma, treatment that involves regimens that are short, involve a minimum number of medications which are well tolerated, thereby improving concordance between me and my patients in a way that is respectful and non-paternalistic, without the use of words such as compliance or default. To do this, we have an interesting session ahead looking at different perspectives in which we could reimagine better treatment for patients with TB. We start off with a TB survivor, Dr. Bharati Kaloti, who would speak on what I would want for patients who get TB like I did, reimagining a better patient experience. She is a project director at Akshaya Project, the Union Southeast Asia office. She's a medical doctor with an MBBS and an MD with a professional experience of more than 21 years. She has a passion for tuberculosis, being a survivor twice in her lifetime, both for drug-sensitive and drug-resistant TB. She started her career as a private practitioner and owned a nursing home for more than 5 years until she joined the WHO as a technical consultant for National TB Elimination Program, and since then has been working in close collaboration with the National TB Program in different portfolios. She has worked at the Central TB Division, Ministry of Health and Family Welfare, as a grant manager to support donor funding for NTEP received through the Global Fund. Her experience and understanding around donor coordination has been appreciated by all organizations, following which she has served many organizations like CHRI, PATH, and now the Union. She will be speaking on behalf of TB survivors, speaking about how we can reimagine a better patient experience. Drugs form the backbone of TB treatment, and we need to reimagine drugs in a way that are more patient-friendly. And for this, we have Dr. Anil Kaul, who's currently the Vice President for Global Public Health and Infectious Diseases Discovery Unit at J&J Pharmaceuticals. From 2016 till recently, he was the Director of Government of India Premier Biomedical and Biotechnological Laboratory named CSIR IM Tech, or the Institute of Microbial Technology. His biggest career milestone was his role as a key scientist at J&J in the discovery and clinical development of bedaquiline, the first drug to be approved in the last 45 years for the treatment of drug-resistant TB. And we all know what a game changer bedaquiline has been. For his contributions, he was awarded the annual Heroes of Chemistry Award from the American Chemical Society in 2020, the Swiss TB Prize in 2005, and various different awards for his contribution to science. He has more than 20 years of experience in drug discovery, development, and scientific innovation, has worked across 3 continents, and has earned his PhD from Max Planck Institute of Biochemistry in Germany and at Delhi University. He will be speaking on how we can accelerate the access to newer drugs, reimagining the bench-to-bedside rollout. Adherence is another word that is very often used in the TB lexicon. We prefer the use of the word concordance, trying to improve the understanding between the patient provider and the patient. Bruce Thomas is the founder and managing director of the RKD Group. He's a recognized expert in the fields of medication adherence and innovation delivery. As both a consultant and grantee to the Bill and Melinda Gates Foundation, he leads the development, testing, and scale-up of new approaches to improve adherence and support differentiated care for TB and HIV patients in India, China, and Africa. He will speak on how can an understanding of behavior help patients with TB have a concordant experience, reimagining better facilitation of the journey. Last but not least, an important part, an important component of TB care is the involvement of governments, is the involvement of public sector, is the involvement of the state in ensuring that TB patients get the care they deserve. Dr. Rajiv Sadanandan is a former Indian bureaucrat from Kerala, from the Kerala cadre of the Indian Administrative Service and healthcare policymaker. He has been working and researching in the area of health systems, policy, and financing for over 2 decades. He has been involved with the health system of the state of Kerala and has been active in health sector reforms in the state. After serving as the additional Chief Secretary of Kerala, taking care of the Department of Health and Family Welfare, he took over as the Chief Executive Officer of Health Systems Transformation Platform funded by the Tata Trust. He will speak on can state healthcare systems do things differently to help patients with TB, reimagining TB care the Kerala way. With this, I hand it over to the speakers and I look forward to listening to all their interesting talks.
Good afternoon, everyone. I am Dr. Bharti, and I'm very happy to be here today in the India TB Summit, as I'll be presenting the patient's perspective of being a TB patient. And as you can read from my presentation, my topic is what would I want for patients who actually get TB like I did. And I think being a TB survivor twice in my life, this is an opportunity for me to actually share my experience during this presentation as how I went through and what I went through and what I look towards in the country. Before starting, I definitely would like to thank Dr. Pinto and the team who have given me this opportunity to share my experience with all of you today who are as my audience. So welcome to you all also. And I would start now. I have tried to make this presentation a little personal because I wanted everybody to have a feel of what a TB patient goes through. Okay, to start with my first slide, what TB is to be. So I would like to tell you all that I was actually, the first time I had my first episode, it was in 1996 when I was a medical student and I was diagnosed with extrapulmonary TB. It was left-sided lymph node, and the lymph node was like a 10 rupee coin which was sitting on top of my aorta. And being a lymph node TB, it was something which was treated with, I think, all types of first-line anti-TB drugs. And it went on, and since the size of the lymph node was not decreasing, I was actually finally operated, and this lymph node was removed from my body. And this took almost 2 years for my treatment till I landed up in a very major surgery, which we call thoracotomy. And after that also, it did not stop. I was given additional 9 months of treatment and additional 3 months of amikacin injection, which led to almost a 3 years treatment, which was ideally expected to be over in a period of, say, 6 to 9 months. And why all this chaos happened and why I landed in such a sort of a treatment was basically the knowledge gap I had as a patient when I was suffering from TB, because I did not want to interfere with the treatment of being the fear of dying because of TB, and I wanted the doctors to take a call for me. I was not interfering with their decisions. And it all went into chaos. People were not aware what's DOT strategy. Private sector was totally uncontrolled, and I became an experimental sort of a, guinea pig for them to actually treat me for TB. And what happened finally was that the after effects of treatment were that post-thoracotomy, I was given very heavy dose of steroids. I had cataract in both my eyes. I was actually operated at the age of 28 years. And I had a very painful experience of those 3 months of amikacin. I still today have chronic gastritis. So if I don't get a glass full of chilled milk early in the morning, even if it's winter, I can't leave my bed. And even worse was that 10-inch thoracotomy scar, which was actually a physical scar, but it became very emotional for me. I was in a mental trauma, and it affected me personally, my moral, my persona, everything. I followed recurrent abortions. I don't link it to the disease, but definitely since my organism was weak, I almost lost the hope of becoming a mother. And finally, I had a precious pregnancy, which landed up well. And the worst thing which happens to a TB patient is the change in the physical appearance. So that is something which brings in a lot of psychological impact on a TB patient when you actually change what you actually look like before treatment and what you become after treatment. And the story didn't end here. So I lived with this for years. And almost after 20 years of my treatment, I was again diagnosed with MDR-TB in 2017 when I was almost 45 years of my age. And I'm showing you my pictures because this is what brought to me, what was the change which came in me after I took these drugs. So again, what was similar? Again, this was a left-sided lymph node. This time it was under my jaw. So one fresh morning, I get up, I see myself in the mirror and I see a round swelling under my jaw, and it turns out to be MDR-TB. But what was different this time? The difference was this time I had the complete knowledge. I knew where to go. I knew which doctor to approach, which treatment to take. I had the privilege of getting the best diagnosis, timely diagnosis, and being treated by one of the best physicians in the country. And of course, a wonderful boss who just said, Bharti, don't even touch your laptop. So those words I still remember, how my colleagues supported me during this treatment. And I knew what was coming for me. The sufferings are going to be worse. As you all know, the treatment is horrible for an MDR-TB patient with 2 years of all side effects. But I was ready to face it because now I had lots of support. I had a job security. I had people who would treat me properly. I knew I was confident I'm getting the best drugs. But what was the severity in this case? So the severity was that I was going to suffer because of somebody who had mismanaged me 20 years ago. Had that treatment not been given to me wrongly, I wouldn't have gone through this. All my first-line drugs were found to be resistant. I had primary resistance to kanamycin, which is one of the major drugs as an injectable for MDR-TB patient. And I was left with minimal choice of drugs to actually have treatment. And how did the treatment go? 21 months, 16 pills a day, which my son used to give me. Injection imipenem given through a chemo port. Every morning, evening in a drip for half an hour. So I have to visit the doctor every morning, evening. And every day there was a new drug reaction. There was not a single day I was not having a reaction. Horrible drugs, horrible side effects. And then imagine the mental trauma which comes to you and your family when you are totally into the system. And I remember the worst remark I got from one of my relatives was, you are a defective piece. So that is how people look at you when you are actually a TB patient. So even if you have educated families around you, TB is not considered to be something very good a person gets in his lifetime. And what was the outcome? I have a purple discoloration of my skin. I had severe scaling. I used to look like a snake. My weight gain was almost 16 kgs because I was taking a diet equivalent to 4 people. I had lived in old age. All my joints used to pain. I could not climb stairs. I could not go out alone. There was one person always required for me to take me out. And now the dark complexion because of clofazimine. 2 years after treatment also, the dark color of the face does not go. It remains there with me. So what do I want? What would I want that a patient should actually get when he gets TB? So equip the patient with all knowledge of the TB as a disease, as the services available. Give him a choice of drugs. Can't we have better drugs with lesser side effects? Can't the duration be brought down to 6 to 9 months? We know we have shorter regimen, but how many of these patients actually qualify for that 6 to 9 months regimen? You need a very robust counseling system. Every morning that patient needs somebody to vent out, tell him what's going on with him. Focus on the mental health of the patient. Secure his needs of food and job. I could afford the diet of four people. How can a poor person afford this food, which he has to get at least for 4 people? So let's think, are we actually saving the lives of TB patients or are we killing them mentally? And let's learn from the COVID pandemic, the new normal. So I'm speaking this because I've been a COVID warrior also. So I imagined when I was having COVID, how could we convince the community to wear a mask in just no time? Everybody was wearing a mask all around. How could we get a vaccine within 6 months? How could health sector respond so aggressively? Why every notified case is received all services? Why are there no TB patient call centers? Were the deaths because of coronavirus more than TB? Not at all. There is no comparison between TB deaths and coronavirus. So let's think this. So to conclude, I would say that there's something definitely we are missing. Government has put all efforts to give us free drugs, free diagnosis. Our Prime Minister is committed for ending TB in 2025, but still we are missing something. So let's work together on it, be the voice of the TB survivors. And as someone has correctly said, let's add life to the years and not years to the life. So just by saving the life of a TB patient, let's not be happy we have saved him. We are actually damaging him physically and mentally. So we have to give him quality of life. So let's think on those grounds, how we move about, how we bring in those drugs to treat a TB patient. Thank you.
Good afternoon, everybody. Good morning, good evening to all the people across the world. My name is Anil Kaul. I'm Head of Public Health Discovery at Johnson & Johnson, and I'm also Professor of Translational Discovery at London School of Hygiene and Tropical Medicine. So today, on this India TB Summit Day, I will be talking about reimagining TB treatment and particularly focusing on innovation in TB drug discovery. So I started my life with the discovery of Bedeclin, and how we discovered it as a team was via unconventional phenotypic approach. So what you see here is the structure of Bedeclin, which was originally called R207910, then it became TMC207, and now it's named as Bedeclin. So what this drug does, it basically blocks an enzyme which is called ATP synthase, which is shown on the right side of the slide. So this ATP synthase is basically involved in synthesis of energy. And as you can see that this drug blocks the enzyme at a very, very potent concentrations, which is almost 2.5 nanomolar. So as I said that this enzyme is involved in the synthesis of ATP, and ATP is the energy of life. And this energy makes the bacteria survive, this energy makes the bacteria infect people. And the moment you block this energy, the bacteria get killed. So what Bedeclin effectively does is basically it shuts down the power supply of the TB bacteria. So how does Bedeclin shut down the power supply of TB bacterium? It's shown in this particular fantastic video, which I will show right now, is the structure of this particular enzyme, ATP synthase, and you can see how complex the enzyme is. It's like a machine, it's like a motor, and in this video you will see how exactly the Bedeclin is able to block this particular enzyme and as such shut down the power supply of TB bacterium. So now I'm starting the video, and you can see that this is the molecule of Bedeclin coming up, and it basically blocks the interaction between the green and the gray. And the moment you block the interaction between the green and the gray, it basically stops the rotation of this motor. And this rotation of the motor basically stops the synthesis of ATP, or the energy source of the TB bacteria. So it's you can see that with that in this Mycobacterium tuberculosis ATP synthase, Bedeclin comes and blocks the lower rotor part of this particular extremely complex structure, which is the ATP synthase. And you can see the yellow ones are the Bedeclin that block basically the whole what we call C subunit of this particular enzyme. Extremely complex, but extremely fascinating in terms of how exactly this molecule is able to prevent the energy synthesis of Mycobacterium tuberculosis. So bedaquiline in the end kills the TB bacterium, and this is shown by this single cell time lapse video microscopy, where you can see the green is the Mycobacterium tuberculosis. They replicate very nicely normally, but the moment you put bedaquiline in them, they start exploding after some days. You can see that in the green, suddenly these Mycobacterium tuberculosis bacteria, which are labeled in the green, you see them exploding, and over a period of time, they start killing themselves, and the green fluorescence goes away. This is amazing, what we call a single cell time lapse video microscopy, where you can see the impact of bedaquiline at a single cell level. So as we go forward, what do we need for a TB regimen? We need more effective drugs. We need improved, safer regimens. We need regimens which can shorten the TB treatment duration, whether it is drug susceptible or MDR TB, and we need simplified regimens. So our aspiration now for a new regimen for TB is that the regimen has to be bactericidal. So the key question is that can we cure TB irrespective of the resistance phenotype in less than 3 months, say 1 month or maybe 2 months? Can it be a universal regimen? It doesn't matter what the resistance background is. Can we cure all forms of TB? Can it be oral, all oral regimen? Can it be much safer as we have right now the regimen? It has to be compatible with the HIV drugs. It has to be better compliance, and the access has to be across the world. So how do we want to do it? We want to do it by basically have a drug which can be done as a single pill, what we call single pill combination. Right now, you know that current MDR TB treatment has a multiple of drugs that a patient needs to have every day, 10 to 12 drugs. The future is that can we have a fixed dose combination of a single drug? This has happened for HIV, and this is going to happen for TB. How do we want to do it scientifically? I won't go in the science in detail, but just to show you, the gray is the ATP synthase, where bedaquiline is basically working, as I showed in your previous video. There are other enzymes in this whole chain of energy synthesis, and that is cytochrome BC, cytochrome BD, and other enzymes. And the aim is that that we just have blocked ATP synthase. Can we block all the elements of this particular chain, which will eventually bring the complete halt to the energy and kill the TB bacterium very effectively? It's like a cycle of the chain. You have stopped one gear. Can you stop the entire whole gearbox of the cycle so that the cycle doesn't move any further? It's the same thing shown here, that the innovation in TB drug discovery, there is Certuro, that belongs to ATP synthase. There are other targets which can be switched off. And actually, these are 4 switches which we have identified. We have switched the main power supply, but there are small generators which can be effectively switched off. And this will basically switch the entire power grid of TB bacterium. So this is going to bring a paradigm shift in terms of that we need this synergistic combination, and eventually a TB which can be cured faster, which can be cured in less than 3 months, and which can be eventually cured as a single fixed dose pill or in a very simplified regimen, and which can cure all forms of TB, whether it is dormant, whether it is actively replicating, or whether it has different resistant forms. So with this, I want to end and say that we are working on new TB regimens. We hope that we will be making a paradigm shift in the TB treatment. And as I said, that it all starts with the discovery. With that, I would like to thank you all across the world for listening to me, and back to the organizers. Thank you.
morning. My name is Bruce Thomas, and I am a global health consultant, primarily for the Bill and Melinda Gates Foundation, but also with Unitaid, the Stop TB Partnership, and with Novartis. I am a specialist in medication adherence and in differentiated care. And today I'm going to be talking about how an understanding of adherence behaviors can help TB-affected persons have a more concordant experience. So let's start here. We know that TB is treatable, we know it's curable, and yet in many high-burden regions, health outcomes remain suboptimal. Here, as we can see from cascades of care in both India and South Africa, a significant number of patients drop out or have unsuccessful transitions from proper diagnosis to inappropriate treatment to cure. And it's even worse for persons affected by drug-resistant TB or persons co-infected with TB and HIV. So obviously there are lots and lots of opportunities for improvement. We'd love a vaccine, we'd like better, shorter regimens, we'd like more point-of-care diagnostics. Fortunately, many of these things are finally on the way. But in the interim, we can, and in my view, we must give TB patients what they deserve: more patient-centric, more differentiated, more concordant care. And on this front, we're making real progress. So what I'd like to talk about today is an important segment in the patient journey, this medication adherence piece, keeping properly diagnosed patients who are on appropriate treatment, taking their medications until they are cured. I want to talk about how we can use new patient-centric tools to capture detailed information on how each person takes their medications, their medication-taking behavior, and lastly, how an understanding of these behaviors can be used to create a more concordant experience and better health outcome for TB-affected persons. And on the right-hand side of this slide, you'll see a definition of concordance. It's a doctor-patient relationship that combines shared knowledge, trust, support, and most importantly, shared decision-making. So we'll talk more about that. A few key points on this slide. So first of all, we know that adherence to TB treatments is essential. How essential? The slide on the right shows that medication taking in TB is imperative. TB treatments are incredibly unforgiving to poor adherence. If you don't take at least 90%, you're more than 6 times more likely to experience recurrence. That's the slide on the right. The slide on the left is Dr. Beena Thomas's information from India that shows this relationship between irregular adherence and TB recurrence. And we know that baseline adherence is low. And some of the reasons for that are, first, adherence is a multi-factor behavioral issue. It changes over time. But in TB in particular, the regimens are long and complicated. The dosing is very confusing. There's side effects to the medication. And unfortunately, some of the things that we have tried to help facility-based DOT may have been counterproductive in that it's burdensome on patients, it's inconsistent with their lifestyle, and it's stigmatizing. The good news is that we finally have given patients custody of their own medications. With FDCs, that shift has taken place. And as we do that, we're using new digital adherence technologies to support these self-administering patients and to capture some of their dosing histories. These dosing histories, which are really adherence vital signs, and I'd love us to begin using that word, can be used to continuously triage TB patients leaving those persons who are adherent alone and prioritizing those who are having adherence-related issues. And secondly, we can use these dosing histories, these behavioral insights, for more personalized, more concordant care. And in the chart on the right, you see how this move from trying to control patient behavior to coaching patient behavior is what we're looking for. So why do we think that this approach is desirable, is more concordant? So the approach is very low patient burden. Again, we give patients custody of their medication and we largely leave them alone unless they are demonstrably having issues. These vital signs, these adherence vital signs are shared. Providers and patients can see that information. These dosing histories, these vital signs provide critical behavioral insights that can be used for discussion between the patient and the provider. What challenges is the patient experiencing? What steps can be taken to mitigate these challenges? And this sort of enhanced counseling, as you can see from the chart on the right, really works. So the blue line shows the improvement in adherence that occurred after this enhanced counseling. So again, it's low patient burden, it facilitates a discussion, and it works. So just to tie it back to this concept of concordance, this approach, this knowledge of adherence behaviors helps create concordance. As shown on the right, again, knowledge, trust, shared decision-making. The approach that we're discussing shares information to establish a shared knowledge base and to establish trust. It facilitates a discussion that helps patients feel supported and make informed shared decision-making about their care. It's behavioral counseling. Nothing, in my view, is more concordant. So in conclusion, we're making great progress, I think, in this shift from controlling behavior to coaching behavior, from this one-size-fits-all to this more personalized approach. These new patient-centric digital adherence technologies facilitate that progress. We must strive to, and we now can, deliver to every TB patient more differentiated, more concordant experience across their entire medication-taking journey. We've made a good start, but much, much more work and much, much more innovation remains urgently required. So I thank you for your time today. Thank you very much.
Morning, and thank you for inviting me to speak today. I'm going to be briefly describing the way in which Kerala manage the revised National TB Control Program. A lot of this is going to be similar to what was done in the rest of India, because this is a national program that has a similar parameters across the country. But given the specifics of the health system in Kerala and the way the health system is located in the whole governance framework, there'll be some interesting difference that may be of interest to the people who are listening in. Now, the reimagining of the TB control program in Kerala happened due to changes in the design in the revised National Tuberculosis Control Program. In the past, TB was managed as a vertical program by specialist pulmonologists. Now, RTCP made a crucial difference by taking the program away from the specialist and entrusting it to the general health system. In fact, it was a shift of power from the pulmonologist to the public health specialist. While in the past, drugs were prescribed based on patient characteristics such as body weight, etc., RDCP came up with a standard drug regimen based on categories into which patients are divided and also the pediatric cases. All the persons in one category received the same medication. Now, this took away discretion from the clinicians on what to prescribe, thereby making it possible, thereby putting every clinician on an equal plane. This certainly had its dangers. In fact, many persons attribute the steep rise in drug resistance to such an untitrated use of drugs. But it enabled TB treatment to be handled at the primary care centers and sub-centers. And this was a crucial change for Kerala. It brought in a paradigmic shift in TB management. Now, primary health care teams, while they were not familiar with tuberculosis, were familiar with patients, their families, and their social milieus. The multipurpose health workers, who are actually the frontline workers for this program, both male and female, had developed the experience of working closely with the community. Sorry. This enabled them to track persons on treatment to ensure treatment compliance, bring in some bit of a social pressure, and also to retrieve them on default while identifying more accurately the reasons for default. Now, the second benefit of this was the management close to the community had the impact of normalizing tuberculosis as community health workers, as part of their work, had an interest in ensuring that the persons assigned to them for follow-up did complete the treatment. The unintended consequence of this change was that it brought attention to something that was ignored in the past, that is the social circumstances of the patients. This is a very important determinant of the disease and also its treatment. In Kerala, in 1996, that is a year before RNTCP was started, all primary care institutions and even secondary care institutions had been transferred to the local governments. That is, the control of these, the administrative control of primary health centers, secondary hospitals were with the local governments. These governments, unlike in other places, had financial resources, which they had the freedom to invest in promoting health. And since health is a subject to the lot of political salience in the state, and since primary care teams work closely with the local governments because they are the advisors on health to the local government, they could advise them how to invest in health. Because of this, those when they were interested with tuberculosis, they could persuade them to invest in adding infrastructure, say for a microscopy center. Slowly, local governments are persuaded to support other aspects such as nutrition. In fact, a district panchayat did run a nutrition program as a pilot one, and then later it was extended to the entire state. Now, not only did the involvement of local politicians lead to mobilization of the resources that were available with them, but because politicians had this contact with the non-government resources, the community, they are able to mobilize the community to build houses, setting up local support groups, providing food, transport, etc. So so the shift to primary health system had the benefit of shifting the management to primary care doctors and multipurpose health workers, which had its own impact. And because this primary health system was aligned with the local government, it had the secondary benefit of shifting that to the panchayats and municipalities. In 2016, when the new government came to power, they announced a set of Kerala-specific sustainable development goals. And as you know, SDG 3.3 targets elimination of a set of diseases, including tuberculosis. Kerala announced the target of eliminating tuberculosis by 2025, which has now got slightly modified to 2030. This is meant to be done with the support of the local governments, and each local body was supposed to come up with a motto of my tuberculosis-free Gram Panchayat or my tuberculosis-free corporation. The advantage then is that the political mileage that a local government gets in supporting tuberculosis has the potential to contribute to tuberculosis and also to bring in other elements that can support this. Now, this is still in the nascent stage. Unfortunately, only the initial stages have happened, but it has the potential to emerge as a major strategy and an instrument for TB elimination in Kerala. Look at the other benefit. To a large extent, if we are able to work with local governments who in turn work with the civil society, to a large extent, tuberculosis is destigmatized, it is normalized, and the otherwise neglected social aspects of managing tuberculosis also come to form. So if you analyze the components that I've described above, the key ones that stand out are shifting responsibility of tuberculosis control to the primary care system, use of community health volunteers to better engage with TB patients and their families and to appreciate the social conditions and its link to TB and its treatment, the linkage that consequently got established between primary health centers and local governments, the availability of flexible funds with the local governments and their willingness to invest that to support tuberculosis patients, the wider social mobilization that happened when elected representatives are made to appreciate the situation of TB patients and how they can be helped, and the consequent reduction of stigma leading to greater willingness to access testing and to complete treatment. In addition to this, as part of the TB elimination campaign, Kerala also undertook a vulnerability assessment and focusing on people who are vulnerable to tuberculosis. Now, if this strategy, which I've just described above, is further extended, it can go upstream and look at those factors that contribute to the vulnerability to tuberculosis. Is it housing? Is it nutrition? Is it any other factor? And because of the flexible funds available with the local government can be used for any justifiable purpose, this can be used to reduce their vulnerability and address them before people get infected. And it can also go downstream. That is, people who are cured of TB have a lot of needs for rehabilitation, which are generally not addressed. Now, if that is also set up as an aim of this assistance, it also has a tremendous potential for making the life of TB survivors a lot easier. I hope my description of how the shift happened in Kerala has been of interest to you, and thank you for listening. Thank you.
What a wonderful vision of reimagining TB treatment that was, encompassing the patient experience, drug development at the bench, how we can improve treatment regimens with newer drugs, behavioral cues, and measures to optimize concordance between patients and healthcare providers, and most importantly, how governments can facilitate this process seamlessly. I thank all the speakers for giving us this hopeful vision I thank Survivors Against TB again for giving us this platform, for looking at this wonderful vision. And we will now take questions from the audience. So I'd like to thank all the speakers again for a wonderful session. Thank you for all the different perspectives that we've got. I'll start my first question for Bharti. Bharti, thank you again for showing us your pictures, giving us a very true, realistic picture of what you went through. I think it's important for everybody to know the journey that a person goes through. One of the questions that's being asked is, what can we do to support individuals who go through that journey? You mentioned that your supervisors, your bosses were very supportive. You had friends to help you. But what about individuals in general? What can we do as a society to make the experience of a person going through it more comfortable? No, you're not audible, Bharti. I think you're muted.
Okay, am I audible now?
Yes.
So I would like to say, see, a patient's journey is very difficult when he's taking a TB treatment, right? So it starts right. The first challenge he has is the duration of treatment. You tell anybody to take medicine for 3 days itself is like a challenge for him. But now here you're asking a person to take medicines for 6 months, 9 months, 2 years is the first thing which you have to help the patient with. Now, since we don't have a choice and we have to go with that sort of a regimen, it's very important for us to understand who is going to take care of this particular patient when he's under treatment. So if you say family can do that, it's not a fact. Family cannot do that. Family can give you food. Family can ensure you are taking your medicine on time. Family can take you to a doctor when you have a reaction. But who is it who is going to solve this problem? A patient always looks towards his doctor or her doctor to be there for him when he has a problem. And every TB patient has a problem every single day. But even a doctor doesn't have that time. How can a doctor keep on getting back to each patient every day and telling what's happening? So my personal feeling is, if the national program is really into giving that support to a PTB patient, leave aside the drugs and the diagnosis. That is coming on, it's going on. People are there to support you with this. You can do it from private sector, you can do it from government sector. What you need is a person. When I say person, I mean specifically a counselor. A counselor who is always available for a TB patient. He may not be physically available. He may be available on a call. He may be available through a call center, but a very educated person who can convince a TB patient why he is on that 6 months of treatment or 10 months of treatment, why he has that reaction, who knows how to guide this patient when and how and where he goes. So for me, in a TB patient's life, a counselor is very, very important, even more than a doctor. A doctor will start the treatment. The counselor has to live with this patient. And the second part, which really plays a role in a TB patient's life, is the age of the patient. If you are a student, your parents will take care of you. If you are a professional, you have to take care of yourself. So we need to have policies. We need to have workplace policies for TB patients where they are comfortable enough to have job securities when they're undergoing this treatment. Every TB patient needs rest. He cannot afford to take medicine without rest. And the organizations should think through this. How do they provide this rest to a TB patient? I think if these two things are being taken care of, the mental health of the patient and the financial part of the patient. Drug TB treatment is very expensive. Even if government is giving you free drugs, there are so many ancillary things you need. I had to hire a driver to take me to the hospital. How can anybody afford a driver? Everybody can't do that. So there is a very strong financial need and support for a TB patient. So I think from my end, two things to be kept in mind always: the mental health of the patient and the financial support of the patient.
Thanks, Bharti. I think that covers another question which we asked, which was asked about why are psychiatric comorbidities not considered as genuine comorbidities as part of the TB spectrum? You know, we view it just as a microbe, an organism, and a disease. I think we need to have a more holistic approach.
Exactly.
Professor Paul, everyone's very excited about a single polypill short course regimen targeting different targets, which will hopefully cure irrespective of what the resistance pattern is. How far do you think how far do you think are we from such a regimen, and B, what do you think are the hurdles in accelerating it and then in actually making it accessible to everyone?
Thanks, Dr. Pinto, and everybody on this call. I think what we need to understand that there are several regimens which are nice right now in the clinical development. So across the world, so there are different drug combinations which people are testing at different stages, phase 2, phase 3. And also there are new regimens which are being developed and in preclinical development. So I think we have made tremendous progress in terms of understanding the science of TB, and also in terms of reaching to the final goal, as you rightly said, a single pill regimen, a fixed dose, a single pill regimen. So that's something I think there are several institutions, several labs, several companies across the world trying to see how fast and how easily we can go there.
Thank you. Bruce, we have a question for you. It says, isn't it unfair to place the burden of compliance on a patient who is already under immense distress and pressure due to their diagnosis? How do we shift the responsibility back to the system? How do we make the system more accountable?
No, it's a great point. You know, obviously, we want to empower patients. We want to enable patients. We want to support patients. We don't want to burden patients. I do think that an enormous first step has been taken, which is to give patients custody of their medications so that they don't have to be burdened by frequent, journeys to the clinic to have their dosing supervised. I do think that what we need to do is then think about how we can make those self-administering patients feel confident about how they can handle their medications and understand that throughout that process, support is available when they need it. And I think that's the important part about these digital adherence technologies. They create a channel for providers to communicate with patients, but even more importantly, for patients to communicate with providers to seek support where they're having issues. So that, again, the idea here is to make self-administration routine so that it is more convenient, and then support patients so that they can confidently manage their own medications.
So again, as an addendum to that, in a country like India, where one of the problems we face, I think, is you often have one cell phone which is shared by an entire family. Does that tend to be a hurdle, or are there confidentiality issues around that are difficult to circumnavigate?
Yeah, I do think that making sure that these digital tools are developed with a sense of what the reality is in the community is incredibly important. Not everyone has access to a phone, as you say, Dr. Pinto. Not everybody has an access to to smartphone. So one of the things that is important is that patients are given a choice with these digital adherence technologies. We have now 3 different technologies, 3 very different approaches that are all integrated into Nikshay. So if you have a smartphone, or if you don't have access to a phone, you can be given a digital adherence technology that will work for you, a box that will actually act as a phone itself, and that will organize your medication. So particularly for MDR-TB patients, organizing medications means confident patients, I think. And so that's the point here. Again, these tools are designed to be pragmatic, to be realistic in the settings where TB patients live, and patients are given a choice about which technology they can use.
Thank you. Rajiv, the next question is for you. Fantastic presentation. I think everybody looks up to Kerala for what Kerala does in terms of health. A lot of your presentation, though, covered the public sector and how you would engage, decentralize the public sector, engage people at the ground. A big challenge that a large part of the country faces, in fact, even in studies have shown that 70 to 80% of individuals approach the private sector as a starting point, and that can be pretty chaotic for a lot of individuals. How do you think we can standardize that, and how do you think, like Bharti mentioned earlier, I knew who were the right doctors to go to this time. How can we make that more universal? There is no right doctor, and everyone does an equally good job, even in the private sector.
One problem with India's health system is the failure to engage with the private sector. We saw that during the COVID. I mean, we've seen it, during HIV and so on. In tuberculosis, what we did, the initiative was taken by the government, which reached out to the Indian Medical Association. What we did was to negotiate with the doctors on how they can join this effort. After all, doctors don't make that much of money out of tuberculosis, and that is something that from an altruistic motive, we found that doctors are very, very willing to work with us. Now the question is a government willing to engage with them and create a group that can, that no matter at what point you go, the benefit that is passed on by government in terms of subsidized testing, in terms of drug supply, all this can be channeled through the private sector. And Kerala, the private sector in Kerala has worked with the government of Kerala to provide this and are still providing it. The samples are collected there, testing is done at, in some cases, the testing is done at the hospital themselves with lab technicians provided by the government. In some cases, it is transported to our centers where it is done. Now, if you create a target that is shared by everybody, my experience is private sector will be very happy to collaborate with us. Question is, do people know how to reach out and build that coalition? Thank you.
Right. So second question I'm again going to ask you is which gets asked often. What do you think why do you think there is a reluctance to upscale the availability of newer drugs like bedaquiline? Why does it seem to be taking so long? Why is it so difficult to access?
No, I may not be the right person to answer that question. But again, as I mentioned, we work through the government. My experience is working through the government system. And in the government system, I have not noticed any reluctance to take it up. In fact, we've been waiting for the newer drugs which have been licensed abroad to be made available here so that we can start screening for latent tuberculosis and start treating them. So I haven't noticed that reluctance. But I may not be the right person to answer that question.
Professor Kaul, would you care to comment?
Sorry, Dr. Peter, was it for me?
So we were just wondering, why has the availability of bedaquiline not matched what the need seems to be? Why is the distribution being limited? Why is it so difficult to access still?
I think, to be honest, bedaquiline right now, if you see that the availability across the world is really, really good. Means we have been the excess of the drug across more than 120 countries, more than 130 countries actually. It's registered in greater than 60 countries across the world. So in terms of the regulatory, in terms of the excess of the drug, there is definitely I'm not talking about India, I'm talking across the world, that there is definitely availability and commitment, both from the industry as well as the governments, as well as payers, to really make this drug available to people across the world. Of course, we have to be careful in terms of compliance, in terms of using it properly, because we want to make sure that the drug does get used in the right context. The emergence of resistance is a big threat for all antibiotics. So there are several factors which we have to take into account when the drug has to reach to the patient.
Thank you. So we have about a minute to go, and I'm going to give all the 4 experts 20-second chance to tell me what their reimagination of drug treatment for TB would be, say, in the next 5 years. Rajiv, can you begin?
Yeah, my dream is to see tuberculosis normalized like any other disease. No stigma. People are willing to accept the best treatment that is possible. And what motivated me when I came to this was the current burden of tuberculosis in India is an unnecessary thing that we're carrying on when we have the means to remove it. I hope that we are able to really scale up and do what we're capable of doing. Thank you.
Bharti? I think you're on mute again, Bharti.
Sorry. So my imagination is, let's have a treatment which is the choice of the patient, a very shorter one with very less side effects, affordable, and at the same time, like any other treatment. It should not be a disease which is a fear to the patient. It should be a disease, we always say it's a curable disease, but at the same time, we should also say it's a very easy disease to get cured with very easy drugs to intake. That's my idea.
Thank you. Bruce?
So I would love to see us move with these better, shorter regimens that are coming as close as possible to a real test and treat model where we're really closing that gap. And that as we treat patients, dosing is less confusing and patients really get the support that they deserve, the support that they need from these digital tools that are both being developed and increasingly available.
Anil, you have the last word.
Yeah, to be honest, my imagination is that look, in the last 20 years, I have spent my life on Bedeclin in terms of the discovery, along with the rest of the team here. So for next 20 years, I really want to see that we eradicate TB. And my hope is that in coming years, we have regimens which are simpler. And one day I'm able to have that single fixed dose pill, which can cure a TB patient in less than 2 months, or maybe less than 1. That's a dream. But I think we are honestly at a phase in TB innovation, one of the best phases of TB science is what we have. And combined, as Bruce said earlier, combine it with the digital technology and digital interface and AI and machine learning and all the innovation that is happening in TB as well as in other sciences, including the supply chains, we will be there to eradicate TB from this world. I'm pretty sure and confident about the science, at least.
On that positive note, I'd like to thank all of you for your fantastic contribution today, and hopefully people will hear, and this will be the first step towards making the change that we all desire. Thank you.
Thank you very much.
Thank you.
Thank you.
Bye.
I retired a few years back as the Vice President of a telecom company. Now I work with the street children in Kolkata. I have fought TB, suffering loneliness, but now I am trying to help others. When I was around 16 years old, my family was falling apart, and that is when I was diagnosed with TB. I was told I would not be able to survive. With TB came extreme stigma. My neighbors found out and threw me out of my own locality. I had nowhere to go until I found a roof to live under with the help of Mother Teresa. Fighting TB was terrifying. In the sanatorium where they kept me, there were 18 of us in one room, and that is what surrounded us. People around us would keep dying, and we knew we could be next. But at the end of 2 years, I was one of the 2 people who survived. When I defeated TB, my entire life changed. I wanted to do so many things, yet I decided to do my education first. I played professional sports, cricket, hockey, football in Kolkata, Maidan First Division, and then decided to get back into working, and I joined corporate. For many years I worked in the corporate sector, but I never forgot the early years, the stigma, the suffering, and the possibility of death. So after my retirement, I came back and decided to work for street children in Kolkata. I had TB twice, acute COPD patient, and I am now cured of tuberculosis. Yet the stigma is very heavy with me, and wherever I go, people look at me with the stigma attached to it, and that hurts. While TB is curable, the stigma attached may not be. Many patients think that life after TB doesn't exist. My life was once supposed to end because of TB, and then again when I had a relapse of TB and lost an entire lung. But I fought it and I did recover. This is what I wish to do for the rest of my life. Help those children recover. Don't let TB be the end. It can be the beginning. I was provided with the opportunity to start a new life. TB isn't the end. A Notun Jibon awaits you.
Good afternoon, everybody. My name is Sandhya Krishnan, and I'm a TB survivor. Along with Deepthi Chavan, who is an MDR TB survivor, we're both SATB fellows, and we welcome you to this track of patient perspectives and high-quality care. Our topic for today is defining my care, why patient perspectives are imperative to achieve high-quality care. And for this, it is my honor and privilege to introduce today's panelists. First, we have Ms. Divya Sojan, who is a nursing officer at the All India Institute of Medical Sciences and is an MDR TB survivor. Her topic is on the on-ground reality of challenges in providing high-quality TB care in India. Following Divya is Ms. Ritu Khattar. Ritu is an MBA student and an SATB fellow and TB survivor. Her topic is a survivor's perspective on high-quality care. Next up, we have Mr. Gautam Yadav. Gautam is the research assistant at the Humsafar Trust, and he brings in a perspective from a completely different disease. His topic is overcoming barriers to high-quality care in HIV, lessons for TB. And finally, it's my honor to introduce Dr. Sanjeev Mehta. He's MD, FCCP, founder LIFE, Lung India Foundation, and the state chairman for the Maharashtra India Chest Society. His topic is enhancing TB care, options and opportunities. I am confident that together this will help us create a holistic and inclusive definition of really what high quality care and inclusive care definitions will mean in TB. Over to Divya.
Happy to be a part of the India TB Summit. Good afternoon, ladies and gentlemen. I am Divya Sojan, a nurse by profession. Today I am going to speak on the ground reality of challenges in providing high quality TB care in India. I have no conflict of interest to declare. I have worked as a nurse for 11 years and I have had TB thrice in this time. The third time I happened to get MDR TB, which is a more serious form of TB, where the general first line of medication for TB doesn't work. From day one of treatment, life became miserable in every sense. I took 22 tablets and 1 injection daily. I couldn't adjust to the drugs and dosage because of nausea, vomiting, and syncope. Doing duty and adherence to treatment was not at all possible. Eating was difficult. From 56 kg, I became 48 kg in a month's time. Thereby, I decided to go back home to Kerala and restart my treatment from Dot Center. After a lot of physical and mental trauma, I completed my treatment in last April. While I was on treatment though, there were countless times I felt that death was better than suffering like this. I'm joined by many TB patients who report feeling the same way. Why? Because TB is incurable? No. Because the quality of care they receive is such that it is difficult for them to continue with such treatment that is already lengthy and painful. I can vouch for the fact that my comparative experience of Delhi, where I did not receive quality care, and Kerala, where I did, that high quality TB care has an impact to reduce the patient's suffering and ability to continue and complete treatment, if not completely erase it. So why is it that patients across the board are not receiving a high quality care? Looking into this, let's go through some challenges in providing high quality TB care. This can be viewed from a systems perspective as well as from patient's perspective. First, from systems perspective, substandard quality of infrastructure. In India, there's a substandard quality of infrastructure in the public health sector like diagnostic centers and machines. And healthcare in the private sector is not affordable. Personnel shortage. The public health sector is particularly problematic because pay not commensurate with skills in low and middle income countries generally. So not many people consider it a lucrative option. Patients suffer on this shortage. In Delhi, when my MDR coordinator was on leave, I had to visit another day to get my medicines or for any other issues. They didn't have enough staff to substitute her to save a patient with the trouble of multiple trips. Knowledge and skilling are limited among health personnel. Working as a nurse, I have observed that sports pain patients are often either underdosed or overdosed with their treatment. We health personnel often forget to be empathetic. While this is understandable in given patient loads, we need to remember that even a tiny gesture or a kind word can actually change a patient's life. TB is stigmatized even by the health personnel. When I was admitted in 2014, there were personnels who were afraid to get into my room to check vitals. In 2019, multiple times I have gone through episodes where colleagues were reluctant to sit with me. Delivery of care is poorly organized in most of the states. What tests need to be done, where and whom to see after diagnosis, what papers need to be submitted was all a big task for me to start with the treatment. I had long waiting hours, especially when I was sick and alone in Delhi. Lack of accountability. I remember if I hadn't gone to the Dot Center for a few days in Delhi, there was not a proper follow-up. Now, from a patient's perspective, there are several changes in providing high quality TB care. Lack of awareness about the standard of care they are entitled to. The patient literacy is often low and they are made to feel like healthcare is a favor and not a right. So most are grateful to simply get a diagnosis and treatment, even if it comes with discrimination and disrespect. Patients need a holistic approach than just killing the bacteria. There is lack of patient support for side effect management, adherence, managing comorbidities, and nutrition. TB treatment can have adverse reactions that are painful and sometimes dangerous. A patient's mental health also suffers because of the treatment. They need support to manage their ideas, they need support to manage their mental health and socioeconomic limitations as well. Stigma attached to TB deters the patient from seeking and continuing care and also impacts their mental health. Lack of accountability to patients. Patients are often treated as passive recipients of charity in the form of care instead of being active stakeholders that health providers are answerable to. TB treatment often requires traveling long distances just to get diagnosed and demand a good amount of money for medicines and nutrition. All of this with loss of pay when sick is a huge burden to the patient and caretaker, especially if they are poor. So how do we address these challenges? Improving quality and infrastructure through engaging the private sector and leveraging their resources is the need of the hour. Kerala, since its inception, has prioritized for better health standards. Quality of care in the state is a fruit of almost 100 plus years of making health a priority. System for TB elimination in private sector helps patients to have free RNTCP medicine and diagnosis in the private sector too. Just the public health sector alone can't manage the disease TB. Multi-sectoral approach and accountability will add on to the skilled human resources and infrastructure. Health personnel need to be skilled just beyond the diagnosis and treatment in what high quality care is and how to provide it. Empowering patients with a person-centered approach enables patients to be afforded their right to quality care by giving due consideration to their values and needs while providing care. And giving them relevant information on the disease, treatment, and social support schemes will help the patient to adjust to the treatment without default. Skill building and reducing stigma among the healthcare team is the first step towards quality care. Sensitization with continuing medical education is the practical solution to provide knowledgeable and supportive care. Mutually developed care paradigms. I took 22 tablets daily and had several side effects. My coordinator in Kerala gave me different tips on how to tackle this as well as on many issues I came across, thus making me an active participant in my care and management. Providing patient support in a consistent manner at every step of care to help beyond diagnosis and treatment, especially for managing adverse drug events, is needed. Patients need to be informed of what events they should watch out for, how to deal with this, and when they require medical attention. An organized delivery system with multi-sectoral accountability. Right from the district TB officer, treating doctors, nurse, coordinator, health inspector, PHN, and ASHA worker were with me in Kerala to support my treatment as if it were their treatment, not just mine. Having multiple points of check ensured my treatment was delivered in an organized manner and that multiple people were accountable for ensuring I am supported through my treatment and complete my treatment. To end with, I would like to thank the whole organizing team for giving me this opportunity. High quality care is a right, and now let's make it a reality. Thank you.
Hi, my name is Ritu, and I work as a strategy and management consultant. I'm glad to be associated with India TB Summit. I have also been a TB survivor. I was 20 years old when I was diagnosed with tuberculosis, and that was in the year 2017. I was a working professional that time, so when this TB happened, it came as a big shock for me. My life just turned upside down. My identity changed from an independent working woman to a TB patient. For months, my universe got limited to the four walls of my room. The medicines also had a lot of side effects. I developed skin infection, developed thyroid, and gained massive weight. So this prolonged treatment with so many side effects took a toll on my mental health. But eventually, with the support of my parents and my family, I started to focus more on my positives. I also started preparing for CAT during the course of my treatment and eventually made it to a good B school. While it may seem that the life would have come back to normal when I joined a B school, but I was still on medication in my first year for one problem or the other. A lot of times life felt very different from my batchmates, but I was still happy with how far I had come. And yes, so eventually I graduated last year, and right now I'm working as a management and strategy consultant. So I think this 2-year journey of fighting TB and taking care of my career and my professional goals has made me much more stronger and confident than I was back in 2017. In terms of challenges that TB patients face, there are a couple of challenges that they face during their entire journey of the treatment. So I'll list out each of them step by step. The first one is very basic, lack of awareness about the symptoms of TB disease. There's a tendency to associate TB with cough, but that's not the case. There are several forms of TB, and that awareness has to be generated among the people. Second is on-time diagnosis and treatment. One of the reasons there's a mixed diagnosis is because first, patients are themselves not aware that they are having symptoms of the disease, and hence they approach the doctor late. And even if they reach the doctor on time, there's a lot of misdiagnosis. You will hear a lot of cases where patients were diagnosed with MDR TB quite late during the course of their treatment. The third is the stigma and social isolation. That's also a very big issue because people discriminate between a TB and a non-TB person. I remember when I shifted to a different city, while I was still on medication, but I was not infectious, I was finding it very difficult to find a flatmate. So yes, stigma and social isolation is also a very, very big issue. The fourth is the economic breakdown. While I did not face this issue, to be honest, I had a lot of financial support from my parents, but a vast majority of TB patients lose their job and they're not able to go back to their jobs because of TB. And last is lack of access to counselor and peer support network. one of the biggest, and I think this is the biggest problem that TB patients face, because there is just no anchor or reference point that they can look up to while they're going through the course of their treatment. In terms of what is high quality care and why it is needed, I think high quality care is a fundamental right of every TB patient. It has to be given. But what exactly is high quality care? It is very much dependent on the patient you're speaking about, because the social, economic, and cultural realities of every TB patient is very, very different. For example, a person who loses his job, for him, financial assistance and grants from government is also a part of TB care. But for women who face a lot of discrimination because of gender issues, for them, non-discrimination becomes a very important part of TB care. Now, in terms of what are the key aspects of high quality care, there are a couple of points. So I would like to highlight 6 main points. 1, it has to be accessible. Second, it has to be delivered in an efficient and timely manner. Third, it has to be affordable, because the treatment is for a very long period of time. The minimum could be 6 months and maximum could just go up to 3-4 years. So the treatment has to be affordable. Fourth, it has to be transparent. The patients should be made aware that these are the XYZ side effects of the medicines that you can face through the course of their treatment. I remember when I started developing skin infection, on the day those symptoms started to appear, I was screaming for straight 30 seconds because I just didn't know what was happening to me. So yes, I think the doctors have to be very much upfront that these are the diseases that you can face along the treatment, so that the patients are just mentally prepared to face them. Fifth, it has to be delivered in a very dignified, empathetic, and stigma-free manner. Yes, we are TB patients, we are suffering from a disease, but we are at the end of the day human beings who also have emotions. So please treat us with respect. And last, it should address the mental health of the patients. So there are a lot of side effects. People lose their job, there is discrimination, the treatment is very long. It definitely affects the mental health of the patient. So yes, this is also a very important aspect of high quality care. In terms of areas of opportunities basis, what is high quality care and what are the challenges that the patients face? One, I feel that there has to be definitely a creation of awareness about the symptoms of disease. As I said earlier, TB is just not about cough. There are several forms of TB. So there has to be a massive awareness drive about the symptoms of the disease. Second, there has to be patient education and information programs. Third, there has to be a massive R&D investment in new drugs that are safer and cheaper. Fourth, you also need to invest in systems so that there is minimum stock out of the medicines at the center or at the stores. Fifth, there has to be a peer and mental support network to support patients at their workplaces. And last, the stigma and social isolation has to be removed from the society so that TB patients can also live a dignified life. Yeah, so this is it from my side. Thank you.
Namaskar. First of all, I would like to thank India TB Summit to invite me for this conference. My name is Gautam Yadav. I'm working with the Humsafar Trust as research assistant. Today in my PPT, we are going to talk about overcoming barriers to high quality care in HIV, lessons for TB. Also, we are going to discuss about the stigma, discrimination, gaps in care, and misinformation. In my next slide, I would like to talk about the furthermore barriers to high quality care and care can include lack of sexual reproductive health and rights education, sexual orientation and gender identity issues, HIV prevention program education, condom uses and safe and positive sex practice, limited education in school and college, deep-seated stigma and discriminatory laws, discriminatory attitude of communities and the healthcare providers, gap between diagnosis and treatment, lack of counseling and other support services. Here I meant to say is that we are still struggling for the sexual reproductive health and right education People still don't know about the safe sex practices, condom uses, and how to live positively. And also, people are still struggling to reach out to people for counseling and other issues where they can discuss about the sexuality, gender or identity issues, sexual reproductive and health rights issues. We are still having discriminatory laws. Like, for example, there are countries where homosexuality is still illegal, and there are countries where the due to homosexuality, people even get death penalty. People are still hesitant to go to the healthcare providers due to their sexuality or their behavior, because they might get judged by the healthcare provider because they don't understand, or they try to make that this person is from this particular community, that's why this person is getting this disease or STI, STDs, TB or HIV. So people are still hesitant to go. There are several gaps in between diagnosis and treatment, because if I diagnose with something, it doesn't mean that I directly need to go on the treatment, because there's several things to cover between diagnosis and treatment. For example, pre-test counseling, post-test counseling, knowing about the adherence, knowing about the stigma, knowing about the other issues, why medicines is important, what are the side effects of the medicines. So these are the few things which is still people don't cover, or give patient the misunderstanding or misinformation, and because of lack of information, people face the challenges. As I said, there is lack of counseling support services because people don't get the proper counseling about the issue which they are dealing with. In my next slide, I would like to address the barriers and exclusion of TB care. Lesson from the HIV experience. Here, I would like to talk about the how we can learn from the HIV experiences. So my first point is take a person-centered approach to care. Create comprehensive awareness and access strategy, improve communication between healthcare provider and the patient, let communities define quality of care, create patient education, peer support strategy, community-based care, and build skill for health workforce. Focus on stigma reduction and mental health issues within health system, and positive stories and personal testimonies. In this slide, what I meant to say is, like, we should not worry, or we should not judge the person, which community the person belongs to, or what behavior the person involved. We should first focus on the diagnosis, counseling, and treatment, so that we give a better service to the person. We should also give the person better strategies to understand what disease it is, what he or she needs to understand about it, how they can work on the stigma, how they can work on the adherence, and how they can follow the adherence about the treatment, and what are the side effects, and full knowledge about the treatment. As I said there, we also need to improve the health communication between the healthcare provider and the patient, because there are several times we have seen that people want to complain about the healthcare provider or give them some feedback or suggestion, but they don't know where to go, whom to talk. So we really need to have a communication channel where people directly can talk or give their suggestion or complain to about the healthcare providers. And the communities, let the communities define the quality of care, because most of the time what happens is community is taking treatment, or community is involved with in the coming to the healthcare providers and taking the services and benefits. But when we make the policies, communities are not that much involved. So let the community define that what policies they need and how they want to work on that. Similarly, peer support is very important. If I am a person who is from the LGBT community, then if I have a peer support, or that person is also from the community, then I might feel free to talk to that person about the issue. So these community-based care and skills we need to work on, where we can involve the community members to help other community members related to the treatment or to the reach out of the people. Focus on stigma reduction and mental health issues. Because of the stigma and discrimination faced by the healthcare provider, we have oftenly seen that people stop their medicines or they don't visit to the healthcare providers. So if the community members are involved, we can reduce the mental health issues and we can motivate people for the treatment and adherence. Last but not the least, then we can share the positive stories and personal testimonies. For example, if I'm HIV positive and I'm telling to the people that I'm living with HIV since 2009, that make an impact on the person who recently diagnosed. That person will know that, if this person can live with HIV or with TB, or then they know how to live positively their life, and how they need to follow the treatment and other issues. In my next slide, I wanted to talk about the more lessons from the HIV experiences. Like if we see in the HIV treatment and healthcare providers, service providers, places, then we see the counseling is in place. Pre-test counseling, post-test counseling is very effective for the people to know about their treatment and follow their treatment. Then information, education, communication material is very important, that people should have printed copy or digital form of education, communication, information material where they can read or see the videos and learn about the issue. Active participation of affected and infected community members. People who are infected and affected, both the communities are important to actively participate in the healthcare providers in terms of community-based organizations or any kind of intervention. Then we need to pull the community to work towards the treatment, providing the treatment and the training purpose and sensitizations and all. Community-led and based interventions are very important. Like now it's high time we need to think about the community-led or community-based intervention, where people are getting the services within the community setup and people are getting the treatment and other support from the community within the community, so that they can freely come and access those treatment and other services. Focus on structural, economical, and social factor of the disease. It is also very important that when we are talking about focus on structural, economic, and social factor of the disease, here I meant to say that income, education, employment, and community safety, these are the few points which we need to keep in our mind to provide the better treatment and better service to the community, and put the individual at the center of the effort, so that people who are from the community and individually who is taking care and treatment from the center or from the healthcare provider, they share their experiences and they motivate other people as well to come and take their treatment ahead. So these are the few points which I wanted to share in my PPT. So thank you so much.
Hello, friends. I'd like to thank Sandhya and the organizers of this excellent program for inviting me to participate in anything as regards TB care in India. And I'm happy to help in any way that I can to enhance the care for our patients. India has a huge problem. Like the rest of the world, we are a hotspot for TB. And unfortunately, along with Southeast Asia, and I'm sure that is the theme of this meeting, is going to be discussed, the problem that we have faced all these years and we continue to face. But that's not the red part that I want you to see. I want you to see the green part. The green part is the Western world, which has managed to, I would say, conquer TB even before the advent of TB medication. So I was tasked by the organizers to try to bring the best practices from the Western world, where I've had much opportunity to study, and bring it to India and see how we can enhance the TB care. You will see in the course of this discussion that I have deviated quite a bit from that brief. I will yet bring what I think are some of the best global practices, not necessarily starting from the US and Western Europe, but let me walk you through that. So there is a strategy to stop TB. The World Health Organization and the WHO have made these exhaustive lists. Now, these lists are not new. Every person engaged in TB care, doctor or paramedic, or even NGOs, are all aware of what we need to do, give very high quality care, be engaged with people, but unfortunately, they stop short. The germ itself learns how to deal with our medication and our processes. And unfortunately, there are other challenges, such as socio-economic challenges. And now we have had the global pandemic. There has been the previous one being HIV. All of these have made the TB strategy implementation difficult. We continue to have a very high level of patients, and hopefully through meetings such as this and the government, we will come up with solutions that will overcome much of these problems, and hopefully we will eradicate TB. So I was tasked, as I told you, to bring in solutions with the best international practices to the country. And I would say that West may be the best, but for the significant part, it does not apply to India. And the reason is that the level of literacy in our country is very different from the level of literacy in the world. In fact, as I was talking a little while ago, I live in Mumbai, but I have a school which we are taking care of, and we do a lot of work in just 100 kilometers from Mumbai in Karjat. Then it's a different world. What applies in Mumbai does not apply to even a place so close to Mumbai, just 80 kilometers away. So what applies in the US and Europe definitely has very difficult applications in India, because medicines are the same. It's the delivery of medicines and the care and the comprehensive care of TB that is a big challenge. So I'm going to, as said, vocal for local or regional solutions. I'm going to discuss just a few of them. So these are the various strategies that have been discussed. And I'm not going to go into this busy slide, just tell you that most governments, most healthcare authorities have developed these complicated and, of course, excellent solutions that deal with TB in a very comprehensive manner. Right from the diagnosis to the delivery of care to reaching out to patients. And this has been extensively discussed, and I'm sure that's going to be discussed in this meeting too. But in spite of these fantastic programs, they don't always come up with the best solution. So what I thought I'm going to show is just two models which probably will have value. Again, for us, again, I'm saying that, in the rest of the world, say maybe in the US, the number of patients, and I gave a lecture in West Virginia, And a few years ago, the total number of patients they had of TB in West Virginia in that year was 4. Now, the strategy for 4 people, you can trace them, you can put them into into a hotel, you can do whatever you want, you can find whatever you like. You can educate them, you can do this. So for limited number of people who are very educated, where the resources are unlimited, those models just do not apply to India, where the number of TB patients, I think at one point in its time, it is said that nearly 1/3 of the population would have suffered from TB. So therefore, our challenges are different. I would like to focus very quickly on few of our Indian or regional challenges. So I like this Philippine model, which I hope I can share very quickly with you. So this is the innovation they've done. They have engaged the healthcare workers. I know we do the same, but you can see here in the regional language, calling them TB partners, having them better trained. I know we have well-trained people in Mumbai, but just out of major cities, the level of training may not be the same. So engaging with the healthcare workers, elevating them to the level of a partner will ensure delivery of care right to the last mile, to the patient's home. And unless we don't do that, we'll never get towards delivering high quality TB care in our country. So improving access with healthcare workers is also cheap, very effective. They speak the local language and know the people. They will follow them up. So I think very strong strengthening of the local healthcare worker is of utmost importance. I like this innovation where they have these people who move on motorcycles into the villages, and you can see any Indian village will have this bunch of motorcycles roaming around. Will even take a microscope, take simple tests, and of course you can deliver care from here too. So again, as I said, vocal for local, get the local people engaged, get them going, and not have the rest of the world or even Mumbai talk to the local people. We can engage with them, but don't talk down to them. This I thought was interesting, and having a TB club. I don't think I'm aware of too many TB clubs. I'm sure this NGO and some others will be doing it. But if we can take this at a national level, I think the level of awareness in regional languages will be great. But above all, removing stigma will probably be the most important thing. And finally, engaging local communities against TB. I think these few simple, cost-effective programs, the healthcare worker, the local auto rickshaw guy or the scooter fellow, the local TB club, and local local leaders will probably go a long way. Having done this, they were able to increase the cured percentage from 72 to 79. Remember, there's no extra expense involved, no extra manpower, just better training and better engagement, and you can improve the percentage cure. Another thing is the stigmas are much less. So people who think TB is a stigma, that number came down. And the people who think that TB patients should be treated as normal patients went from 30 to 70%. So clearly, this strategy works. And once people begin to get educated, engaged, they will take care of themselves. What about, and this happened only in the last 2 to 3 days when I would talk to Sandhya. And the thing is that, what about the Indian model? So we have a huge problem, right? And we all know about the TB problem. But we have a bigger challenge, and that was COVID. We've probably got some of the second largest or third largest number of COVID cases in the world. And I would dare say that we had the best response in the whole world. Honestly, we've had the least mortality of the entire world with one of the most weak healthcare systems in terms of per capita expense. Yet we beat COVID with the least amount of expense. So we were able to isolate our people. We were able to produce the maximum PPEs in the world. We were able to deliver the best healthcare. We have the least mortality. And we did it at the most reasonable price in the world. We now have a vaccine, and we have one of the best apps to deliver the vaccine to every Indian, and probably the fastest rollout. What lessons does this have for TB? And I would dare say, let's learn not from the rest of the world, let's learn from our own experience, which is COVID. So, bringing very quickly, and I'm going to wrap this up in a minute, if we were to take the same experience, the same educated healthcare team, and we would take these lessons from COVID and put it to TB, then this is the model that I think will have the maximum success. Let's isolate. And I dare say that once you have masked everybody, my own gut feeling is that TB will come down because the spitting is going to stop. The person who's going to spit, TB is going to be not easily able to spit, and the rest of us will be protected because we are masked. Universal masking probably should continue for the next 5 to 10 years to keep TB out, even if COVID goes away. Notification, and we've seen that how well we were able to notify COVID. We should be able to bring that same level of expertise to notification to TB. I think where there is a will, there is a way. And so far, this country has shown the will for COVID. If we show the same will for TB, we'll be successful. Let's do it on a war footing. We have the resources. We have now the protection. Let's do it. And we have the most reasonable cost of healthcare delivery in the world. So if we were to put all this together and we develop maybe a vaccine, and that's far away, if we use the best technology, that will help us. And we have the best. Bangalore is one of the best in the world. We have such a fantastic app for COVID. Maybe a similar app can be developed for TB. Then we can get better contact tracing, better treatment reminders, defaulters, caretakers can get engaged. And I'm sure then that if we were to bring everything together, we would be able to conquer TB much faster than we would have done otherwise. So in conclusion, we have a huge problem. We need to fight TB better. I think our solutions are going to be more suitable. Lessons from COVID, if applied to TB, may provide the answers that we are looking for. So let's not look outside. Let's look within, and hopefully we will deliver the best healthcare for TB, and we'll be able to eradicate TB. I'd like to thank you once again for inviting me to this extremely important and prestigious conference. I'd like to thank and congratulate the organizers. I'd like to thank Sandhya for engaging with me and the entire team. I wish you the very best, and I'm happy to participate in any way that I can. Thank you.
Thank you once again to Ms. Divya Sojan, Ms. Ritu Khattar, Mr. Gautam Yadav, and Dr. Sanjeev Mehta for your valuable inputs. What we're really looking at is trying to imagine a definition that is inclusive and references some of the highest qualities we can see from around the world. And I'm confident that our speakers have given us a voice, given us their perspectives that will lead us towards this very inclusive definition. Thank you to everybody who took the time to be with us today. And I hope that in the next iteration of TB Care Guidelines, we see some of these perspectives included. On behalf of my co-chair Deepti and myself, Sandhya, I thank you for your time.
Hello again, everybody. Thank you, Divya. Thank you, Ritu. We've had a few change of lineups in the last 3 minutes, besides change of outfits, clearly. But unfortunately, my co-chair, Deepthi, couldn't make it yet. She's still under the weather. Gautam has also taken ill and he can't join us. Dr. Mehta, thank you so much. He's in the COVID ward right now and can't join us for the live Q&A. And so between Deepthi, Ritu, and I, we're going to do our best to address any queries that come our way. There are questions coming in, but Divya and Ritu, one after the other, I'd actually love for you guys to share your TB story in terms of the quality of care that you received. What did you feel like what was the good that happened? Where did you guys struggle? Divya, would you like to go first? You're muted, so you'll have to unmute yourself.
Am I audible, ma'am?
Yes, you are.
Thank you so much for giving me the platform. It's a pleasure to share my story. Last I've been diagnosed with TB, sensitive TB, sensitive to drugs, all the drugs in 2012 when I was working in Mumbai. Then with 6 months treatment, I was fine and I was working back. Then I came back to I came to Delhi for my further education. Then 2014 when I was doing my masters, again I had pleural effusion, and it was drug sensitive. Then I was back with my education and joined AIMS as a nursing officer. Then in 2016, while I was I was at work, again I had this same pain, so I was again went through all investigations and I was diagnosed with rifampicin and isoniazid resistant TB. So that time the last story was a little tough, so much of investigations and 22 tablets plus one injection daily really took my life out of me. More than that, being a health professional, I had multiple episodes of depression, which I counted as something personal than counting it as a side effect of the drugs. It was a very bad time. I was alone in Delhi, so I had to go back home to Kerala, where I belong to. Then from there, I restarted the treatment. Actually, I couldn't manage with work, drugs, everything. So I took leave and I went back home to Kerala, where I had a very wonderful experience with the DOT center, the health system. It was all organized. I really felt it's their need to get me cured than I to be healthy. So they were just behind us like angels, right from the district TB officer till the ASHA worker who came having frequent visits at home to check whether I'm taking my tablets, how my health was. Everything was really fantastic. So about in 4 to 5 months, I was back to normal. I came back to Delhi because leave was an issue. Many other speakers said, COVID just in 2 years, we have a very nice protocol to manage it. But tuberculosis running all those centuries in the world, we don't have a protocol for how to take care of a patient or leave protocols, vaccination, drugs. All these are undershown actually, or undiscovered maybe. So I came back to Delhi, and again life was a little tough, being alone. But somehow, with the support of my colleagues and God's grace, completed treatment and back to work.
We're so happy to have you here with us. But Divya, you mentioned that the healthcare workers were very diligent in following up with your medication. With NACO, with AIDS, for example, they do ask about mental health and they do have support for depression, which is very prevalent, right? This is, in a sense, it's like a sentence that you get and it comes out of nowhere. Were you asked about how you were feeling emotionally, mentally, and when did that actually go away for you? When did you realize that you were struggling with depression, and how did it go? When did it go away for you?
Here, getting a diagnosis again of MDR TB was like, why this is not leaving me? It's always every year I used to have pneumonia in Delhi. So when I was diagnosed with MDR, it was like, it's gone. I'm not going to recover. from that point onwards, I was having a middle of depression stage. But when I went back home, even though I was amongst my family and friends, I had multiple episodes of crying spells. I used to cry without any reason. So everybody was like, why are you so sad? Then I also thought, why am I so sad? Why I'm not able to mingle? Even though I've studied psychiatry, I didn't realize or read about the drug side effects. I didn't realize that it's the side effects of the drugs. I looked into myself as I'm depressed. But of course, the TB dot center in Kerala, they do have frequent visits with the psychiatrist, and he used to ask, how are you feeling? Are you able to comply with the treatment? Which I lacked in Delhi. So,
well, yes, and I think for a lot of us in Mumbai as well, we didn't have access to any of this. Thank you, Divya, for sharing that story. Let's hear from Ritu as well. Ritu, what was your experience in terms of the quality of care, and what would you have liked done better for you personally?
Yeah, hi. Thanks, Sandhya, for having me. In terms of my experience, I think there are two things that I want to specifically point out, and this is something I pointed out in my presentation also. So, the TB starts from, being aware about the symptoms of the disease. The basic problem that I feel that there is not much campaign around TB right now in our country. People don't even know, okay, X, Y, Z are the symptoms of TB. And the same thing happened to me. For months I kept on suffering. And it was at a very later stage, I was diagnosed with tuberculosis. And that was also, it was when my mother insisted to get the tuberculosis test done. It was not the doctor or the healthcare professionals who told that I should get the TB test done. So I think that is a very, very basic problem, having late diagnosis. Second problem that I feel is that, patients are not made aware about the side effects of the medicines. It comes as a shock to them. When I started with the side effects of the disease, it was like a big shock for me. I'm just getting up in the morning and just see my, entire skin having rashes, acne all over, and I just started screaming because I just didn't know that it was going to happen to me. It just felt like a bad nightmare. For 10 minutes, I just kept on thinking that maybe this is a bad nightmare that I'm having. But no, but that was the reality. So I think these two things are very, very critical. First, making the patients aware about, the symptoms of the disease itself, and there has to be a very standard, mass campaigns around this. That these are the symptoms of TB. If you are having these symptoms, the way we are doing for COVID, right? There was so much of campaign, so much of information about regarding COVID. So the same has to happen for TB as well. And second, please be very, very transparent about the entire, journey of tackling TB. It's a long journey. Make the patient very much aware. You can have excellent side effects. So please be very, very mentally prepared. And also, third thing, we really need to talk about the mental effect of TB treatment on a patient. It's not easy, right? Every day you're getting up in the morning and starting your day with this. And it can just go on for years. Like, I was on treatment for 2 years, right from tackling TB and the side effects. And it's not easy. Life is not normal. Let's just accept this. So, having a network of, a healthcare professionals or, people who can give you guidance, who can tell you, okay, this is normal to happen, and they can provide you that mental support because, it's very important that the patients are supported emotionally during this journey. So, yeah, that's my experience. And I think if these three things were there, I would have had a far better journey as compared to what I had.
I can't agree more. When I was diagnosed with TB, this was before the big movie stars were even telling us about TB and how they'd had TB, right? So for me, it was similar in that I probably had it for 2 months. And before, like, it was my staff that pushed me to go to a GP, and the GP just gave me some generic pills and said it's a cough and it will pass. And this is after 2.5 months. And finally, actually, my doctor was Dr. Mehta, and it was a lot of tough love from him. But I will add one aspect, which is that partly I was so busy. I was just starting a business. I had 2 young kids, and you don't even know what to ask at that point. And I'll say it, you feel half dead, right? By the time you're at the doctor's door, at least in my case, I could barely put one foot in front of the other, let alone function in my everyday life. So you're not even sure quite what questions to ask. And I'll say this in Dr. Mehta's defense, I mean, most TB doctors work insanely long hours. I mean, he's there, he's at his clinic like 11 o'clock every day. And I know that several of the other doctors, including those on our panels, have been. So then it comes round to, and I think one of the speakers earlier mentioned that, who's going to be the best person to answer these questions. One of the things that we as SCTB, we do is to try and create that community where we offer peer support, but we really need, I remember I used to hound Dr. Mehta's compounder and say, भैया ये क्या हो रहा है, कुछ असर नहीं हो रहा है, and he just say, madam sab theek ho jayega, but he's really not the best person to give me any kind of advice in that front. I didn't know communities existed, and it was literally us having easy access to information. But I was quite heartened by Dr. Mehta's note of positivity, and I'll refer also to Gautam's comments about the affected and the infected. Very often the affected is not just us, the infected, right? It's our families, it's the people we work with. We don't know whether we should be telling our bosses or not. We don't know if the doctors are going to be informing who they're required to inform. So having some sort of control, just having some sort of information about how this information is communicated, I think would be so important. But who is going to do that, right? It can't possibly be the doctors because they're so overwhelmed. Then who are these bodies that we create? Are they going to be from the government? Are they going to be volunteer based? Are we going to create? Divya, do you have any thoughts on these?
Yeah, I too support it. When I was diagnosed with MDR, I didn't had any support in being at the hospital setup. There was a lot of stigma. Like my colleagues were like, they don't want to sit, or they used to walk out. How to take these 22 tablets, I didn't know. Being a health professional, it is easy to tell a patients, those who are taking injections or tablets, kha lena, ki din mein 3 baar. But having 22 tablets, 24 hours was literally was less for me to take, and I didn't know how to manage. So I really felt good when my MDR coordinator in Kerala, she told me how to manage. She had an experience from another patient who took those tablets, so she gave me how to take it. So those things were missing when I was taking my treatment. So actually I thought of making an in-house peer support group, something so that whoever is getting diagnosed has support from those who have already gone through those pathway. As you rightly said, doctors, and of course health professionals, being a health professional who may be having a spine TB, I can't be of any use. I can just say whatever books are telling, but that's not the real scenario. So those peer supports has to start from a small community. It could be, of course, NGO types, but it would be better if government is providing like educator, like in a hospital setup we have epilepsy educator, diabetes educator. All these educators are there. So somebody who has that basic education and who is a survivor is the best person. Every dot center would connect with people who are survivors, who are affected or who are infected. So, and would be able to convince those patients because they have already gone through those hard times.
Absolutely. Thank you for that. Ritu, sorry, go ahead, Divya. You wanted to say something else?
It should be from each dot center or a small community, local self-governing body.
Yeah.
It has to start from then. Only the change will be evident in the country.
Can't agree more, Divya. Thank you for that. Ritu, you and your survivor, advocacy. What are your experiences?
So I think I have similar thought to Divya. Every dot center should have, dedicated resources, who can guide the patients, who can tell them, that it's okay, this is just a journey for you guys, and ultimately you're going to defeat it. Because, even those 2 to 3 lines from somebody who is non-judgmental, I think that is very important. The person who is sitting has to be non-judgmental. If those kind of people even gives you 2 to 3 statements, I think it's very, very, powerful. And also, I think, again, let's say like, SATB is doing a lot of work, For me, one of the good things that happened was that when I started, doing Google search of TB communities, I could find 2 to 3 of them, and SATB was one of them. So when I Googled, I read the articles of the people who had written it. It gave me a lot of motivation, and I think that was for me a turning point. And I also, simultaneously, I also came across independent bloggers, who had also, told about their journeys on their blogs, on their Instagram posts. So I think these kind of things are also very, very powerful, because these are the people you can relate to. This person suffered in life and he recovered. He's great right now. I can also be the same. So, those people become a benchmark for you in life. And, I can literally name people from SATB, Deepti. I saw Deepti's videos on Satyamev Jayate, I don't know, multiple times. I used to watch, TEDx videos of Saurabh Rane. And I mean, multiple times when I watched them, I felt that, okay, even I can, defeat TB. And one day I will be like these people. And I think it worked for me. I mean, personally, it worked for me. So, yeah.
That's wonderful. I think what we don't realize is that although we live in such crowded cities, most of us, TB can be very, very lonely, a journey to walk through, right? Because there's so many things that you're told not to speak about, and nobody really, I mean, when you're 6 months, 9 months, 1 year, 1.5 years into your treatment, really everyone's expecting you to get over it and get on with your life. But you actually can't, and you yourself will keep wondering, right? How much longer? When am I ever going to start feeling better? I remember asking my doctor that, like, at some day when I wake up, I have to start feeling better soon, right? But that day just seems to never come. But just knowing that there are other people who've had this long before they've seen a turning point and have made it and have gone on to really thrive, but also really to see that life goes on. Question for both of you. Do you feel that, I know you did in Kerala at least get good quality of care, Divya, but do you feel that there was something that could have been done differently in how your care was handled that would have helped you move on better, embrace the sort of the depression and the confusion that you had even as a healthcare worker? Do you feel like if your case was handled differently, you would have had a different post-TB experience?
When I was diagnosed in Delhi, the first thing I asked was, I don't want injectables this time. So second time I was on streptomycin for 90 days. So the pulmonologist who was looking at me, he said, of course that guidelines have changed. So you can have it regimen without injectable. So when I went to the dot center, it was like they are following the old textbooks and he was referring all the pages. He couldn't understand what to start with. Then that time itself, I had that query, is he knowledgeable enough to give me the right treatment? Then again, he prescribed canamycin. Then I said, so sir told me I don't have to take injection. Then again, why am I taking? So the question there, from there it started. Then again, as Ritu rightly said, judgmental talks. Being a health professional, they were like, you should know about all this. Why are you not doing? Then starting with the first day itself, I had severe nausea and I had a syncope attack and I fall down in the ward. And it was all mess. I had to be in the ward for that night, and again I had to join back duty because leave was an issue. So then with the IV cannula, when I went back to the dot center to take canamycin, she was like, why are you having a cannula? कि ऐसा होते हैं, सब injection लेने की जरूरत नहीं है. And then if I'm not able to stand up, how am I going to deal with this? So these things were ignored actually here in Delhi.
And this is being a healthcare professional, right? Yes. So that you even knew that.
Or I'm not able to work. What I will do? And but I'm not able to go with it. So that was all this. I really don't know what to do. Okay, I'm not able to do, but others are not understand. Then I was alone also. So I thought it would be better if I'm back at home. So when I went back to Kerala, it was like each and every point I'm having nausea, vomiting. Okay, they prescribed the usual antiemetic. With that, I'm not able to control. They tried the second drug. Then every point of my even vision, basic investigations was not done here. When I went there, all the basic investigations was done again in Kerala, like ECG, eye testing, hearing, everything was tested, and then they started with the treatment. So when I started blurring of vision, I know, okay, something was going wrong. Then I again went back. They stopped stopped some drugs, and again, once it was back, then I again started with the drugs. Hearing also, it's difficult for a patient. Being health professional, I couldn't realize that my hearing was a little bit decreasing. Until and unless I used to ask again what you said or something, it will become a little worse to understand for me to understand I'm having hearing loss. So, but all these points were taken care with a frequent auditory testing and eye testing in Kerala, which I didn't even had when I came back to Delhi. So that was every point as a patient, I was being cared for like a baby. When I went to the dot center, okay, how are you feeling? Patient-centered care was there. Every aspect was being taken care of. Here it was like, कि दवाई खत्म हो गया, दवाई ले लो. Okay, एक हफ्ते के बाद आओ. Wait, there was not like, are you feeling okay? How are you feeling? Is there any side effects? All this was lacking in Delhi. So when we feel that we are being recognized or we are being taken care of, so patient feels good to go back, be compliant to the treatment. All those some are emotional points, but it really affects the treatment.
I think one of the things that we hear again and again from survivors is that, almost made to feel like we're a burden on the system, and that, we should be very grateful that we're getting this treatment at all. One of the things, I'll let Ritu speak, and then I'll just share some of my reflections as well. Ritu, did you have any experiences that you feel could have made your life after TB so much better, or help you come back into everyday life if your treatment and care had been handled differently?
Yeah. So I think I would want to emphasize on one point that I said earlier also, that if I was made aware about the side effects of TB medicines way earlier, and if I was told that this is completely normal, it would not have affected my self-confidence so much. I can't tell you, I mean, it's difficult, to even tell at this point of time, Sandhya, that how much embarrassed I used to be of myself, I mean, I used to hate looking myself into the mirror, for six straight months, I did not look into the mirror at all because I was just so embarrassed of myself. And I didn't know that this is common for TB patients, to have side effects like, skin infection or having an increase in weight because of multiple side effects that happen of medicine, like let's say, having thyroid. So if somebody would have told me, I mean, I would not have hit that rock bottom stage in my life. I did come back. I had a lot of support from my parents, my family, but it took me time, to get to this stage. It took me 2 years, to feel that, okay, life is back to normal. If somebody would have told me way earlier, I think I would have utilized those years maybe far better. But overall, I think, and I am also saying that I was lucky to get support from my parents who never made me feel that I'm a burden on them. Though deep inside, when I left my job, I used to feel that maybe, I'm a loser. Maybe, I did not put that much effort. I could have continued with my job by taking the treatment. Though I knew that it was impossible for me to do it, okay, because I was just not even in a position to even walk. As you, Sandhya, said, like I was half dead when I reached the doctor for my. I was half dead. So yeah, I mean, I had a lot of support from my parents. That was a good part. But again, from the healthcare perspective side, like from the healthcare professional side, if they would have made me aware about the side effects way much earlier, I think it would have turned out to be a better experience. So, and
Absolutely.
I just hope that, and even I just hope that people also start becoming non-judgmental towards TB patients. I mean, we are not patients. I mean, we are living human beings. We have a life. We are just suffering from a disease, but we are equal to them. So people also need to start having, non-judgmental attitude towards TB patients. So that is another aspect.
I hear you. I wish we had got them here because so much of the perspectives that he brings, we still are, educated people, and Divya as a health professional, we're able to ask questions about doctors. Although I have to say, I was intimidated myself, and or just didn't have the mind space, right? Mine was not even working fully at that time, but. The perspective and the feeling of judgment for people who are otherwise disadvantaged, sex workers, you have people of other genders, trans people, people who have comorbidities who are also struggling with HIV and then get TB, the way the healthcare system, just to be sensitized, right? To say that one of the things I always felt was that if people would just see that TB is a result of the system having failed us, not something that we went and voluntarily did to ourselves, and it really it's like society owes us to look after us. The system failed, and that's why we are here, and that's why we're struggling. So if that perspective and those sort of conversations were to happen more publicly, I think it could make a huge difference. In my case personally, as something as simple as if in the first at least 1 month of coughing, if I'd actually got diagnosed with TB rather than just being given some antibiotics and not even told to come back or anything like that, and this is after 1.5 months of coughing, right? I wouldn't have been diagnosed like 2.5 months later. So there is that sort of anger. I don't hold it against anybody. I take responsibility eventually for my own health, but I could see that when you're so busy, life goes on. These are not even the things that your brain doesn't even realize that this is salient or it needs to pay attention to these facts. And even with continued TB care, very often you're just struggling to just keep yourself alive. Then who's going to think about, have I eaten my 3 square meals a day? Have I got all my macronutrients in? These are distant conversations for many of us. And like you said, Ritu, something like even skin changes and stuff, they can definitely affect our self-esteem. They can affect how we perceive ourselves, but also in several communities, this can be huge in terms of marriage prospects, and some communities can be very, very focused about the surface and the stigma of having contracted TB and being a survivor as well. These are conversations, and again, Gautam's not here, but the conversations around sexual health, and there are wives or I'm sure works both ways, but when can I start having sex again? And there are demands on me, and can I have healthy children? All of these are conversations that we need to have far more openly, because it's a question that every single person that suffers from TB will have in one way or the other. So like Divya said, if we had all of these down ready, or if we had somebody to just answer them, and it comes from a peer group, like you said as well, Ritu. And that's what I think one of the things that we as SATB hope to do. And there are several other groups in the country working as well towards this. I think that brings us to the end of our time here. I want to thank Divya and Ritu, both of you, so much. Also, a big, big thank you to Dr. Mehta and to Gautam Yadav and my co-chair, Deepti Chavan. Deepti's been a vocal advocate as well for TB survivors for several years. I'm deeply saddened that she couldn't be here today, but she's very much here in spirit. And I hope that this is just the beginning. I'm hopeful also, and I think Dr. Mehta's message ended in one of optimism, that we really are getting a lot of things right. And I feel like if India has leapfrogged like the entire telephone system and went mobile overnight, we can also leapfrog and get lessons from COVID and transform TB care from a patient's perspective. And for that, I call on each and every survivor to tell their story loud and clear, make their demands heard, so that nobody else that's struggling right now and doesn't have a voice will have to go through what we went through just because the other side hasn't heard us loudly enough. So with that, thank you to everybody. Thank you to Pi Consulting and Indian Express, and to each and every one of my panelists, and to my co-chair, and to the audience that joined us here today. Have a wonderful day. Thank you.
Thank you.
Thank you. Bye-bye.
Hi everyone, my name is Andrew Cross, CEO and co-founder of Everwell Health Solutions, a company focused on digital innovations to support public health. I'll be pitching some work we've been focused on to support people undergoing treatment to receive the best care and support while taking medication using technology-supported methods. But first, let's set some context. Even when a person is correctly diagnosed with tuberculosis or TB, and has access to effective medication, there are still challenges that might prevent them from recovery. Strong adherence to their medication regime is a critical determinant of their recovery. Research has shown that people who achieve less than 90% adherence are far more likely to have an unfavorable outcome than those with 100% adherence, and that adherence was the single most potent factor associated with unfavorable treatment outcomes. To address this challenge, 3 innovations have been developed and deployed to support adherence and connect providers with people undergoing treatment through technology called 99 Dots, Video Observed Therapy, and EveryMed devices. These technologies, collectively called Digital Adherence Technologies, or DATs, have been developed to support people undergoing treatment through a combination of reminders and engagement during treatment, allowing healthcare workers to understand a person's adherence in real time and effectively reach out to people undergoing treatment with additional counseling and support. The WHO has approved the use of these technologies, and experience reports in several cases showed high acceptance by users. However, other studies also showed that no individual technology is appropriate for all people. So how do programs choose between these technologies? How can they provide access to all 3 DATs, promote choice between them, and remove the unnecessary burden of training staff on multiple platforms with duplicate entries for people? As one of the original innovators in the adherence space, our team at Everwell, in collaboration with fellow innovators shared here in Weispill, have developed a single integrated platform that allows programs and people undergoing treatment access to all 3 technologies on a single platform. This integrated digital adherence platform is deployed as part of our own source tool called the Everwell Hub, which has been deployed in over 15 countries for all 3 digital adherence technologies and reached over 300,000 users for adherence. A program or implementing partner can work with Everwell to set up the hub for their context and provide a combination of any of the 3 DATs. Everwell works in collaboration with national TB programs, health ministries, and other government partners to make DATs part of their national strategic plan to ensure appropriateness of the solution, support for scale-up, and a plan for sustainability. People undergoing treatment can opt for any of the 3 DATs based on their personal choices around usability and privacy and their access to mobile phones. Providers and programs can suggest a technology based on which may be more appropriate for that person, if any at all. During treatment, a person can switch technologies if they struggle with their original choice. Throughout, all adherence signals are aggregated in a uniform adherence calendar for providers to review and react to with additional counseling, just as they could with individual technologies. The integrated digital adherence module has been deployed to date in 3 settings for more than 1 DAT and in all 12 settings for additional DATs, and is being rolled out in several more countries via the Unitate-funded Ascent project. Nearly 10,000 patients across these settings have so far used the integrated adherence module, a number which is growing every day. The integrated digital adherence platform has also been contextualized for HIV support, mental health, and leprosy, with early deployment soon to be underway. So how can you get started? To get started, anyone can reach out to us at Everwell to set up a demo or share more about the integrated digital adherence module. We're actively working with funders, implementing partners, and governments to roll out better tools to empower people undergoing treatment and providers to support them. For more information on Everwell, digital adherence technologies, or how we partner with governments, hospitals, and implementing partners, please check out everwell.org for more information. Thanks.
Chapal, I think you're on mute.
Good evening, and I'm sorry for being on mute. I wish a day of conferencing, and this is what you come to. But welcome everyone who's joined us in the expert session. I'm with Dr. Burnali Datta, a leading TB specialist from Medina Medicity, and Dr. Lance Pinto, also a leading specialist from Hinduja Hospital. This session has been drawn up basically to discuss some of the concerns, issues, clarifications, and questions that many people from the media have had as they were reporting around tuberculosis and other associated comorbidities. I think one of the key things here is that what we do want to do through this session is to give you the opportunity to ask questions. Some of you have already sent us questions. Unable to attend because this is the time for reports being filed in newspapers and in online magazines. But you have also reached out to us with several questions around TB COVID, research, innovation, and many others. So I'm hoping today with Burnali and with Lance, we can resolve some of these queries for you. Please remember these are intended to help you report better and possibly bring more clarity to concerns that you may have and clarifications they may have. This is not necessarily all scientific evidence because that takes a little bit more time. And the doctors here are speaking to respond to your questions. They're not necessarily quoting evidence at every point in time, although I'm sure knowing both of them, they will cite evidence as and when a relevant question comes up. So without further ado, let me welcome both the doctors. As you can see, they're sitting in their hospitals. These are busy times, and they both run COVID wards. So they're super busy times for both of them. So I'm going to just jump in and start asking these questions. One of the questions that has come up to us from a young journalist is actually around what is the impact of COVID on TB, and this is a theme that is reappearing since morning all day. So I'm also asking both of you because you're best suited, because one of you is in a city which is seeing a second or a third wave, depending on how you categorize it, and one of you is herself a COVID survivor, and you have been involved in this. So, Burnali, let me ask you this question. How badly or in what way has COVID impacted TB in India?
Yeah, I think that's sort of, a very pertinent question. And that's what I guess the entire summit is about. TB, we had huge goals and targets of elimination by 2025. And then 1 year has just gone from under our, so we, a lot of catch up to be done. So I think we have been affected at numerous levels. One is that in the wake of a pandemic, all diseases go underground. And TB has been no different. We saw a drastic drop in case notifications. So the patients were just not presenting, not coming. And then, obviously, the disease is going nowhere. So the patients are just sitting at home getting sicker and probably spreading it within their community, within their households. So that's one way that the disease has just got much more deep-seated, deep-rooted in this 1 year that we've not been able to sort of deal with it. Fortunately, things have taken a turn, and I think people have started. I mean, our hospital is now overrun with non-COVID, with every other illness as well. So at least we are able to get some of our momentum back. So that is the first sort of in a notification sense. In the clinical sense, in a clinical sense, of course, damaged lungs, destroyed lungs, they do form one of the problems of severe disease, and TB does cause a significant amount of lung damage. The other problem that we all encounter, and I'm sure Dr. Lance will also agree with that, we do use quite high doses of steroids and other immunosuppressants during treatment of acute COVID. And at that point, that is all we have, because these drugs are life-saving, lung-saving at that point. And we hit patients hard with it because we want to pull them out. But then all of us are now expecting that in the long run, patients who have been on steroids, protracted courses of steroids, may well come back with a reactivation of their latent TB and problems like that. So I think we may face these different aspects.
Lance, if I can ask you to respond to this, because you are in a way back in the thick of it, aren't you? TB and COVID. It's kind of crazy.
Unfortunately, that's the reality. So I completely agree with Bernali. And, again, talking anecdotally in terms of the patients that I have seen who've now come with TB, newly diagnosed patients, I get a feeling that they're getting diagnosed at a slightly more advanced stage of the disease than they would have got diagnosed about a year back. So I've seen some patients who come with bilateral disseminated TB now, young individuals from relatively better socioeconomic strata as well, who've been so petrified of interacting with the healthcare system, who've just remained cooped in at home while their disease got worse, and are now presenting saying that, oh, we've been coughing since 4 months, so we've lost about 5 or 6 kilos over the past 4 months. So I think we're seeing more advanced TB compared to what it was before. And, the corollary to that, or the consequence of that, is definitely going to be greater spread. Within most of these individuals were indoors, were locked in, and continue to cough for 3 or 4 months, and therefore the probability of spread is going to be higher. In terms of patients with TB who already were on treatment, I think we managed it reasonably well. We switched over to teleconsults here. A lot of our patients continued consulting us over teleconsults, but I'm sure those must have been challenges, especially in rural areas as well. Drug supplies, again, I can potentially assume that we had a lot of drug supply problems for a lot of other diseases, including asthma, including COPD. There were shortage of drugs. So I suspect that must have happened with TB as well. But these are statistics that we don't really know. This huge migrant, the huge migrant population which went back to their hometowns, for example, a lot of them possibly were receiving treatment from their local DOT centers here in Mumbai or here in the cities. And I'm not really sure whether they've been tracked adequately, whether we know what happened to them, whether they continue to receive their medications. So I suspect that we could see a huge resurgence of TB in the near future. I hope I'm wrong, but I suspect that would be optimistic to hope that that's not going to happen.
I think that's a very realistic assessment, and thank you both for doing that, because I think we don't know, but we have to be prepared. And I think to inform reporting, this is a critical thing to remember, that watch out for the data, watch out for the numbers that come out, because I think in the next few months and years, we will come to know how far this damage has been. I think there's no doubt that there is damage. The other question that has come to us is, of course, not related to TB COVID, but it's totally related to resistance. And the question that is being asked by another journalist is talking about resistance. What kind of resistance pattern are we seeing in India? And how should we be prepared in terms of diagnosis and treatment? I think this is a broader question about how we we do not sufficiently understand resistance, not only in the public discourse and in reporting, but generally, right? Doctors understand it, but people don't understand what even resistance is from. So, Bernali, if I can get you to weigh in on that a little bit, and then I go to Lance.
Sure. I agree that drug-resistant TB is a completely different entity. Drug-sensitive TB, if the patient is compliant and you give the correct treatment for the correct duration, the vast majority will recover, and it is a fully treatable, curable disease. The minute they come with drug resistance, you get a bit worried, because we start with, single drug. Is it only one drug resistant? Is it multi-drug resistant? Is it all drug resistant? So these are the various sort of, the entire spectrum that we've been seeing, and we've been seeing more of it, and we've been seeing a lot in younger patients. So it's a very worrying trend. And, considering we are wanting to eliminate TB in the next 4 years, with this kind of drug resistance increasing, this is almost like a Herculean task to actually achieve that. Now, the largest number of drug-resistant cases in those who have been treated. So which means that it's been a failure of some sort of treatment completion or compliance, or not having or not knowing from the outset was what the drug-resistant sensitivity pattern was. So that is the commonest. Primary drug resistance is not as much. That is a lesser percentage. Now, of course, monoresistance with isoniazid is probably the highest that we see. That is the most prevalent. And then we come to what's called MDR, multi-drug resistant, which implies rifampicin and isoniazid both. And then as you go further to pre-XDR, XDR, then those are very, very difficult situations, because even your second line medication are now getting, used up by resistant, sort of getting involved in the resistant pattern. So the first thing is that I think the first thing to say is that proper treatment of drug-sensitive TB is vital to preventing the emergence of drug resistance. And I think that remains the key, that we find, diagnose, treat properly as many TB patients as we can who are there, and that will just quell that number of DRTB cases which are on the rise. I think we are quite good with diagnostics in the sense of having widely available gene expert facilities, molecular diagnostic facilities. I think that is pretty good. And I see that, every district will have a gene expert machine. And now if we try, if we once start getting the XDR, the, wider range of second line as well, then I think that will also be a big advantage. Culture is desperately short. Like in the whole state of Haryana, we have, in the government sector, we have one in Rohtak, one in Karnal. So culture is again quite a vital part of diagnosing drug resistance. And if culture is so short, then how are we ever going to confirm? And so I think just a couple of things before I hand over to Lance. One is that microbiological confirmation and diagnosis is vital. I think that is, that has to be there. The empiric treatment and all simply does not. I mean, extrapulmonary TB, maybe, sometimes we don't have a choice, but in pulmonary TB, we just must have microbiological confirmation and sensitivity pattern. And I think that is vital before we start the treatment. And that way we can sort of, at the outset know who is going to respond to what, and not rather than putting empiric first line for 6 months and then change it, and things like that kind of haphazard behavior has to change. And I think we have to get very, very focused on dealing with drug-resistant TB as a real threat, and and giving it quite sort of properly and intense.
Yeah, just to add to that, if you look at the statistics in Mumbai, this was a reasonable time ago, where close to a quarter of all patients with tuberculosis in Mumbai have drug-resistant TB, and this is MDR TB. So it's not a trivial problem anymore, and it's not a safe assumption to assume once upon a time when a patient came, you would start them on first line. You would do what we used to call empiric treatment. If they didn't respond, then you would go down the pathway of trying to figure it out. I don't think that's safe anymore, when a quarter of all patients tend to have drug-resistant TB. Our study from Hinduja, where we looked at our samples, suggested an even more disturbing pattern, that a significant proportion of these individuals who have MDR TB are also resistant to quinolones. So fluoroquinolones form the backbone of a prescription for those who have MDR TB, and about 70% of our population, at least the samples that we receive, tend to be resistant to fluoroquinolones as well, which again, pushes for this dire need for drugs like bedaquiline, greater, easier access to those drugs, because it isn't as simple as it used to be. Even if it's MDR, it's seldom pure MDR in the truest sense of the word. So it's usually pre-XDR or XDR TB that we're facing. And outcomes all over the world in the best of centers, once you have MDR or XDR TB, your probability of survival is about 60 to 70%. So a good third of these individuals tend to not make it. So I think we really need to pull up our socks and try and offer these people rapid diagnostics and a quick empiric drug-resistant regime which is tailored to their needs.
Thank you both. I think that's very useful. I think a connected question is a slightly provocative one, which I think only a journalist could ask, which is to say, how reliable are the COVID-19 numbers in India? And for that matter, how reliable are the DRTB figures in India? What is the real data? I mean, well, I just want to clarify this, that these are doctors, they are not data crunchers, and they do not have access to health information systems so they can only make opinion. They can only give an opinion on it. They cannot offer you data. Just to clarify that before. Yeah. Please, Burnani, if you want to say something on that.
Yeah, no, absolutely. I think it's a valid question. Now, the difficulty with a country like India, which we all understand, is that it's just vast. And 75% of the population are in the rural areas, and the rest are in the urban. And if anybody's visited rural areas, you'll know that the distances are tremendous, access, nothing. It's like another country. It's like another sort of something stuck in a time warp kind of a thing, where they don't have access to very basic stuff. And maybe things have got better with mobile technology and things like that, but not enough. So I think definitely we measure, under-report, underestimate almost everything. In COVID-19, however, there's something to be said that I don't think it did actually permeate through to the rural areas to that extent. Probably, very less. It didn't, and we were fortunate that way, that it was in the urban cities and all the densely populated metros and the tier B cities and things like that, and never really made it to the rural areas, because that may have been, again, numbers and all. At some point, we just tailed off. So that is one aspect of it. So the rural, I think we definitely undermeasure it. The other thing to point out is that, when we went into from mid-December, when the numbers in India completely plateaued and we just kept going down, 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 and nobody was sure why. And of course, we've surged back again, as Lance has been, saying in Mumbai especially, and even here we are seeing like a small peak now building up. But the feeling was that maybe everybody's just developed, maybe they've developed herd immunity, although there is no grounds for believing that. But the feeling was that how can we explain that the disease is dying out, or has sort of the peak has completely plateaued? How do we explain that without somehow saying that, look, in some way we have developed herd immunity without knowing? The people didn't even know that they had got infected. So that kind of a thing. So if you say that, then obviously we're grossly, under sort of reporting, under picking up. We're not able to, diagnose those patients who just sat at home, got mild or asymptomatic disease and just got better. And I think by the same token, DRTB, yes, I think there is a lot of data. I mean, unfortunately, I wouldn't be able to share the exact numbers, but I think there are many who will not get diagnosed, many who will get diagnosed and then fall off the, they'll just never, come back for treatment, and those who will start the treatment but not complete it. So at every level we have, the sort of cascade, we have losses of numbers. So I think our data, certainly we could do with far better systems of, health information systems that would then give us a really true picture of what is the reality, what is actually the numbers, and then we could maybe, our funds could then be channelized in the right way. To you, Lance.
Right. So I completely, there is no doubt about the fact that the numbers are underreported. And I don't think that necessarily means that the numbers are fudged, right? Underreporting does not mean that the numbers are being cooked in some way. The fact that underreporting is happening is clearly evident from the seroprevalence data. If you look at the seroprevalence data for COVID, it's way more than the number of cases. But again, if these individuals had a milder form of the disease and did not need to get hospitalized, that's reassuring in some ways. Okay, a lot of people did get infected. We underreported it. What is a bigger concern is the mortality data underreported, because that's where we really want to know what's happening to individuals. And I think that there are some indicators which have looked at comparisons between all-cause mortality between the previous year and the current year. There are a few limited studies, I think, which are coming out, which do suggest that, all-cause mortality probably increased in the past year, despite the fact that road traffic accidents fell down, despite the fact that a lot of other pollution-related causes fell down probably. And that, again, may not be a reflection of the data being fudged. It maybe people didn't get tested in time. People just, were so scared of approaching the healthcare system that they came in too late and they passed away, unfortunately, even before they could get a diagnosis. When it comes to TB, I think, again, the notification of TB is fantastic now. I think the notification rates have increased significantly. But at the end of the day, you're still relying on A, the patient seeking help when they have a cough or they have a fever for a long time, and B, you're relying on the healthcare provider immediately asking for the right tests. So the numbers could be misrepresented, not just because of the fact that somebody's trying to hide them, but the fact that people are not thinking TB enough and people are not testing TB enough.
Thanks a lot. I'm going to, I've been told by my team that we are getting a lot of live questions, so I'm going to ask a couple of live questions as well. This is by Radhesham Jadhav, who's a very well-known journalist. He's saying, what are your views on the coverage of TB in the mainstream media? What are the concerns when it comes to mind for information dissemination? I think this is basically asking about the role of the media. So what are your views, Bonali, if I can get you to touch on that, and I'll get Lance to handle the second part of the question.
Sure. So, if you look at India, so obviously I don't think we have any lack of knowledge of the disease TB. I think we understand it. It's a difficult disease. It's been there for centuries, but it's been sort of understood, analyzed scientifically very well. There is good treatment for it. There is excellent diagnostics for it. So I don't think that, and of course, so the health, that scientific health is not a problem anymore. I think the biggest problem is the awareness of people, the understanding of people about the disease as such. And I think that social component is the biggest hindrance we will face when we actually try to, eliminate the disease. And I remember there was somebody, a WHO representative in Haryana said, they are expecting the health department to end the epidemic of TB, and he was sort of being sarcastic. And I understand that, because the health aspect is a small aspect. The socio-economic, cultural barriers are always going to be far more problematic. And I think, and I think people's sort of knowledge, awareness, understanding of TB is still so skewed, they have such a, it's misrepresented so much that I think media could play a vital role in, actually, demystifying, debunking myths, and actually getting it out there that, look, this is a perfectly treatable, curable infection. Just take the treatment, don't go into hiding, don't be in denial, don't do all the, don't default, don't do the things that you do. So I think media could play a fantastic role in this, because really, I think scientifically we are pretty sorted. We have all the technology that we need, we have the medications we need. And of course, that has to be, again, the government has to make it more widely available and things like that. That's a different matter. But I think just that awareness thing would help a lot. And I think government have done, with Mr. Bachchan and things like that. Obviously, people are more aware, but I think, just conventional media, social media, if this would just go out there the way polio has, why polio? Look at COVID. Everybody knew everything there was to know about COVID. I mean, I'd struggle with my patients because they would be telling me things that I didn't know about, because they had read the latest news from Europe or whatever. So I'm just saying that, so you can see what is possible. With media, what can be possible? So why can't we do that with TB? Just because TB sort of just been there for hundreds of years, it's just gone into cold storage. But if we could sort of do that kind of a media awareness for TB, I think that would work fantastically.
So I have to agree, in the sense, look at what's just within 1 year, people are asking you things like, what is my CT value? Does this mean anything on this smear? People are asking you, oh, my CORAD score is 4. What does that mean? People know how to read oximeters now. People are debating Covishield versus Covaxin. I mean, look at the level of rhetoric within a span of 1 year. And the media has played a fantastic job in that. The media has shown both sides of the story, has shown different ways in which it could be analyzed. Why is it that nobody knows what a gene expert machine is? Why is it that nobody knows the full form of MDR-TB? What does it really mean? I mean, surely the media can play a much stronger role, and I think we can make a huge difference.
I've been told to keep my questions short because we have very little time, but there are a couple of questions who have come in. One is about the vaccine, which I think is very critical, where somebody's asked, we got a COVID vaccine very quickly and TB still lacks one. Are we short of science? Are we short of data? Are we short of political will? Are we short of funding? What are we really short of? Or are we short of all of them in a sense? So Burnali, if you could briefly touch on that.
Yeah, so a valid question, but a difficult one nonetheless to, really address. I mean, these are different diseases. And although in both, we are ultimately trying to, use our immune system to tackle the virus or the mycobacteria, but they are different. And with TB, the way TB behaves is that, like in India, for example, 40% of us have have latent TB infection. We have the mycobacteria within us, but it stays in control with the help of our immune system. So it's like an interplay between the mycobacteria and the immunity. So if your immunity is reasonably good, it will keep it under control. If your immunity dips, then it can sort of manifest itself. So that is how the TB thing works. Now, TB vaccine, it's difficult. We had BCG, which of course doesn't do anything at all for us, maybe children, but yeah, that's of no use. Then we do have the GSK vaccine, which is I think now phase 3 trials, and maybe something will come of it, maybe 50%. It does provide 50%, I think, efficacy from preventing. So that may help. So I think there has been a lot of effort that has gone into TB as well, but certainly nothing to the tune of what has gone into COVID. I mean, because I think it's unheard of to have a vaccine developed within a year, and all backed by science. They are not. I mean, we understand that they've undergone phase 3 trials. They've thought of new methodologies, the mRNA vaccines. I mean, earlier we only had live attenuated or inactivated. There was nothing else. And now we have a vector-borne vaccine, we have mRNA, and so many sort of different types that we all have. So there is no doubt that that a huge amount of effort and science has gone behind this. But this was a pandemic. This was a pandemic and a pandemic can, wipe out the world, maybe not the world, but a large amount. So I think that kind of response was necessary. Now, TB is much more indolent. It's been there for centuries. And while it may be as threatening, as bad as, COVID, but in a much more slower, spread out. So that it has never received that extent. But I think it's also difficult. I don't think there has not been studies into developing it. I think it has genuinely been difficult to develop a vaccine against TB because of the way the disease behaves. It's just a different behavior, whereas viruses typically will lend themselves far better to a effective vaccine. Over to you, Lance.
Let me ask you this, Lance, because I think we are short of time. There is a very specific question that has come up, which is, what is your view of the BPAL regimen? And I think this is a lot of debate around that currently. And what impact do you think it will have on the length of treatment and the patient experience? I think a journalist has asked this, and I wanted to bring this up to you because I think this directly relates to the conference about rethinking and reimagining TB care. So
I think there's a lot of optimism to be had with the BPAL regimen. The fact that it's going to be a really short, I mean, they're hoping to be the next trial suggests that it could be a really short regimen. Most of my patients who have MDR TB, because of the fact that they also are MDR plus, we in any case try to procure bedaquiline for them. Most of them are already on linezolid and they're on ethionamide, so protonamide would be a similar analog. The only concern, of course, is linezolid. A lot of our patients develop sensory neuropathies, and the next iteration of the class of drugs tends to be better in terms of peripheral neuropathy. So hopefully there'll be an even better regimen further down the road. But I think shortening the length of treatment is going to be a big step forward. Just the fact that you sterilize quickly, you don't expose people to the ill effects, you get rid of clofazimine, that will be great. So all this skin darkening, pigmentation, all these issues that come along with that would hopefully be taken care of. So I think there's a lot of optimism to be had. So, let's hope they quickly do trials in India as well and we can move forward.
I've been asked to ask a question to actually both of you, which probably will end up and that is that what are the two areas that you think in TB that we should be investing in, very briefly?
Yeah, so I think I go back to that same thing, that I think we have enough vis-a-vis the science of the scientific of diagnosis, treatment, etc. But I think it would be wonderful to, first of all, increasing awareness, and second is we need some mechanism for adherence and treatment completion. Just assigning an ASHA and saying, look, please make sure that this person, or whatever, in cities it'll be different, but I'm just saying we need a far more robust way to ensure that the treatment is adhered to and completed. Otherwise, we'll never be able to win this battle.
Right. So the two things would be to help patients come to the system. So that would be a function of education. That would be a function of being sensitized. Just as people know, I have a sore throat, I have a little bit of a fever, get a COVID swab done. I think that's the level of awareness we need to create, destigmatize it. So people realize, okay, this must be tuberculosis. Let me go and check myself. So bring people to the system. I think that's the number one thing. And number two, support them through it. So whether it's nutrition, whether it's control of their diabetes, have a holistic approach so you can support people through their journey with TB. And I think Survivors Against TB is doing a great job in raising that kind of awareness as well. And I think both these things go hand in hand.
I want to thank you both and also our audience for asking us these questions and sending them to us beforehand. Thank you both. You're both in busy OPDs, and I'm glad you were able to make time. Thank you, and thank you again. And we'll see you all tomorrow. Thank you. Take care.
Thanks, Thanks, Pranali. Bye-bye.
Bye. See you.